Good morning, everyone. I'm glad to be here. My name is Neil Christopher Apellis, and I'm the Chief Nursing Officer at Providence Sacred Heart Medical Center and Children's Hospital. So I'd like to welcome everyone in person here. We have almost 100 attendees in person that are registered, and then I know that online we have about 100 people registered online too. So even bigger group than we've had last year. So welcome to everyone. So a little bit about your host, the people that are hosting you today, which is my hospital, Sacred Heart Medical Center and Children's Hospital. For those of you that aren't familiar with the hospital, we are just located right up the hill here. So if you come out and you look up, you'll see our medical center up there on campus. We're a 691 bed hospital, tertiary hospital, and we serve as a referral center, as many of you know, for all of our surrounding areas, eastern, central Washington, parts of Idaho, even parts of Montana. We do have a children's hospital within a hospital, and so we are a level 2 trauma center for both adults and pediatrics. We are a Joint Commission certified stroke center, and we also are certified by Joint Commission for ventricular assist devices. We do operate transplant centers, so we have a cardiac heart transplant program, as well as a kidney and pancreas transplant programs. And then, of course, the full cadre of services, our emergency departments, adult, pediatric, and psychiatric ED. We do carry a pretty heavy load with our psych ED. We've got about almost 30 beds for psych ED, and then inpatient adult psychiatric care as well. And like I said, pretty much a full service hospital operating here in Spokane. So I just want to go over some logistics before we get started with the day. We do have Wi-Fi available in the convention center, and you'll see it up here. SPFD Rental is the name of the Wi-Fi. And then I'll leave this slide up just for a little bit for the password. It's capital SP02 or O 2025 at capital CC exclamation point. Oh, I'm sorry, 020. Breakfast and lunch will be located in the hallway right outside the conference room. I know a lot of you already received breakfast. And then we'll also have snacks and beverages inside the room at the back over there. Restrooms are located in the Riverside lobby, so just exit the room here and make a left. You'll see the restrooms there. And then in an event of an emergency and the need to evacuate, please proceed to the exit doors on the window side of the room onto the terrace, so right over here. For all of the virtual attendees, please go ahead and place any questions that you have in our Q&A on Microsoft Teams. We will have someone dedicated to monitor that throughout the day. And then there will be time set aside at the end of each of our sessions to address questions both in the room and also online on Teams for our Q&A. So we've got a great agenda for you. We definitely have some themes woven throughout the symposium, focusing on really collaboration and coordination for preparedness. And we'll also share some lessons learned from some real-life examples that we've had. We had a suspect case in Alaska and also Lassa fever in Iowa. So we'll make sure to weave that throughout our day and share those experiences with you. So here's our agenda. We'll have presentation from 8:30 to 9:45. We'll take a short break, 15-minute break, and then we'll jump back into our presentations at 10. We'll do lunch at 12:30, and we'll allow us for some time there for networking with everyone. We'll start at presentations at 1:15, and then we'll do a 10-minute break at 1500 at 3 o'clock. And then we'll conclude the day at 4:25 p.m. and we'll allow for some networking. There'll be some refreshments available to you. And we're in a great location right here for those of you that aren't from the area. So Riverfront Park is right here, and so hopefully you can enjoy the sunshine here in Spokane. It's a great park, pretty expansive, so there's a lot of walking trails with signs on the different features in the park. The Spokane Falls are roaring right now, so hopefully you get a chance to go out there and enjoy the park. So those of you that are seeking out continuing education, we will be offering CNE credits. We are disclosing that there are no conflicts of interest by anyone involved or anyone presenting these activities as disclosed by them. And just a reminder, to receive full credit, please make sure to sign the registration form. You have to attend 100% of the activity, and most importantly, remember to fill out that evaluation form at the end of the day. And then we'll have certificates of attendance that will be sent upon completion of your evaluation. So to get us kicked off for the day, I'd like to introduce our first speaker, Jonathan Grine. He's a director of hospital epidemiology at Cedars-Sinai Medical Center. Dr. Jonathan Grine is an infectious disease physician and director of hospital epidemiology at Cedars-Sinai Medical Center. And I'm happy to recognize some of the places that Jonathan's worked because I did a bunch of my training in Southern California. He's a clinical professor with the David Geffen School of Medicine at UCLA and serves as a co-chair for the Infection Prevention and Control Committee. And since 2016, he's also served as a principal investigator for the Cedars-Sinai Special Pathogens Program, funded by the Administration for Strategic Preparedness and Response. Dr. Grine received his medical degree from the University of California, Los Angeles, and he completed his medicine residency at Cedars-Sinai Medical Center in 2007, and his infectious diseases fellowship at the UCLA affiliated program in infectious diseases in 2009. So welcome, Dr. Grine.
Morning. Thank you very much. Okay, I know I've got slides here somewhere and they're coming. Yeah, nope, we're good. How's everybody? Good. I really want to thank the group here for inviting me. Lovely to come up here from Los Angeles. I'm not used to seeing this much water in a river, so it's fantastic.
Clicker.
Perfect. Thank you. Okay. All right. So again, thanks for having me here. We've also been fortunate as the Region 9 Special Pathogens Treatment Center to be able to partner with all of the other regions and their regional treatment centers, including Region 10. And so it's just great to be able to be here and collaborate with our partners in Region 10. So thank you. So this is what I'm hoping to cover over the next 45 minutes to an hour or so, and you can all let me know at the end if I did a good job with that. Hope to review some of the clinical presentations of some selected special pathogens, describe some of the unique challenges associated with providing care for patients infected with special pathogens, and also recognize, hopefully be able to describe how regional treatment centers, such as one here in Region 10 and what we have in Region 9, how we can contribute to the overall national preparedness for special pathogens. And I don't really have any relevant disclosures, but as mentioned, I am the PI for our Region 9 site down south of you all here. Okay, so I'm going to tell this a little bit like a story, if that's okay with you. And in my version of this story, we're going to start in 2014 in Texas, and perhaps some of you know where this is going. But in that time, of course, there was a large Zaire Ebola outbreak in West Africa. And in Texas in 2014, a 42-year-old male presented to an emergency department with a couple days of abdominal pain, headache, and also some nasal congestion. They did a basic workup. You could see some of the labs there. Slightly abnormal labs, slightly elevated AST, for example, but not much was thought of it. He was ultimately sent home with azithromycin for presumed sinusitis. And I'm sure you're thinking that the story doesn't end here, and you're right. Of course, he unfortunately did not get better and got worse, and about 3 days later returned with fevers and now with diarrhea and malaise. He at that time it was uncovered that he had recently traveled from Liberia, which of course was at that time in the throes of a massive Ebola outbreak. And also around that time, he began to develop what was described as explosive diarrhea and vomiting while in the emergency department. Was ultimately admitted. The concern for Ebola, and sadly, Ebola was confirmed shortly thereafter. He was placed at the time, and the CDC recommended precautions for Ebola, which was essentially contact and droplet precautions. Sadly, 2 of the nurses in the ICU who were helping to provide care for him then shortly thereafter began developing Ebola symptoms and were subsequently diagnosed with Ebola as well. And this was really a watershed moment in the United States in terms of how we think about providing care for special pathogens patients. This is a little bit of a timeline, and I know it's small to read there, and I don't expect you to read all the details, but I'll just make a couple points that the patient timeline there is on the top. You could see when he presented, when he represented, was admitted to the ICU and sadly died several days into his admission from severe illness. And I'll point out patient 2 and 3 are the nurses that were providing care for him. And the point I'll make here is that both of the nurses were providing care during his peak illness while he was in the ICU. Notably, none of the healthcare workers providing care earlier in the course of his illness, fortunately, developed any symptoms or contracted illness. The good part of this story here is that both of the nurses ultimately were transferred to biocontainment units and survived their infection. But there were many important lessons learned from this experience. One, of course, is travel history is very important, and this is something we constantly harp on over and over. It's really important to know where people have been recently when you're thinking about a potential infection. We also, sadly, learned that the U.S. health system at the time was highly unprepared for something like this. And we could talk on and on about all of the challenges faced by this hospital, which, by the way, was considered for all intents and purposes a fantastic hospital that had done many things to prepare for this, but they were simply overwhelmed with what had happened. And also, and I think most importantly, the recognition that ongoing system level preparedness is essential to provide safe special pathogens care. And I'll emphasize the importance of system level preparedness, hopefully throughout the talk here. But I think these were some of the real important key lessons from that experience, which is now just slightly over a decade ago. So what I'm hoping to cover now over the next little bit of time, we'll talk about some current special pathogens of concern. I've chosen a few to kind of cite as examples. We'll talk again about some of the unique challenges associated with the care of these patients. And then we'll talk a little bit, I'm going to, of course, talk about the CEDARS program here, but understanding that overlaps very significantly with our Spokane partners here. So we'll talk a little bit about our program and what we do and how we help contribute to national preparedness. And really the ultimate question is, are we ready for what's next? And I'll at least share my thoughts on that. So first, let's just talk about special pathogens of concern. So that really begs the question, what is a special pathogen? Some people call this high consequence infectious disease. You may hear other terms thrown around. Interestingly enough, we don't really have actually a universally accepted definition of what a special pathogen is. Everybody has a slightly different take on it, perhaps, but I think in general, it's fair to say that this is referring to low incidence infectious diseases that carry disproportionate high potential consequences for healthcare worker safety, as well as for public health. So as I said, there's no formal list of special pathogens, but ones that are commonly associated or considered special pathogens include our hemorrhagic fevers. So that includes our filoviruses like Ebola and Marburg, Lassa, as well as Crimean Congo hemorrhagic fever or some of the South American viral hemorrhagic fevers. This may also include emerging respiratory pathogens such as MERS-CoV. There's obviously been a lot of talk about influenza H5N1. I know there's a talk coming up on that after me, so I'm not going to get into H5N1 today. And then also I've kind of loosely bucketed other pathogens, things like Nipah and Mpox is an interesting case study. I won't spend too much time on that today. I am going to spend some time talking about filoviruses, Lassa, and Nipah, because I think these are ones that are at least high on my list of things that we worry about. So let's just jump right into it. And get into a case study. And this was just not that long ago, Rwanda, 2024 in September. As you're probably familiar, Rwanda reported multiple cases of Marburg associated with a hospital, or actually a couple hospitals in Kigali, which is their main capital. At the end of this outbreak, in total, about 66 cases with 15 deaths. That's a remarkably low fatality rate in general for Marburg. Sadly, 80% of those cases involved healthcare workers. And looking back at this situation, the index case, it was hard to pinpoint, but they believe was likely a minor who had been recently hospitalized for what was at the time thought to be malaria, and then in retrospect identified as Marburg. And I think I'll just say credit to the health response in Rwanda due to tremendous aggressive supportive care as well as rapid implementation of medical countermeasures. They saw one of the lowest mortality rates on record for an outbreak of Marburg virus. There was aggressive use of remdesivir, which is off-label. Now, we all think of remdesivir as a COVID drug, of course, but keep in mind that remdesivir was really actually developed as a filoviral agent and was initially trialed in the PALM trial and its efficacy in Ebola. Not a great drug for filoviruses, but it does have really good in vitro activity, and it was thought that it's probably got some benefit, although we don't know for sure. The Rwanda health system also employed experimental therapeutics, including a monoclonal antibody, MBP-091. They were also very aggressive in providing an investigational vaccine for Marburg virus. And I think all of these things, in addition to just very aggressive supportive care, IV fluids and whatnot, all hopefully contributed to a much lower mortality rate. The good news here is no cases were detected outside of Rwanda. They were able to contain this outbreak in relatively short order. But what do we know about Marburg virus? So it is really it's a filovirus in many ways very similar to Ebola virus. Looking at outbreaks that have been published, the mortality rate ranges anywhere from 23 to upwards of 90%. The host is that cute little cave-dwelling bat there. That you could see that likes to dwell in caves, and that is one of the reasons why people who work in caves and miners are potentially at highest risk of contracting this. The largest outbreak of Marburg on record was in Angola in 2005, where you could see close to 400 cases and an 88% mortality rate. So really, really atrocious, and really points to the severity of this illness. In general, it's got an incubation of around a week, up to 21 days. And then the onset of illness heralded by fevers, headache, myalgias, vomiting, diarrhea. Some may develop a maculopapular rash. Some may develop conjunctival injection. And for those who are going to succumb to illness, that usually happens around day 9 of symptoms. To date, asymptomatic cases have not been identified. As you'll see as a common theme across all of these, there are no approved treatments or vaccines for this illness. This is a nice, just quick viral life cycle, so to speak, of this virus and how it works. And without getting too much into the weeds, it's thought that the virus is likely introduced into your body through perhaps minor breaks in the skin, then infects your white blood cells, dendritic cells. That allows it to spread throughout your body, where then the virus can wreak havoc on just about every organ in your body and cause necrosis and really just a devastating systemic infection. Now, sorry, this is another busy slide, but the point I'll make is this is the timeline of illness. And after a incubation period, you'll see that the illness is generally divided into an early phase, generally with what's described as dry symptoms, followed by a late phase or with wet symptoms, meaning nausea, diarrhea, vomiting, bleeding. Very similar to Ebola, and what you're probably familiar with Ebola. And in many ways, this is an illness that overlaps significantly in terms of symptoms with Ebola. But the other point I'll make is that early in the course of illness, when patients are not having wet symptoms, when they're in their dry phase, the viral load is much lower. So these patients are likely much less infectious. And as the illness progresses, as their symptoms become more severe, they become more and more infectious as their viral load begins to climb, and perhaps peak infectivity at the time of death for those that succumb to illness. Now, there have been Marburg outbreaks described since the 1960s, and you can see this map of the distribution. You can see a couple outbreaks in Europe. Those were actually the initial outbreaks described in researchers that were studying various primates coming from these endemic areas, but the bulk of infections really in Central Africa and right around where Rwanda is. One point I will make is that unfortunately the frequency with which we are identifying these outbreaks is increasing. So you can see between 1967 in 2007, a 40-year time period, there was about 8 outbreaks, or 1 every 5 years. Since 2008, that has really accelerated. We're seeing just in that short time period from 2008 to 2024, 10 outbreaks. So a much faster pace of these occurring, with no signs of that slowing down. And I'll just point out from an interesting historical fact that Marburg has made its way to the United States before. There was a really interesting case report from Colorado in 2008 of a 44-year-old female who'd returned from Uganda from safari. She was admitted to a Colorado hospital. with some fevers, abdominal pain, confusion, and hepatitis. Interestingly, also underwent cholecystectomy while during that hospitalization. Fortunately, recovered, and through strange twist of events and serendipity, was retrospectively identified and confirmed to have actually had a Marburg infection during that hospitalization. Retrospective contact tracing fortunately did not identify any secondary cases. I think this was in many ways a miracle when you consider the patient had had surgery and without any suspicion of a viral hemorrhagic fever. So in many ways, we were very lucky, but this is a warning sign, right? That we are certainly at risk of these patients showing up somewhat unexpectedly. Now, with regards to treatments and vaccines, as I said, there are no approved treatments, no approved vaccines. There are several in development. On the treatment side, there are multiple antivirals. I won't go into the details, but unfortunately, very limited human data for all of those. We've got favipiravir with very limited data. Remdesivir, as I mentioned, is protective to some degree in non-human primates, but we have really no experience using remdesivir for Marburg in humans outside of the recent Rwanda experience, which hasn't been published yet. There's also some exciting monoclonal antibodies like MBP091. There's some discussion in the literature about potential benefit of combining remdesivir with the monoclonal antibody, at least in some animal models, that looks like it might have some benefit, but we really don't know how effective these treatments are. And with regards to vaccines, similar story, nothing approved, several in development, including phase 2 trials and including in Rwanda. So we hope to see some results from that soon. I haven't seen any data from those yet, but I'm hoping that we'll get some progress in this regard. Okay, so that's Marburg virus. I'm going to switch gears a little bit. And I know a little later in the day, we're going to have someone talking about the experience in Lhasa in Iowa. So I'm not going to get into the details as well as my partner can, but I'll just remind you that in October, the CDC announced the death of an Iowan resident from Lawson fever. This patient had developed fever 12 days after returning from Liberia, sadly passed away into the course of their illness. A preliminary test for Lassa came back around the time of death. Sadly, because of this, well over 100 healthcare workers were exposed and required monitoring. And again, my colleague will talk in much more detail about this. But I will say that this was the 9th known case of Lassa diagnosed in the U.S. since 1969. It has the notoriety of being the most commonly exported viral hemorrhagic fever outside of Africa. So what is Lassa virus? It's an arenavirus, and arenaviruses are known to affect rodents. So this is a rodent virus in some regards that is endemic to West Africa. It's probably well underdiagnosed. The estimates are 100 to 300,000 cases a year. Upwards of 5,000 deaths a year are estimated in West Africa from this virus. It's transmitted by rodents through their urine or feces. The symptoms develop 1 to 3 weeks after people are exposed. And the good part about Lassa, if there is a good part, is that most people get mild symptoms. Some may not even have any symptoms at all, but about 20% do go on to develop more severe illness and may require hospitalization. And in those patients, you may see bleeding, vomiting, facial swelling, chest abdominal pain, shock, of course, and a very devastating consequence of infection in those who survive includes deafness, which is described in about 1 in 3. In addition to that, outcomes are not great in pregnancy, where miscarriage is very common in pregnant women who become infected. The treatment for this is largely including ribavirin as well as aggressive supportive care. And I'll just make a few interesting points about Lassa transmission is that it does occur with some seasonality, and that has to do with the climate. And what's thought is that during the dry season, the heat drives the host rodent into the dwellings, and they like to dwell inside the mud brick of the homes in the area, and so that brings them in closer to proximity to humans. So you see an increase in Lassa cases during the dry season, which is largely November through May in West Africa. And once it infects a human, then of course person-to-person transmission can occur like other viral hemorrhagic fevers, and patients may present to the hospital, and you can see transmission to healthcare workers. There are many instances of that being described. including one article I included there of a physician's experience where he described being exposed and or infected with Lassa. So you can read about that if you're interested. But this is well known to cause nosocomial transmission. The clinical presentation is just quickly described here, and I won't spend a lot of time on this to say after an incubation period, similar to these other viral hemorrhagic fevers, you may get a onset of nondescript symptoms, fevers, malaise, headache, and such, followed thereafter by abdominal pain, gastrointestinal symptoms. You may get head and neck edema is classically described, conjunctival injection. And then, of course, you may get more and more severe symptoms in patients that will progress, including CNS symptoms. And for those who survive, as I mentioned, sensory neural hearing loss is a common complication. What about medical countermeasures for Lassa? Same story, not much, unfortunately. Antiviral treatments, nothing is approved. Ribavirin is commonly used, however, and there is some data, principally from one study that I've included the table from there for reference. So not a ton of data, but there is some low-quality data to suggest that if you give ribavirin within the first 6 days of illness, you can see a reduction in mortality. So so that is commonly used. Of course, ribavirin has its own set of significant side effects that you'll have to monitor for, including potentially hemolytic anemia. So it is not a benign treatment. And similarly with vaccines, nothing approved. Fortunately, several in development, including a phase 2 trial that is currently underway, although the results of that are not yet available. So we will wait to see what comes of this. Now, I said the point before, and I'll just reiterate that Lassa is the most commonly exported viral hemorrhagic fever outside of Africa. This is one study just citing all of the exported cases from West Africa, mostly to Europe, where they see a higher volume of travelers from the area. But we've had now in total 9 cases in the US. And if you had to put your money on a viral hemorrhagic fever to strike outside of Africa, it would be Lassa. Now, a little bit of a sobering note here. This is one study looking at modeling of changes in climate, changes in human populations and animal populations. And this study is demonstrating that due to all of these changes over the next several decades, we'll likely see a dramatic increase in the number of people that are potentially at risk of Lassa. So you can see currently estimated around 83 million people living in areas where it's endemic. That number will likely increase to well over 300 million by the year 2070. So this is something that we need to be very cognizant of is not a risk that is going away. Okay. I'm going to speak about one more special pathogen, and this will be a case study in Nipah. So changing gears a little bit in your brain. This was in July, is in 2024 in the Kerala state, which is in the southern part of India, and I'm probably mispronouncing it, so my apologies to anyone who may be from there. But they reported a fatal case of encephalitis from Nipah in a 14-year-old. This case, it was unclear where the patient had contracted the illness. There was speculation that he may have acquired it from eating some what was called a hog plum fruit from prior to the illness, and it was speculated that that could have been contaminated from bats roosting above in the trees. None of that's been proven. I mentioned that here just to make the point that it was unclear kind of where the illness came from. They through this investigation identified over 300 contacts, including over 100 high-risk contacts. Fortunately, no secondary cases from this particular outbreak, but this was the 5th outbreak in this area since 2018, and this is really a hotbed of Nipah at the moment. So, what do we know about Nipah virus? It's likely a virus most people have not heard about. It's a paramyxid virus, so that puts it in the same category as things like mumps and measles and parainfluenza. It's endemic to parts of India, specifically Bangladesh and India, where most cases have been reported. The initial outbreak of this was reported actually in Malaysia. For those who are movie buffs, I always like to say this is the virus that they modeled the movie Contagion after, if you've seen the movie. So that makes it a little bit easier to remember, perhaps. The symptoms can range from anywhere from mild to severe and, of course, fatal. Mortality rate in 40 to 70%. The host is this flying fox fruit bat. These are not the cute little cave-dwelling bats we talked about with Marburg, but these are the large I always joke it's like when you watch Indiana Jones, the large fruit bats that they show in the movie. It's those bats. The symptoms develop probably 3 to 14 days after being exposed. Fever, headaches, cough, sore throat. Some then will go on to develop an encephalitis, and you can see an MRI here of some classic discrete subcortical and deep white matter lesions that you may see on an MRI. So this is kind of what we know about Nipah virus and just a little bit more. The life cycle is thought to be that this flying fox fruit bat is the primary reservoir host, and that as the bat excretes the virus into the environment, it may infect other animals such as pigs or horses, as it did in Malaysia classically. But this bat also likes to roost in trees, and specifically trees that are used to collect palm sap. And so this is thought to be one of the most common ways that humans are potentially exposed to this virus is through that mechanism. Now, this is a little bit of a sobering slide because the graphic here on the left shows the areas in red are the areas where Nipah has been described in humans, but the areas in yellow are the areas of the fruit bat distribution. So these are really areas where we are at risk of seeing cases of Nipah, but for maybe perhaps luck, we have not. And I'll just point out there are quite a few people that live in this area that is described. So, there is certainly concern for increasing cases of this. And picture on the right just shows the collection mechanism for date palm. And you could see very simple mechanism, how easy that would be for bat excreta to potentially fall and contaminate these date palm collection devices. And that is thought to be the primary mechanism currently for how humans may get exposed. Now, why do we worry about Nipah? This is a really good case study in my mind to illustrate the concern with Nipah. So this was a incidence in southern India in 2018, where a 27-year-old man presented with fevers, myalgias, and vomiting, subsequently developed encephalitis, but along the way visited 3 different medical facilities presenting for care, which I think is not uncommon. And you could see through the retrospective contact tracing they did all of the secondary cases that were identified from close contacts both of patients and healthcare workers in the surrounding environment that this patient was in. In total, 22 additional cases were identified across those 3 hospitals, including caregivers, other patients, and a 91% fatality rate. So in my mind, this is a really good example as to why this is something we need to be mindful of and watching for. Now, a similar story here with regards to treatments and vaccines, nothing approved, several in development. So I won't spend a lot of time here, but with regards to treatments, just know that ribavirin is thought to have lower mortality when it's used. However, the data behind that is pretty weak, so we don't really know. Also, remdesivir is thought to have some activity, at least partially in vitro, so it might be effective, but we really have no experience with that. And again, multiple vaccines in development, nothing approved at the moment. Okay, so if I've done a good enough job scaring you, I'm sorry. But what I've really described over the last 15 or so minutes are examples of zoonotic diseases. And it is estimated that about 3/4 of all emerging human pathogens have some sort of zoonotic origin. And this is a nice graphic from the WHO just highlighting many viruses that we're all familiar with today, including, for example, hepatitis C or West Nile virus, that all have a zoonotic origin. And so for this reason, zoonotic pathogens, those that primarily affect animals and then bleed into the human population, are perhaps our largest risk for further emerging pathogens. I'm just going to take a quick break for a sip. Okay, and I will also say, and that many believe, and I'm one of them, that the threat posed by emerging infectious diseases is only going to continue to increase, and there are a variety of reasons for that. That may include changing climate, which changes distribution of various vectors and animals, increasing global urbanization. We see a higher human-animal interface, or a more common human-animal interface that increases the risk of exposure to these pathogens, as well as just increasing travel. We're on pace to have the busiest international travel year on record, and that doesn't look like it's going away. So I'll just point out recent examples of changing emerging pathogens that you're all familiar with. I'm not going to talk about H5N1 today. A subsequent speaker will, but that's a perfect example of an emerging zoonotic pathogen. Mpox clade 1, I'll just point out our first U.S. case in California from a returned traveler from Africa, and of course, endemic to parts of Central Africa. Lassa virus, as I've mentioned, Marburg virus, as we've talked about, and I'll even mention, although not necessarily a risk for healthcare workers, but even things like dengue, we are now seeing becoming more endemic in even areas like Los Angeles, and that's my hometown, so now I'm really worried about this. So my point from this slide is that we should expect these events to continue to increase in frequency, whether we like it or not. I'll just add one last slide on this section, which is a study that was just recently published that I found interesting, is that there's really fascinating work going on in trying to predict when these spillover events, so to speak, are occurring. And this is specifically looking at outbreaks of viral hemorrhagic fever, such as Ebola in Central Africa. And this study I thought was fascinating. They used high-resolution spatial data to look at areas of forest loss and fragmentation, and they were able to identify a very strong correlation between areas of high fragmentation of the forest and incidence of outbreaks of Ebola virus, which I think is very insightful in terms of the potential etiology of this. And quite simply put, the more humans are having interactions and having that human-animal interface with animals that are infected with these pathogens, the more likely you are to see human cases. And I think this paper makes a really good point of that. So just use this as an example of some really fascinating work going on to understand where these spillover events might be occurring so that we can hopefully channel our resources to focus on early detection and mitigation and containment once we've identified them, and of course, aggressive treatment. Okay, so we'll move on now to the second part of this talk, which just is an overview of some of the unique challenges that are associated with providing care of these patients. And I'm perhaps preaching to the choir in this group, so just be patient with me. But there are a few I guess I've clumped them into 4 categories. There are perhaps more. There are many things we do differently with these types of infections than normal standard of care. So I put them into 4 categories here. For example, 1, we take significantly enhanced healthcare worker safety measures, including the use of non-traditional PPE, extensive protocols to minimize our risk of self-contamination, things like symptom monitoring for healthcare workers that are providing care for these patients. All of these things are not typical in our care of other pathogens. There are, of course, unique clinical management issues with the care of these patients. There's just very little data on what treatments are effective for these infections. There are a lot of challenges, even with just the logistics of getting diagnostic testing. And of course, investigational treatments are a common or should be always thought about for the care of any of these patients, given their low frequency and high mortality rates. I will speak briefly about unique waste management issues, which is perhaps putting it lightly. But the management of the waste streams that are generated from the care of these patients is substantial and provides a substantial logistic barrier to providing care in our current U.S. healthcare setting. And then lastly, I'll just speak to some of the health system challenges associated with these care of these patients. And there are many. I'll just focus on a few, including transport challenges, management of the worried well, and the importance of having very robust communication strategies when you're providing care for these patients, not just for the team providing care for the patient, but for the health system and for the community because of all of the interest and media that these cases tend to get. So let's just first briefly talk about PPE. You're all likely familiar with the kind of extensive PPE used for these patients. And why do we use PPE like this for patients with, I'm really using viral hemorrhagic fever here as the case in point. So when we think about viral hemorrhagic fever patients, we know a couple things. One, they generate a high volume of infectious secretions. And one study from patients hospitalized with Ebola, I believe this was in Nebraska in 2014, found that the fluid output from one patient could approach up to 10 liters a day. So it's a very, very high volume of liquid secretions. And coupled with that, those secretions have a high virus load, but also these viruses have a very low infectious dose. And it's thought that as low as 1 viral particle might be enough to cause an infection in a human. You can put that in context to a logarithmic difference with other pathogens that have been estimated. So when you combine these two, you can see that there's a very high risk of transmission to care providers, even minor breaches in PPE can be sufficient for transmission. And unfortunately, in healthcare, sometimes we tend to get a little bit lazy with PPE. We don't always don and doff it in the safest way. And we can do that for most standard pathogens because minor breaches aren't consequential to us. But with infections like this, they certainly are. So we've learned some things about PPE, and in particular, we've learned that self-contamination during PPE removal is actually very common. This was studied quite a bit after the 2014 Ebola experience in the US. And you could see that the more complex your PPE, the more likely you are to self-contaminate. One study here that I'm citing found an overall 79% contamination rate in staff that were doffing Ebola level PPE, most commonly on the shoulders, neck, chest, and hands. So that is certainly alarming. But we've also learned that regular training can help to reduce this risk significantly. And we've also learned that there are things you can do to minimize risk even further, such as using a trained observer, which is what all of our regional special pathogens treatment centers do and what we train to do. And that is literally someone there who is guiding healthcare workers through each step of doffing. And we know from studies that both of these efforts can reduce self-contamination significantly. I'll just speak for a moment about unique lab challenges associated with the care of these patients. This is a picture of some of our team doing an exercise a few years ago. We know that for example, even just collecting specimens, we need to take special precautions to make sure we do not injure ourselves with a needle stick, for example, while collecting specimens. Transporting these specimens has its own challenges. Of course, we want to make sure that we safely transport it, and we also have to use specially devised packaging for Category A specimens for transport, which is illustrated there. And then, of course, there are ways we have to safely perform testing, including routine clinical testing, but also diagnostic testing, not just for special pathogens, but for other common pathogens. And so this puts an onus on our laboratorian colleagues to develop very safe protocols to be able to do this. Just a word about diagnostic testing, and I do think this is a big weakness nationally, in my opinion, is that we just do not have robust mechanisms or tools available for special pathogens diagnostic. Nearly everything is diagnosed through the CDC, which is great, except for that provides a significant bottleneck to testing, which is unfortunate. And at least in my worldview, I think we should be lowering the barrier to getting these tests and not increasing the barrier. So that's my opinion. I will point out that the Department of Defense does control access to some PCR panels that many, I think all of our regional centers have access to now, that does allow us to provide presumptive results, and this is very useful. But there are barriers to getting this type of testing. You can't just order this off the shelf. And so we do have a lot of bottlenecks with regards to diagnostics for special pathogens in this country. I'll just mention briefly investigational agents. As I said before, the use of investigational agents should always be considered when caring for patients infected with a special pathogen because the consequences are so severe. And most investigational agents available are usually monoclonal antibodies, some antivirals as well, but they're all in either preclinical or only early clinical phase trials, phase 1, maybe phase 2 if you're lucky. And so this creates a significant barrier for the clinical management of these patients. We just don't know which treatments are effective. Of course, in this country, we have an emergency IND process through the FDA to get access to many of these treatments, and that works very well. The problem with the EIND process, for those who have done it, is that it does create barriers to then being able to collect data on the efficacy if you're using this in multiple patients. And we learned that the hard way in the early days of COVID and the initial 10 Ebola cases in the US. And so I will just point out that many of actually all of the regional treatment centers have moved towards developing a single IRB process across the 10 regional centers so that if there is a cluster of cases of an emerging pathogen, we could rapidly enroll them into a trial and more rapidly collect data rather than having to use the EIND process. Now, I put a picture of the PALM trial on here just as a case in point, in that my point is it's actually very, very difficult, as you can all understand, to conduct clinical trials for any of these pathogens for a variety of logistical challenges. So even during the height of the West African Ebola outbreak, where there were, again, tens of thousands of cases, even during the height of that, with a tremendous amount of effort on trying to get clinical trials up and running, you can see this 4-arm trial was not even able to enroll 200 patients per arm. And the reason is not because people didn't know what they were doing, is because the logistic challenges in getting these clinical trials up and running in a timely way. So I just using this to make the point that we will likely never have great data on many of these agents, unfortunately, for these infections, but we've got to do what we can with what we've got. Speak just for a moment about waste management. Never thought I'd be up here talking about waste management in front of a bunch of people, but here I am. So waste management I bring up because the logistics of this should not be underestimated. And we unfortunately know that caring for patients with special pathogens and all of the PPE we use generates a lot of waste. And it was estimated, well, I'll get to that in a second. But the other challenge, of course, is this waste is all then considered Category A waste, which has with it in this country a significant amount of regulatory control over it for understandable reasons. Unfortunately, we know that the care of these patients generates a huge amount of waste. It was estimated one patient in the United States in 2014 generated about 1,000 pounds of waste, just to put a number to it. So this is not something that should be taken lightly. And in fact, as I understand it, this was one of the biggest logistic challenges that our poor colleagues in Dallas had to deal with that first Ebola case, was just management of all of the waste. So that means that regional treatment centers or treatment centers in general have to have some detailed processes on how they're going to manage waste. We generally break this down into management of solid waste, and that could either be done on site through an autoclave or off site through incineration, or it could be, and in addition to that, liquid waste streams. And I'll point out that, for example, with viral hemorrhagic fever, CDC does not recommend any specific disinfection of liquid waste going into the sewer system. That being said, CDC is not the regulatory body for that, and local water management districts are, and they will usually or often require some sort of disinfection process for this, if anything other than to make people feel safer. But you do need to work with your local water management to develop a process for this. Also, just add that you should anticipate non-scientific barriers to this. And there are many examples of this during the 2014 outbreak in political barriers to waste management. And for example, governors barring the transport of processed inactivated waste through their state for incineration, for example. So these are just some challenges. Unfortunately, we've also learned that autoclaves aren't as simple as we would have liked. I was under the naive assumption that you could throw some waste in the autoclave and turn it on and everything gets inactivated. And sadly, that is not always completely true. This is a picture of my team. We're digging through mock waste with our state waste regulators on some autoclave protocols here. And what we've learned through some studies done in this with some of our colleagues is that the waste composition, how much moisture and other variables can affect how well the heat of an autoclave can penetrate into waste. And what this means is throwing waste into an autoclave is not as simple as we would have liked. And all of us are actually still in the process of working through specific protocols on how to inactivate waste thoroughly so that we can all feel safe. Okay, I'll just speak for a moment about patient transport, and then I'll start to wrap up here. And I know I've got some colleagues in the room that have really spent some tremendous effort on this topic, so I won't do this completely complete justice, I know, but I'll just make the point that we have significant challenges still in the United States with ground transport and air transport of these types of pathogens. Ground transport, as you can imagine, provides significant logistical challenges. Our poor EMT colleagues, for example, wearing PPE for extended periods of time is very challenging. You also have to think about other contingencies that can occur during transport, such as accidents and coordination required with police and first responders. How do you disinfect an ambulance, of course, after a patient is transported? All of these things can be worked through, but they do require significant planning and training. And of course, unfortunately, air transport in our country for special pathogens is still unfortunately very limited. So as I understand it, really just one private company, Phoenix there, that has the capability to do this, in addition to, hopefully some additional capabilities coming in the near future, but just points to a significant logistical challenge we continue to see in this country. So that kind of takes me to the last part of my talk. Thanks for your patience. Is where are we at now with special pathogens preparedness in the United States? I'm going to use Cedars-Sinai program as an example because that's what I know, but I recognize that my program capabilities overlap almost completely with our Spokane colleagues. So I'll just use that as an example. So going back to 2014, again, really, this was a turning point in special pathogens preparedness in this country. I put these pictures up as a reminder of the hysteria associated with Ebola in 2014. It was not completely unusual to see someone in homemade full-body PPE in the airport in 2014, if you remember those times. There was a lot of concern. And so that event in Dallas, and particularly the transmission to 2 healthcare workers, demonstrated the need to develop specific expertise in special pathogens care. At this time, all U.S. hospitals began to rush to secure PPE and develop their own programs. This, of course, led to supply chain challenges and extreme costs. That is not a sustainable approach. It doesn't make sense for every hospital in the country to be prepared to do this type of care for the duration of illness. So at that time in 2014, the federal government decided to step in and allocate funding for a more strategic approach to this. And this, so the initial funding was set aside to develop what is now called NETAC, as well as the regional Ebola and special pathogens treatment centers. So this was developed in the wake of that 2014 Ebola outbreak. And the strategy at the time was to develop a tiered approach with treatment centers capable of providing care through duration of illness, assessment centers to provide care through the first few days of illness pending test results, and then frontline healthcare facilities, which was essentially everyone else that was really prepared to identify, isolate, and inform about a suspected case. And the initial approach was to put a regional center in each of the 10 HHS regions across the country. And you can see that map there. I'll point out now we have 13, fortunately, but that was the initial strategy. And the idea was that regional treatment centers, such as ourselves and our Region 10 colleagues up here, would be ready to admit a patient within 8 hours, provide treatment through the duration of illness, maintain regular exercises and trainings, maintain PPE supplies, manage the waste, rapidly deploy experimental therapeutics if needed, but also, and I put this in bold because I believe it's one of the most important things, is collaborate with our partners across a wide range in the healthcare industry to maintain this ongoing readiness. And I think that is what we continue to do. So just briefly about my program down in Los Angeles, and I shouldn't say my program, our program down in Los Angeles that I'm very happy to be a part of. We were funded since 2016 to support Region 9. That includes California, Nevada, Arizona, as well as all the Pacific. And I'll point out a commonality we have with Region 10 is just the vast geographic challenges associated with that. So good reason for us to partner with Region 10 to learn from them. On this. We maintain a really wonderful volunteer clinical team, nurses, physicians, respiratory therapists, laboratorians, and others. We undergo regular exercises, and I've thrown a few pictures in there. We do not at this point have a dedicated unit, so we take over a corner of the ICU if we have to activate. So I've just shown some pictures of kind of what that looks like. We have the benefit of having 2 rooms next to each other that are negative pressure and share a common anteroom that works really well for donning and doffing PPE. And we'd set up a lab right next to our patient room. So that's the kind of creative approach we've taken. We are developing a dedicated biocontainment unit space. It hasn't yet started construction, so I'm hoping it does. But this process works fairly well. And of course, we do multiple exercises, and I've shown some pictures of exercises here. I know our Region 10 colleagues have similarly done some amazing exercises, for example, including exercises with pediatric patients, advanced skills like intubation. My personal favorite is the exercises with the obstetrics patients and practicing delivery on that's a mannequin there for just to be clear. So I think all of these things, of course, it's unlikely that we hope that a patient we'd ever have to be in a scenario where we are delivering a baby that is potentially infected with this. But what I would say is this type of practice is really critical because it gets everyone engaged. And if you can do this, you can do many other things. And so that is the way I look at this. Of course, we have a dedicated laboratory for this type of work, and I won't go into the details of it, but we do provide an option of diagnostics and clinical supportive labs for our patients, as I know our Region 10 colleagues do as well. And of course, other things such as maintaining a PPE stockpile, doing other things like educational outreach, things like this and symposiums, but also things like training sessions, PPE training, hospital consultations. And I know our Region 10 partners are also very active in that. And we've had the opportunity to collaborate with them on some of these trainings and educational efforts, which I'm much appreciative. I'll just point out that collaboration is key in all of this work. We can't do this work alone. We require close collaboration, for example, with our communications team, who I have on speed dial, with our IRB, who's been very collaborative with us in setting up a single IRB with Nebraska, and also our state and local public health. We touch base constantly with them. And all of this is important because it doesn't just help us for special pathogens preparedness, it helps us for a lot of other things. There's a few ways we could be activated, and this applies to all regional centers, not just us in Region 9. We may be activated by a federal request. For example, a repatriated healthcare worker coming from an outbreak zone outside of the country. They may ask a regional center to help provide care in that situation. We may be activated by our state or local health department, for example, to care for a patient who has returned, traveled to an area with an outbreak and developed symptoms. And of course, like everyone else, we have to be prepared for unannounced travel as a patient showing up to our ED or a clinic unannounced. And so these are the ways that we kind of prepare. I will point out one little difference. We were very happy in LA. Our local health department has financed these really unique special pathogens transport ambulances, which are only used for special pathogens transport. So these are strategically deployed for us across LA County. What's nice about these, they're really just a stripped down ambulance that allows for isolation in the back compartment with a localized HEPA filtered air compartment in the back. Very easy to disinfect surfaces and such. And it also provides really great training opportunities. So we exercise regularly with our local EMS on this, and it's been a great tool for us. You don't need a high-risk ambulance per se. You can do this with the standard ambulance, but this does make things easier, and it's a great training mechanism for us as well. I'll just point out quickly that these activations are infrequent, but we try to get the most out of them. We did activate once for a suspect Ebola case in 2019 on short order for a return traveler. They, of course, ruled out, but it was a great first opportunity for our team to put things to use. But we also activated in January 2020 in a modified way to help provide care for one of the very first COVID patients in the United States. This was in a returned traveler, a family actually from Wuhan, China. One of the very first cases reported in the United States. We also activated in a modified way to help provide care for some of the very early Mpox patients, and this was actually in an outpatient capacity. And all of this brings up kind of one last point I wanted to make, which is that everything I've been talking about up to this point is about a biocontainment response. Really, you're taking a small number of patients, dedicating staff, dedicating a huge amount of resources, an abundance of PPE, and this is really a resource-intensive way to maximize safety. But when you get to something like a pandemic, of course, we all know, sadly, that is very different. You have a large number of patients, you have to use all your space available, you have very limited PPE, and you could say that is a judicious use of resources to maximize safety. My point is that there is a significant overlap in all of the training and preparation and education and collaboration that you do for biocontainment preparedness really does help you with pandemic preparedness. And I make that point because I do think there's value in this work more broadly than just in biocontainment. Okay, I'm going to finish up here. We still, of course, have some significant gaps in our national preparedness. The most salient, I'll say, is the lack of funding for non-regional treatment centers up until very recently. So that means assessment and frontline hospitals, unfortunately, have kind of withered away in their preparedness. Now, recently, there's been some funding allocated to support additional treatment centers. Of course, with all the federal uncertainty right now, it's unclear exactly how that's going to shake out, but we hope that continues. I mentioned this before, and I'll just reiterate. I do believe we have a significant diagnostic testing bottleneck in this country. We still need to overcome. We shouldn't have to send every test to the CDC, in my opinion, to confirm a diagnosis. We should have better access to diagnostics for these pathogens to lower the barrier to testing. We still have limited transport capabilities across the U.S. for all of the logistic challenges I mentioned, so I know there's ongoing work on this. And I'll lastly just say that waste management plans are still a big challenge. They're challenging, costly, and inconsistent across states. So we still have to work through some of these details. But I do think there's reasons for optimism. The National Special Pathogens System of Care is being developed. And this is the concept that we need to kind of organize better and get to a tiered level of treatment capabilities that mirrors what we see, for example, in a stroke system or the burn system. We have different levels of facilities. And the idea is that you also need a coordination scheme or mechanism for this. And our NETEC colleagues are best positioned to serve as a coordinating organization to support this kind of tiered structure. I'll also point out that EMS is a critical piece of this tiered structure because we need to get patients from point A to point B in a system like this. I'll just kind of lastly say that there are some interesting novel approaches being developed, actually one kind of right behind me. So for example, right in front of me, I should say, these rapidly deployable isolation tents are something that have been newly approved, and we are looking at the best ways to deploy these kinds of strategies. Also, just add that our colleagues at ASPR have been working on more robust transport processes, such as this portable biocontainment unit model, which is a prototype has now been developed, and we hope to see more of these coming. So there is hope on the horizon. And I will also say, as you all are familiar, the new Joint Commission requirement around identify, isolate, and inform is now required for all hospitals, which is great because it's spurring on a lot of discussion around how hospitals can prepare for this. So just included our kind of process at our hospital for this. But the idea is we need to have every health facility ready to immediately identify, isolate these patients, and inform local public health to work through next steps. So I'm going to skip that and just say, in summary, we have to believe that these events are going to increase in frequency over the next several years and decades to come. We are going to need ongoing system-level preparedness to be able to provide safe and high-quality care for these patients, and we will all need to stay vigilant and use our identify, isolate, and inform process to identify these patients in a quick way so that we can rapidly get them into this system of care that is still being developed and that I think has come a long way. So with that, I really want to thank you for your patience. I hope I didn't go over too much, and happy to take any questions.
Thank you. I do have one question online. This is from Brian Thornburn, sorry. Considering that in general, patients infected with HCID pathogens initially present with ILIs or influenza-like illness or GI symptoms, which many patients present with in hospitals, do you think that standard droplet and contact precautions, including gown, gloves, non-N95 masks, are sufficient in preventing healthcare worker infections?
Oh, good question. Yeah, I think kind of if I can say, I think the question is kind of getting at, it is very difficult to rapidly identify these patients right up front. So I think that's an excellent point. And obviously I would not say that standard precautions alone should be used for the care of a special pathogens patient. I wouldn't say that, but I will say that we shouldn't forget the benefit of good, high-quality standard precautions and transmission-based precautions in significantly mitigating the risk. Actually, I think case in point, if we want to use the 2014 Dallas example, where that patient came in very ill, of course, on their second admission, and fortunately, perhaps by a little bit of luck, but also because of standard precautions and some basic PPE, we did not see any of the initial care providers get sick. It was, of course, in the throes of the later parts of illness where we did see 2 healthcare workers get sick. So there is something to be said for good quality standard and transmission-based precautions to reduce risk for sure. I am not saying that I would recommend that once you know a patient has that, but it definitely can be very, very it can significantly reduce the risk. Absolutely. I hope I'm understanding the question correctly.
Do we have any other questions in the room?
All right, well, I hope I didn't put anyone to sleep, but I'll stick around. All right, but I appreciate it. Thank you guys very much for your attention, and happy to take any other questions if they come up.
Thank you, Jonathan. Yeah, round of applause. I'm just going to pause. Hi, everybody. I'm Krista. I manage our program here at Providence Sacred Heart Medical Center. So thank you so much for being here, and a huge thank you to Jonathan for coming up and sharing his expertise with us. We have just in the theme of collaboration that he highlighted is I think that's one of the biggest strengths of the RESPECT program and the development of the NSPS. And some of Jonathan's team came up and played with Category A waste with us in February. Just an example of coming together with also colleagues from Denver Health at the Region 8 RESPECT to really dive in deep and collaborate on how are you approaching this, or how are you approaching this, or what does your state make you do? Sorry, state health partners, or what don't you have to do as far as regulatory things around Category A waste. So that's just one example of how the regional treatment centers really come together and try to tackle some of these challenging issues. Any other questions that spark? Oh, go ahead, Brooke. Oh, I'm bringing you the microphone.
Well, thank you. I've got one more in the chat. What resources do you use to create your ID threats? Oh, sorry, that's actually for me. Do you have any of this embedded in our EMR? So any of your identify, isolate, and inform embedded in your EMR?
For us, yeah, no, good question. Yeah, so we, at least for our facility, we do have the customizable travel screen tool that we've built in. So in theory, the goal is that, you know, everyone asks about travel as patients present. And then we can build in kind of secondary questions. So the basic question is, have you traveled outside the US in the last 30 days? And then we can link to specific countries depending on the outbreak and that. So that's the tool we use, and that works fairly well. You know, I'll be perfectly honest, it is hard to expect everyone to ask about travel at every encounter. It is very difficult. So we reinforce that with our highest risk areas like the EDs in particular. I was going to make one other point. I know there are some Epic-based travel screen tools as well from Epic that many places use, which work well. So it kind of just depends on kind of how you're set up and how you want to use it, but we do use some.
And there's a follow-up to that. This is in regards to your QR code. What resources do you use to create your ID threats for your QR code?
Yeah, I didn't really show it much because I was running over, so sorry. Yeah, we put this out once a month. It's what we call an ID threats report. The idea is we just want to provide a quick and easy tool for our frontline providers, ED, clinics, about things that we want them to be aware of. So we base this on local outbreaks that we're aware of. So you'll see some LA County specific stuff on there, but also CDC reports, you know, WHO reports. We kind of keep our eyes on CIDRAP and other tools out there, and kind of it's a conglomeration of a few different sources, I guess is what I'm saying.
Thank you.
An international airport here, very different from Los Angeles International Airport. Like, how many suspect cases do you feel like you guys see on a yearly basis with the amount of international travel?
Yeah, it's obviously it depends on the countries involved, so it's a good question. You know, we don't see a ton. We'll see a handful, I guess I'll put it that way. You know, we're one of many large health systems in LA County, so I guess they kind of get evenly distributed across. But you know, it kind of brings up an interesting question though, in my mind, which is, it's easy to deploy a travel-based risk screen when it's a country that very few people go to. It's very hard to do that when you have a country involved that a lot of people travel to, because you do have to be somewhat aware of the risks associated with overtaxing the system. So there's a little bit of a balance in my mind, that you don't want to have so many false positives that it doesn't mean anything. That becomes a burden. And you know, there is a little bit of a risk with activating. You may be potentially delaying care for some period of time as well. So these are all kind of some, I think, nuances to this travel-based screening. The last thing I'll say is H5N1 is a really good example of how travel-based screening isn't always the best way either. And obviously H5N1 travel-based screening it doesn't really work. So yeah, we don't always have a great way for recognizing these patients up front, unfortunately. We do the best with what we can.
Yeah, it's challenging. Any other questions from the audience? All right. Thank you so much.
Thanks a lot. Thank you.
All right, we are actually running a few minutes ahead of schedule, which is very exciting. We're going to take a brief break here in a moment, but I wanted to introduce McKenna Freed. So McKenna, do you want to stand up? McKenna is a member of our special pathogens team, and she just graduated with her doctorate in nurse practitioner, right? Yes, this weekend, yes. And she worked with our team at Sacred Heart on her doctorate, your project. What's it called? What was it called? Her DNP project. And so, and she worked with Kootenai Medical Center in North Idaho around special pathogens preparedness. And her amazing poster that highlights all the hard work and really the deep dive that she took with them around special pathogens preparedness is on a poster out in the foyer, out where our beverages and food will be. So we really invite you to go take a look at that and that hard work. And McKenna will be standing by her poster, happy to answer any questions. Do you have anything you'd like to add, McKenna, to that?
No, you pretty much covered it. I'm happy to answer any questions. And then I also have flyers for more resources related to the project if you guys are interested in any of that. So I'm excited to be here and looking forward to your guys' questions.
All right. My name is Daryl Ruby. I'm the regional coordinator with our special pathogens program here, and it's my distinct honor to introduce our next keynote. Henry Arganchona is our medical director, and so we get to know him well. You might also recognize the last name. He happens to be brother-in-law to our program manager. For anyone who is setting up a program, it's a highly efficient way to communicate when your nurse leader is related to your medical director. But Dr. Arganchona is an infectious disease doc, board certified in that, University of Washington grad, so a diehard Husky here in Washington State in the UW-WSU rival, and he's been working as an infectious disease doc for over 30 years. So I will not share with you when I ask him how he wanted me to introduce him, but again, it's my pleasure to introduce Dr. Henry Arganchona.
All right. Well, when given a talk, I mean, my first big challenge is coming up with the title. So I'm always looking for advice or suggestions. And my brother, Krista's husband, Pat, I said, well, what do you think, Pat? And he said, how about H5N1 from beginning to influenza? And I said, well, okay, but not great. Krista liked How to Win Friends and Influenza People. I don't know if you've ever read that old book, but my wife, Carlene, was an ER doc. She retired 5 years ago at Sacred Heart. And she would often listen to my lectures as I prepared them before I gave them and give her thoughts. It was always very helpful. So when she listened to this one, her suggestion was, pandemic influenza, if it doesn't kill you, this talk just might. So I decided not to go with that one. My son, Joe, my youngest, is a endocrinology fellow down at the Mayo Clinic in Phoenix. And so I was run it by him, and I decided to go with his title, which I really like, which is Under the Influenza. So that's what we're going with here. I'm going to cover a lot of ground here, and there are going to be times when you're going to be daydreaming. But what I'd like to ask you to do is just try to learn one or two things from this talk, because there's going to be a bunch of stuff, and you're not going to remember all of it, but just latch on to a couple things. The objectives are to review the history of influenza, particularly with regard to pandemics, talk about the basic virology, and I'll try not to spend too much time on that. Talk about the clinical aspects of influenza, including transmission. Think about avian influenza and think about the transmission and how we might be prepared for that. Also learn about the management of suspected cases of avian flu, and then spend a little time at the end on exploring a prospect of a universal vaccine. So with regard to history, the father of medicine, Hippocrates, back in Greece in the 5th century BC, described a winter outbreak of an illness that is thought to be the oldest existing account of influenza. About 1800 years later, there was an outbreak in Florence, Italy, and that was described and also was very consistent with influenza. And subsequently, influenza has been very well defined and very well understood as an infection. Now, even though a long time ago, influenza was a known entity, nobody knew what caused it. Viruses and bacteria had not been discovered yet. Back then, the theory was that infections and all illness was caused by something called miasma, and that's bad air that comes from decaying organic matter. And so that was the common thought, is that that's where influenza came from. In 1676, a Dutch microscopist, Antony van Leeuwenhoek, had his little homemade microscope, and he was looking at a raindrop under it, and he saw a little organism. 1676, that was the discovery of bacteria. Despite the fact bacteria were discovered back then, still the miasma theory persisted. And it really wasn't scrapped until about 200 years later in the late 1800s when the germ theory was adopted, and that's what I subscribe to nowadays, namely that microorganisms cause infectious diseases. About the time the germ theory came into fashion, a Russian botanist named Dmitry Ivanovsky discovered viruses, and it was kind of in an interesting way. He was a botanist, and he took some diseased tobacco plants. And from these plants, he took an extract and he filtered it through a filter that had porins small enough that it would filter out the bacteria. So then he took these filtered extracts and put it on healthy tobacco plants, and it made them sick. So he surmised there's something smaller than a bacteria that can cause infection. And that was the discovery of the tobacco mosaic virus. You couldn't see it. It's too small for a light microscope, but he knew it was there. In 1933, a group of British virologists proved that the influenza virus was the cause of influenza. So it wasn't until 1933 that we knew that influenza was caused by a virus. And they did an experiment very similar to what Ivanovsky had done. They took, during a flu outbreak in London, secretions from noses of patients who were sick. They ran it through a filter that filtered out bacteria, and then they put it on their children. I'm kidding, they didn't do that. They put it on ferrets. I was going to say put it on their wives, but no, they put it on ferrets, and then they watched the ferrets get ill. And so they said, aha, influenza is caused by a virus. That was a discovery of the influenza virus. Now, about that time, late 30s, early 40s, electron microscopes were being developed. And so sometime in the 40s, I don't remember exactly when, influenza virus was actually visualized for the first time, and you could see the structure. And that's about when in 1944, Thomas Francis at the University of Michigan developed a killed virus vaccine, and that vaccine was licensed a year later. Influenza pandemics. We always think about the biggie in 1918, but the first described one was back in 1580 in China, spread to Africa and Europe, and it's really not known how many people it killed. That's too long ago, but in Rome, it was estimated to have killed 8,000 people. Now, back then, the population of the world was only about 500,000, right? Well, 500 million, more than that. That's about 1/16 of the population nowadays. The population of Rome was probably about 100,000 back then. So 8,000 deaths out of 100,000, that's pretty significant. Every 50 or 60 years or so, there have been outbreaks. They're all a little different in character. 1831 began in China and spread to Russia, Europe, to America. That one was kind of peculiar in that had a very high attack rate, but a very low mortality rate. In 1889, another one began in Russia, spread to America, about 1 million deaths worldwide. But the biggie happened in 1918, and that's the Spanish flu. It's called Spanish flu, and that's not because it originated in Spain. Spain was the first country to widely publicize the pandemic, and that's why it got the name Spanish flu. But most people hold that it actually got its start in the United States in the state of Kansas. So that's the most commonly held theory. I add another little personal story here, and just to let you know that these outbreaks affect people and affect families and change families. The fellow you see there in the middle, his name is Eladio Arganchona, and that's my grandfather. He was born in 1900, and he grew up in Spain in the Pyrenees Mountains. He was a Basque, if you know what Basque is. His family farmed in those mountains. Now, times were tough back then, and so his older brother, who was 6 years older, in 1912, went to the United States to find work. He ended up in southern Idaho near Boise, where he worked as a laborer and herded sheep. And he would send money back regularly to the family in Spain. Well, October or so of 1918, the money stopped coming. So my grandfather, who then had turned 18, said, well, I need to find out what's going on. So he got on a boat, went over to the States, and found that his older brother, Luis, had died from the Spanish flu. So he stayed at the US. He worked as a laborer, sheep herder, sent money back to Spain, found his Basque wife, Laura, and that's why my family is here and not in Spain right now. So the Spanish flu had a couple peculiarities. One was it targeted young adults, those between 15 and 34. They were particularly vulnerable. It's not known how many people were killed worldwide, but there are estimates up to 50 million. And in the US, about 675,000. Now, during the Spanish flu epidemic, the life expectancy in the United States dropped 12 years. Pretty significant. More American soldiers were lost in World War I to influenza than to combat. The first wave in the US hit in Kansas, 18 severe cases with 3 deaths. That was in the spring of 18. In the fall of 18, up in New England at a couple military bases, there was a much bigger outbreak at Camp Devens, an Army training base. There were 14,000 reported cases in that fall and 757 deaths. There was a third wave in the winter and spring of 1919. And this is just a picture of a makeshift infirmary at a military installation in Kansas. Now, this is 1918, and it wasn't discovered that influenza virus until 1933. This is a poster taken from a manufacturing plant during the Spanish flu outbreak in the United States, and the flu is increasing. No one knows what causes this disease. They had a pretty good idea how to avoid it. Keep away from sick people, especially if they cough and sneeze. Use your handkerchief when you cough or sneeze. Avoid crowded streetcars, trains, and houses. Don't spit on the floor. Wash your hands before eating. Krista, keep your fingers out of your mouth. Avoid common drinking cups and keep out of dusty places. Now, again, like I said, in 1933 is when it was discovered that it was caused by a virus, an influenza virus. It wasn't known what type of influenza virus until 1997. And then it was determined to be H1N1. And what happened there is the Armed Forces Institute of Pathology sent a team of molecular biologists up to a little town on the coast of Alaska called Brevig Mission, kind of up the north coast of Alaska. Now, back in 1918, that town was, or that village was occupied by 80 Native Alaskans. The flu hit there and killed 72 of the 80. Awful. Up there, there's permafrost, so the ground stays frozen pretty much year round. So those people that were buried there stayed frozen. So the AFIP sends people up about 80 years later, 1997, and they exhumed the body of a woman who died from Spanish flu, took a piece of her lung, and they isolated the virus. 97, they partially sequenced it and found that, yeah, it was in fact H1N1. Now, with the next few years, the entire viral sequence was done, and from that, we gleaned that it was probably of bird or avian origin, but nobody really knows the path from bird to human, but probably avian origin, and it wasn't H1N1. This is just to show there have been further pandemics. Some of you, I'm sure a lot remember the swine flu pandemic H1N1 that started in Mexico, which is a reassortment of a pig, a bird, and a human virus. Influenza virology. This is the part of the talk where you're going to think my wife's title is pretty accurate. So it's an RNA virus. And RNA viruses, just in general, make mistakes when they reproduce. DNA viruses are much tighter. They have much better proofreading. It has a couple really important proteins, hemagglutinin and neuraminidase. Now, when we say H1N1 or H3N1, the H is hemagglutinin and the N is neuraminidase. Now, the hemagglutinin is a protein on the surface that helps the virus bind to a mammalian cell and enter it. And the neuraminidase is a protein on the surface that helps it bud from the cell when it's reproduced. There are some other important proteins, the matrix protein, M1, and M2, which I think is more important, which aids in the uncoating of the virus when it enters the cell, and we'll get there. Here's a picture of the virus. You can see the little red mushroom-like things are the neuraminidase, and then the little purpley blue things on the surface would be representations of the hemagglutinin. And remember, the hemagglutinin is important for binding and entering the cell. The neuraminidase is important for leaving the cell. We'll get through this quick. So the big oval in the center is a mammalian cell. You see the viruses. Now the virus approaches the cell. The hemagglutinin binds to the virus, helps it enter. The M2 protein uncoats the virus. RNA polymerase from the host cell then transcribes the RNA from the virus to mRNA. That mRNA is read by the ribosome, which makes all the parts for the bacteria. It goes to the surface, and then with the use of the newly made neuraminidase, it buds from the cell, and you have a new virus to go out and infect other cells or be coughed out and infect other people. Okay, there are 4 types of influenza virus. How many people knew that? Everybody thinks influenza A and B, but there's a C and D too. So influenza A, birds are the reservoir, but certainly can infect mammals. We know that it infects us, pigs, horses, bats, seals, all kinds of mammals too. Influenza A is classified by H and N subtypes, just like we said. There are different H's, H1, H2, H7, H5, and different N's. Now, all in all, there are 18 H subtypes and 11 N subtypes. Now, in birds, you can find almost any combination of those. In people, not so much. If you exclude avian infections in people or bird infections, the only H's that are found in people are 1, 2, and 3, and the only N's are 1 and 2. Now, the last few years, the strains going around are H1N1, right, the seasonal ones, and H3N2. Influenza B, which we see in people, is primarily in humans, but it can be seen in other animals like horses and dogs. Generally a little bit more prevalent in kids than adults. There's influenza C, which is seen in humans, but can be seen in other mammals, camels, horses, dogs. Usually doesn't cause bad disease, usually asymptomatic or very mild. And then there's an influenza D that's seen primarily in cattle. People can get infected with it, but they generally don't have any symptoms from it. Now, we know that we have to have a new influenza vaccine every year, right? Because the influenza changes. And even if you're infected with influenza the year before, it's not very protective for the following year. And there are 2 ways the influenza viruses change. The first common one is antigenic drift. And what happens here is each year there are mutations in primarily the hemagglutinin, some in the neuraminidase, that change the virus. Now, the virus can still work and infect cells and reproduce, but it's different. So there's not great immune recognition. There's some immune recognition, so it generally doesn't cause severe illness, but it causes illness. And this is why we have to change the vaccine every year, antigenic drift. The H and N type doesn't change. They're just mutated. So if we have an H3N2, it will stay that, but it'll just be a little different. Just one thing I want to get into, and this is kind of important when we talk about the prospect of a universal vaccine, and I'll get there at the end of this, but hemagglutinin has a globular head, you can see there, and a stalk. Now, mutations happen very frequently in the globular head, but it still works. It can still bind the mammalian cell and enter. Now, if the stem or stalk is changed, though, it kills the virus. The virus can't reproduce. So The globular head of hemagglutinin is different among all the different influenza viruses. The stem, though, is relatively conserved. The stem of H1N1 that you may have had earlier this year, the seasonal influenza, is this pretty much the same as the stem from H5N1 or H7N9. Throughout all the influenzas, it's pretty conserved. Unfortunately, though, when we launch an immune response to influenza, really it's launched against the head, the globular head, and not the stem. If we had some sort of vaccine that would attack the stem, right, because the stem doesn't change and it's conserved through all influenza viruses, you could give one vaccine that would get them all, right? That would be a universal vaccine. So, but unfortunately, the globular head is immunodominant and the stem is immunosubdominant, I guess would be the terms we'd use. Here's a picture of antigenic drift. You can see an H3N2 virus. The H's are those little mushroom-shaped things. Goes into the cell. There's screw-ups when it's reproduced. And you come out where the H's have little pentagons on them. Now, it will still infect cells, but your immune system doesn't recognize it as well. That's antigenic drift. Now, there's another way they change, and this is called antigenic shift. And this happens much less commonly, but when it does, it's a big deal. The major way this happens is when you have a pig or a human or some mammal, and it gets infected with one influenza strain and a second influenza strain at the same time. Now, when that happens, they can mix up and they can form a hybrid virus that has characteristics of both. This happens seldomly, but when it does and that virus gets out into the community, there's often very poor immune recognition. So this is the sort of thing that can lead to pandemics, right? Antigenic shift. And I have a picture here of that, where we start out with an H1N2 and an H3N1. They infect, we get hybrid viruses, and the two to your far right there on the screen are hybrids that we didn't have before. You have an H3N2 that we didn't have before, and an H1N1 that we didn't have before. So that's how antigenic shift works, and it's much less common. Now, here's the scenario for infectious disease pandemic or catastrophe is this. Pigs like to get infected with avian influenza viruses, and they also like to get infected with human influenza viruses. Now, avian influenza viruses generally have a very high mortality, but they're not very transmissible from person to person, whereas human influenza viruses generally don't have a high mortality, but they're very transmissible from person to person. You get infected, the pig gets infected with a bird flu and a human flu, you form a hybrid virus that has the mortality of bird flu, but the transmissibility of human flu. And that's the worry, you know, for the next big influenza pandemic. And eventually it's going to happen unless we get a universal vaccine. We're just going to breeze through this really quick. The virus targets respiratory epithelial cells. The seasonal ones that we get every year generally attack respiratory epithelial cells in the upper respiratory tract. Now, the avian viruses, when they do infect people, they like more to target the lungs or the lower. And you can see an illustration here. H1N1 now is seasonal. And so it targets mostly the upper respiratory tract. It's pretty easily spread because people are blowing their nose and coughing. H1N1 targets generally the lungs. And so it's more prone to cause pneumonia and is often fatal. Now, the recent outbreak hasn't been so much that way. And the H5N1s we've had here have targeted the conjunctiva where there are receptors, right? When people are exposed to cows and they get it, they get conjunctivitis, and they generally have mild respiratory symptoms. So we're gonna skip through this. The virus infects, causes inflammation, the lungs are damaged. People can get secondary bacterial pneumonias, and that's a bad complication from influenza. What happens is the person gets their influenza, they're sick for 3, 4, 5 days, they start to get better, and then they'll start getting worse again, shorter breath, fever, cough. That's the presentation of secondary bacterial infection, and we've seen several of those at Sacred this year. Common bugs for that are strep pneumoniae and Staphylococcus aureus. How in general is influenza transmitted? Large drops. So when you cough or sneeze or sing or talk, and those big drops generally drop within 6 feet of where they were produced, right? They hit the floor. That's the main mechanism. There was a paper in CID, Clinical Infectious Diseases, in 2009, where in an emergency room, they did demonstrate that there was some aerosol spread. And that's when little tiny particles, less than 10 microns, go into the air, float around for hours. It can happen. Also, aerosol transmission has been demonstrated in animal models, but really probably not a very common mode of transmission. It's really mostly large drops. And then fomites. If somebody coughs on their hand, shakes your hand, and you touch your nose, or if somebody hands you a glass that they've touched, that would be a common mechanism also. In people who are immunocompetent, generally they're contagious from the day before they have symptoms for 3-4 days or so. In immunocompromised patients, they can have viral replication for days and even weeks, so they can be contagious for a very long time. Clinical presentation, and we're just talking standard influenza here. Incubation period is 1 to 4 days. You guys know the symptoms: headache, fever, sore throat, cough. Kids often get GI symptoms. Usually upper respiratory, but you can get pneumonia, of course, with influenza, symptoms 2 to 8 days. And then we talked about the secondary bacterial pneumonia, which is a bad complication. Treatment, there are several drugs out there. The first 3, oseltamivir, zanamivir, and peramivir, are all neuraminidase inhibitors. So they bind the N and keep it from helping the virus bud once it's reproduced. There's another one called baloxavir, which is an endonuclease inhibitor, kind of chops up the RNA and processes it. And then amantadine, which really isn't used anymore because it just doesn't work anymore. There's, in most communities, 90% resistance to that, and that's an M2 antagonist. So who should we treat? Just for general influenza, healthy people without any risk factors, if you start within a couple of days, maybe a little benefit from treatment. In hospitalized patients with influenza, there's data that says that if you treat them within 5 days, they benefit. And there's even observational data that suggests there's a mortality benefit. So in your hospitalized patient with influenza, even if it's 4 days out, you want to start your antiviral. And then in immunocompromised patients, cancer patients, transplant patients, they can have viral replication for weeks. So if they've had symptoms for a week, you start it. Now, who's at risk for bad outcome? The very young, less than 2. And I used to say the very old, older than 65, but I don't say that anymore. I just say older than 65. People with chronic pulmonary, cardiac, renal, hematologic, metabolic disorders, neurologic disorders, immunosuppressed, we talked about, high BMI, nursing home residents, Native Americans and Native Alaskans. Remember Breivik mission up in Alaska, 72 of 80, right? And pregnant women are at high risk. Prevention, I mean, currently we're preventing the seasonal flu, or at least we're trying to with our vaccine. We make a new one every year. The current one is targeting influenza A, H3N2, and H1N1, which are the ones that are going around, and then influenza B Victoria that's going around. Now remember that these vaccines induce an immune response primarily to the globular head, that head of the hemagglutinin. Mutations are very common there, and that's why we need a new one every year. A universal vaccine, what we'd want to do is target something that doesn't change, that has to stay the same for the virus to live. So let's shift gears a little bit and go into avian influenza. You see how I'm doing on time here? I've got tons. Okay. Now, as we said, influenza A strains infect birds, and they're the natural reservoir, particularly waterfowl. There are 2 types of avian influenza. It's divided into 2 categories. There's highly pathogenic, like H5N1, which first discovered in China in 1996, and it kills birds. They have a hard time with it. And then there's low pathogenic avian influenza like H7N9, which causes little or no illness in birds, but in people, it's bad. Again, we said there's numerous H and N subtypes, but the ones we're mostly concerned with would be H5N1 and H7N9, because these are the ones we've seen predominate when people get avian flu, and they've been historically bad. Now remember, I think it was late December of 21 when we first found birds in North America with H5N1, and then since early 2022, avian influenza has killed more than 150 million birds, and that includes poultry farms, backyard flocks, and wild birds, 150 million birds. Not just birds, though. On the northeastern coast, have seen increased deaths in seals, and that's because seals are particularly vulnerable to H5N1. Again, it can affect a large number of mammal species, as we see here, dogs, cows, mice, cats, people. Human-to-human transmission had been documented, but the first mammal-to-mammal transmission was documented at a mink farm in Spain, where these farmed mink were giving it to each other. In the US, remember, just recently in Texas and Kansas, March of 24, we detected H5N1 in dairy herds. Now, likely that came from eating feed contaminated with, wild bird feces. Subsequently, we know that the cattle are transmitting it from one to another, and cattle are transmitting it to humans and also to cats. The cows have a lot of H5N1 receptors on their mammary glands. So when they produce milk and colostrum, that has a lot of virus in it. Early on in the outbreak, the farmers would give the colostrum to their cats. The cats would drink it, get H5N1, and cats do very poorly with it. The cats would die. Again, there are other H and N subtypes in avian flu that have been issues. H5N8 caused an outbreak in birds, and 51 million had to be culled. Cost $3 billion to take care of that. And there have been others, but still the important ones are H5N1 and H7N9. So we'll get past that. Just to talk about H7N9 briefly, the first case of that was documented in 2013 in China. Severe pneumonia with mortality of 35%. There has been human-to-human transmission, but it's been non-sustained. It's usually been in households with the index case who got it from a bird. In the 2013 outbreak, the Lancet reported some Tamiflu resistance. So that, of course, is a concern. And as of May of 2022, there were just under 1,600 confirmed cases of H7N9 with just over 600 deaths. H5N1, the first documented human case was in China in 2006. Now, prior to this recent outbreak, it had a 60% mortality. So in the US, we've had cases and it's been less severe. But prior to that, 60% mortality, non-disdain human-to-human transmission documented within households. From 2007 through February of this year, there are 972 reported human cases in the world with 468 deaths. Now, talk a little bit more about H5N1 transmission. The first known bird-to-human transmission was in Hong Kong in 1997. There were 18 reported cases with 6 deaths. In 2004 was the first documented person-to-person transmission where an 11-year-old girl gave it to her mother and her aunt. There was in Sumatra, the island in Indonesia, in 2006, there was a 37-year-old woman who was out taking care of diseased chickens. She got H5N1, gave it to her nephew, and ultimately there were 8 cases there, and 7 of the 8 died. And that's pretty well believed to have been human-to-human transmission. There have been other clusters. There have been vertical transmission from mother to baby, because you get viremic with the virus. The last cases, though, of known human-to-human transmission are 2007, and that was in Thailand and China. So there hasn't been a documented case of human-to-human transmission of H5N1 for 18 years now, if my math is right. Okay, a little bit more about H5N1. H5N1 first detected, like we said, in the US in wild birds in 2021. Began in commercial backyard poultry shortly after that. In March of 24, it was detected in dairy cattle in Texas and Kansas, and now we have 17 states, that have dairy herds with H5N1. Since April 2024, CDC's reported 70 cases of human infection with H5N1 in the United States. Now, 41 were exposed to dairy cattle, 25 were from poultry or culling operations, 2 from wild birds, and 3 unknown. There's been no documented, again, human-to-human transmission. Okay, I know this talk's getting more and more circuitous and confusing, so I thought I'd add this slide just to top it off, okay? But if you look at the slide, if you start with wild birds here, I think it kind of helps, because it starts with the wild birds, right? They give it to poultry. They give it to cats. They give it to cows. Now the poultry can give it to people, right? The cows can give it to humans. We've seen that, poultry and to cats. There's not an arrow between cats and humans, but I was just looking at a recent study from the CDC where they looked at 150 small animal veterinarians, and they took their blood and looked for antibodies to H5N1. And they found antibodies to H5N1 in 3 of these veterinarians. Now, these veterinarians didn't have exposure to dairy cattle. They didn't have exposure to birds. And so some people think that, well, it's probably from cats. Not proven, but it may occur. If transmission from cats to humans does occur, it does not occur very efficiently. Who's at risk for avian influenza? Well, contact with infected poultry, wild birds, or infected mammals, touch contaminated surface of dead or sick animals, then touch a mucosal surface on you. Liquid contaminated with virus splashes into eyes, nose, or mouth. Unpasteurized milk. Eat or drink unpasteurized dairy products. Inhale contaminated droplets. You walk into the chicken coop and the chickens are flapping their wings, aerosolizing all of this stuff. Prolonged close exposure to an infected person. The incubation period is 3 to 5 days. So clinical presentation of H5N1. Now, prior to the recent outbreak here, it was similar to typical influenza, only much more severe with a 60% mortality rate in H5N1 and H7N9, a 35% mortality rate. With the current outbreak here, like I said, most cases are mild. Conjunctivitis is the prominent symptoms because the virus is binding receptors in the conjunctiva. Some with fever, respiratory congestion, and cough. Now in North America, as far as I know, there have been reports of 3 severe cases. And the first one that I heard of was in December of 24, was an elderly man with reported comorbidities. It wasn't publicized what those were, in Louisiana, who acquired H5N1 from a backyard flock and died. Subsequently, about the same time, in British Columbia, there was a report of an 11-year-old girl. Now, the girl presented initially with fever and malaise. She didn't really have a lot of risk factors. She was a little overweight and had some untreated asthma, but she presented initially with a little bit of malaise and fever, then got the nausea and diarrhea, which kids often do, and then came back with a left lower lobe infiltrate and a white count of 0.7, very sick. They tested for influenza, and when they did, it came back influenza A, but when they subtyped it for H3 or H1, it was negative for both of those. So they sent it off to their state lab or to their province lab and found that it was H5N1. Now, the girl was very hypoxic. She was intubated. Despite mechanical ventilation, they could not adequately oxygenate her. So they put her on veno-venous ECMO. She was on that for 2 weeks, on the vent for a total of 3 weeks, was dialyzed for a month. She was treated with every antiretroviral you can think of and some you can't. And she survived, and apparently she's without deficits, so she made it through. The last report is one just more recent. Last month, Mexican authorities reported the death of a previously healthy 3-year-old girl in Mexico. And I don't think much is known or publicized about that case. I just want to step back for 1 second and talk about the outbreak in cows here. Until early this year, all of the strains found in cows were genotype 3.13. Okay, so all of them had that. Now in January, we saw in, I think it was Nevada, they did bulk milk testing. They found a different genotype, D1.1. And then a month later in February in Arizona, D1.1. Now the severe strains, or the severe infections in the human cases in North America, at least 2 of them, have been D1.1. So to me, that's a little concerning. Now, they've looked at these ones they found in cattle, and they don't generally have a lot of the markers you'd associate with severe disease in humans. But the fact that we're seeing different strains now, to me, is concerning. How are you going to recognize avian influenza? Well, the incubation period is about like regular flu. you need to ask, have you been around dead birds? Do you have dairy cattle? Do you have chickens? Look for appropriate signs and symptoms. Conjunctivitis is a very common symptom in this outbreak. Fever, sore throat, myalgias, diarrhea in children particularly. And then what are you going to do if you suspect that a patient might have it? Well, the first thing you want to do is get a mask on the patient. More important to do that than to put a mask on yourself, right? So get a mask on the patient, move the patient to a single room. And if you have a negative airflow room, that's optimal. PPE consists of fluid-resistant coveralls or gown, particulate respirator. You can use a PAPR. If you do use a fitted N95, probably a good idea to use a face shield. And of course, gloves. The CDC likes to say that protection can be enhanced with a head cover and a fluid-resistant apron. How are you going to test for it? Now, when we test for influenza, we send generally a PCR of respiratory secretions, right? And that PCR differentiates between influenza A and influenza B. It also will tell you if the influenza A is H1 or H3, okay? Now, so you send off your influenza PCR and it comes back influenza A, but it can't tell you if it's H1 or H3. It's negative for both of those, okay? You should suspect this could be an H5 or an H7, right? Now, usually in that circumstance, it's a false negative. And the problem is there just aren't enough viral particles, so it can't detect the H1 or the H3. But it could be an H5 or an H7. So you send it off, it comes back influenza A, but they can't give you the H type. You need to send it to the state lab for them to determine whether or not it's an avian flu. Does that make sense? Okay, good. Treatment, avian influenza treatment, ICU support, antiviral drugs, primarily the neuraminidase inhibitors. Also, oseltamivir is preferred. There can be resistance. Peramivir can be given intravenously if you can't give it orally. Zanamivir is given in inhaled form in this country, but there is an IV form. It's used in Europe. So baloxavir can be given also. Whether or not this is helpful, nobody knows. It really hasn't been studied, but the data says that the early treatment with neuraminidase inhibitors does provide benefit. How about if somebody's been exposed? What is post-exposure prophylaxis? And risk would be 2 meters unprotected exposure to a bird with documented infection. And that's not a law or anything. I always think, you know, we take these hard. Well, I guess I was 7 feet away. So I'm not. Suppose you're 7 feet away, you're in a chicken coop, and the dog gets in the chicken coop and they're going crazy and raising dust all over the place. Okay, 7 feet. You'd still want to check, right? So, you know, you want to use common sense too, of course. Close or unprotected exposure to a person with avian influenza, exposure to secretions of an infected person, and treatment, you want to start oseltamivir or Tamiflu as soon as possible and continue for 5 to 10 days. Now, prevention, vaccination. There are several H5N1 vaccines that have been produced. They've been stockpiled. In some countries, I think in Japan, they are actually vaccinating certain people. And one of the Northern European countries, I can't remember which one. It's uncertain how effective these are going to be because there can be, remember, genetic drift in the head of the hemagglutinin changes. Several H7 and 9 vaccines are being developed. But one important concept here is people who are at risk for bird flu, dairy workers, people who have chickens, you want to vaccinate them with the seasonal vaccine. And the reason is if they get seasonal influenza and they get the bird flu at the same time, we can have genetic reassortment and shift, genetic shift, right? And create a bad virus. So it's really important to vaccinate those people. Excuse me one sec. We're getting close to the end here, so just hold your breath, okay? I want to talk just briefly about the prospect of universal vaccines. I was just reading, despite what's happening in our federal government and our current Secretary of Health and Human Services, $500 million has just been earmarked for the development of universal vaccines. Now, how are we going to make a universal vaccine to the flu? Now remember, this is a picture of the hemagglutinin. And remember, the head changes every year, but the stalk doesn't. The problem is that our immune response to vaccine and to the natural infection is to the head. It's immunodominant. The stem is immunosubdominant. So what can we do to enhance the immune response to that stem? Well, one thing that's been tried is to make the stem that protein and leave the head off. But when that happens, the stem is misshapen and our immune system recognizes shapes, so it doesn't work. There are other ongoing trials where things are being done to enhance the immunogenicity of the stem. And there's one trial, I think I left the reference in somewhere, I think Krista has it, but that's a potential for a universal vaccine, because remember, the stem is conserved among all of them. It can't change, because if it does, the virus doesn't survive. Okay, another potential target is the M2 protein. Now, the M2 protein is 99% conserved among all influenza viruses, birds, humans, cows, whatever. It's just not very immunogenic. So what's being done is that protein is being combined with adjuvant molecules to help enhance its immunogenicity. So that's another concept that's being worked on. Okay, and we're just going to end here. I usually have a Venn diagram in every talk I give. Even when I gave a talk at my daughter's wedding, I had a Venn diagram like this. So pretty much everywhere. So you know, we worry about a pandemic or big outbreak, and we look at the three circles and where they intersect. Now, an avian flu is hazardous and it's infectious, but it's not very communicable. If we have that genetic shift and we get a communicable strain, then the area in the middle, novel influenza, could be a real challenge. So, and I think I might have one more slide. Yeah, and how's that going to happen? Like we said before, pigs are going to be the culprit. Well, there are other animals, humans too. But pigs harbor human strains, avian strains, they get infected. Thank you. With both genetic reassortment, you get that bad viruses that causes a pandemic. So that's it. Thanks for paying attention. I know that was a lot of stuff. So any questions, anybody?
We don't currently have any virtual questions in the chat, so please come up with your questions here. Yeah.
Diane?
I was curious, why do you think the Spanish flu targeted the young? What was different about it?
Okay, I'm gonna give you a circuitous answer. Do I have time? Yeah, I do.
Oh yeah, you do.
Okay. My son Joe, now that my youngest child, like I said, he's the one who came up with the title for this talk, and he's an endocrinology fellow at the Mayo. But when he was a boy, he would ask questions like, Dad, how come there are more stars on that side of the sky than that side? Dad, how come some people like vanilla ice cream and some people like chocolate? So I'd call those Joe questions. So Diane, your question to me is a Joe question. I have no idea. So sorry about that. I don't know. There's somebody has a question back there.
Oh, great.
So my question is about lab testing, because I don't know a ton about that, but are there like certain drifts or shifts that would allow viruses, either influenza or others, to like dodge our lab testing? And how does that work if things are coming up viral but negative for everything?
Well, basically, when you test with the PCRs we use commonly, right, it's going to tell you, is it influenza A or influenza B? Now, influenza B doesn't have, it's not typed. It only has one hemagglutinin and one neuraminidase. So influenza B only has one. So it'll differentiate between those. Then it will tell you if it's H1 or N3 reliably. If it says it's influenza A, but it's negative for those, you send it to your state lab. Now, it could be a false, like I said, a false negative where you just didn't have enough virus to demonstrate the H1 or the H3. But the genetic, the assays generally are not outsmarted by genetic drift and really by shift either, because it'll tell you if it's an A and it'll tell you if it's not a 1 or a 3. So they're generally not outsmarted. So it's a good question though. Another one back there.
Dr. Ruby.
Henry, I gotta say, I can get kind of nerdy, but that was like next level nerdy. But it was pretty fascinating.
Sorry.
Staying in my emergency management lane, I was kind of intrigued. Why do we see more Native American, Native Alaskan impacted by these influenzas? So as we're doing planning and stuff, obviously high populations in our region. So just curious if there's much more data or information on that.
I've got a 2-word answer for that Joe question.
I was afraid of that.
Yeah, there may be an answer there, but I really have no idea. Just different racial groups are more susceptible to different things. Like for coccidioidomycosis valley fever, Filipinos have a hard time with it. I mean, and there's, I'm sure, some immunologic predisposition that could be determined, but what it is, I have no idea. I'm sure it's there though, Daryl. So, anything else?
What other questions? Yeah, Lindsay.
I was just curious if you have any insight into why we haven't seen much change in the data, like change in numbers of infected humans over the last couple of months.
Yeah, I've been noticing that too, because I first was developing this talk several months ago, and there were 70 reported cases in the United States. And I looked the other day and there are still 70. I'm not a conspiracy theory guy. So, but boy, you guys are, this is strike 3 right here in questions. I don't know why that is. I suspect there have been cases and they've been probably subclinical that just haven't been found, but why more are not reported or more haven't been found? I don't know the answer to that. I don't think it's a huge conspiracy, but again, okay, that was strike 3. You guys are, my self-image is very tarnished. So.
Henry, I'm going to ask a question around screening, because I know that there's different types of screening out there at different facilities. But what do you think is like best practice for screening for H5N1 human cases when somebody presents to a facility currently?
You mean in terms of lab screening or?
No, like question screening, like as they present with symptoms, what kind of screening
the important questions would be exposure to someone with avian influenza, exposure to wild birds, and particularly sick birds, but they don't have to be sick. Remember, H7N9 causes infection and it's low pathogenic AI. It doesn't make them sick. Exposure to birds, exposure to chickens, backyard flocks. Exposure to other sick mammals. If you're at a dairy farm, you don't take care of the cows, but you take care of the cats, that sort of thing. So it would be exposures like that. People with it, birds, dairy cattle, and animals you might suspect. So those are important questions to ask.
I'm curious how many people who are here representing facilities, hospitals, urgent cares, are doing screening questions for H5N1 exposures. Anybody who works at Providence should raise their hands. I saw Lindsay did, but when I went and had my shoulder repair 6 weeks ago, they very diligent, and then they didn't know who I was or where I worked. It was at one of our other hospitals in town. And she did ask me exposure questions. I almost gave her a hug. I was like, this just warms my heart. Asked me if I drank raw milk or been exposed to dairy, dairy farms or cattle or birds. And so I was super excited about that. But yeah, Kelly.
Do you have a theory as to why so many influenza are first detected in China? Do you think it's population density? Is it advanced diagnostics and they're just testing more frequently, or any theories?
I think 2 things. I think bird exposure would be one, and the other thing would be population density. I said that the Spanish flu, most people feel that it really got it started in Kansas in the US, but there are some people who feel that it actually did get it started in China also. It's not known with certainty, but I think exposure to different animals, particularly waterfowl, much more so than here as in markets and in places like that, and then the population density. So I think that those would be the reasons. Anything else?
Other questions?
I've got some stuff from our virtual participants, and this is from Marley Mace, infection preventionist, and she's responding to the question about why younger people died during the Spanish flu. And it is some immune factors, and there's some theories that younger adults, those in their 20s and 30s, died at a higher rate during the pandemic because they hadn't been exposed to the version of flu virus before. This meant that they didn't have immunity, tools in their body that they could use to fight the infection, like antibodies, so that particular virus. Other theories suggest that their immune systems overreacted to the virus, like a cytokine storm, damaging healthy tissues in the process.
Yeah, those are both really good points. The thing about the Spanish flu is that is mostly ages 15 to 34, and the below 15 weren't as affected. So the theory that it's that the older people have seen a similar virus before, so they have some immune response to it, I don't think holds water as well there. Now, the swine flu outbreak in 2009, that predominated in children, and that's exactly the reason, is because older people had seen viruses that were somewhat related, so they did better and predominated. The potential increased immune response with cytokine storm, yeah, that's possible. In the girl who was infected in BC and almost died, the 13-year-old girl, another thing they did for her is they put her on plasma exchange to take the cytokines out of her blood and then give her back her plasma. So plasma exchange was done too. They did a lot to save that girl. So the cytokine theory, it may be correct, but I don't know the answer. So,
and I've got a couple more from the chat. What are the thoughts behind the decrease in mortality of H5N1 from 68% mortality to mild disease, i.e. conjunctivitis? P.S. I'm hoping the decrease in human avian influenza in the U.S. is due to better biosecurity in the agriculture. The USDA is doing a lot of work to control.
There are certain markers on these viruses that make it more likely that they're going to be severe in humans. The fellow who died in Louisiana, they looked at that virus, the H5N1 virus in him, the D1.1, and they found markers in that virus that made it more likely that it would cause severe disease. The ones that are going around now, and the D1.1s that have been found in bulk milk testing in Nevada and Arizona, they haven't had those markers. So I think it has more to do with the particular virus and its markers of pathogenicity. So we just haven't come across really bad viruses. Now, we certainly could, but these viruses just don't have the typical markers of the ones historically we've seen that have caused the 60% mortality.
And one last question. Do you think there is still benefit to testing all admitted patients with positive flu A if they are negative for H1N3, like the CDC recommends, or is there a patient population that you would recommend?
I think because some people, like the girl in BC, 2 patients from the US so far, or I think 3 actually, come down with H5N1 without known risk factors. I think anybody who has a positive influenza A, but negative 1 and 3, it should be sent to the public health lab and determined whether or not it's bird flu. That person should be in isolation in a negative airflow room, and proper PPE should be used. So, okay.
Okay. Thank you so much,
Thanks
Henry. Yeah. Thank you. Okay. I gave myself the impossible task of tackling category A waste in a 30-minute time frame. So our team, when we were talking, we knew we wanted to dive a little bit deeper into category A waste, which is always a request from attendees, but always a risk, because it's kind of like if you start to dive into it, where do you stop? So I'm going to do my best to try to address the really key things that we think are important, and we've deemed through our multiple years of trying to figure out this category A waste challenge. And so our team wanted to come up with a catchy name. Daryl, our regional coordinator, He always wants us to come up with a really cool exercise name. So getting an A in category A waste was Sarah Emerson. She's our, oh, thank you. Yeah, she's got her hand wave there. She won the contest for the name title for this talk. So we'll dive in here. So some of the objectives. We're really just going to define category A infectious substance, what a category B infectious substance is, and then regulated medical waste. So what are those differences? Talk about the federal guidance for category A waste management. Talk about the roles that federal regulatory partners and waste vendors have. Talk about operational considerations. Do you have the right stuff? Do you have the right space for managing Cat A waste? And then really dive into those priorities for frontline facilities and developing a plan. Okay, so, and then I want to say, is Carrie in here? Carrie Brouillard there. Okay, so Carrie over here is our laboratory coordinator. And so I may defer to her for some of your questions when she's taken a lot of deep dive into laboratory category A waste management. So category A body secretions mixed with chemicals in laboratory platforms or whatnot. So if you have any of those really type of complex questions, we have Carrie, we have all sorts of, yeah, Juliana's here, Kelly's here. So we've done a lot of deep dive into that. And so we'll talk about that as well. So a category A infectious substance is really a material known or reasonably expected to contain a pathogen that is in the form capable of causing permanent disability or life-threatening or fatal disease in otherwise healthy humans or animals who are exposed to it. And I just highlighted a few. So if a pathogen is categorized as a special pathogen, it may not have category A waste, and it may not be a select agent, or it could be all three, or it could be one or two. So if you see there's some, I did just a few examples, Ebola virus disease, Marburg virus disease, both considered special pathogens. We'd put in our biocontainment units. Both are category A waste. Both are select agents or special agents or toxins. What's the right? All select agents the best. Okay. Middle Eastern Respiratory Syndrome or SARS. Some people might put those in their biocontainment unit, some might not. Neither one are category A waste, but SARS is a select agent, MERS is not. And then Brucella, just the cultures are category A waste. There's other pathogens as well that have that same categorization. And so just kind of understanding the differences with some of those pathogens. So over here, the document managing solid waste contaminated with a category infectious substance, I have nicknamed it the Bible of category A waste management. I have spent probably more time reading it than I would have cared to or ever would have thought, but it is the comprehensive document that really guides the federal regulations around category A waste management. I don't know if you can see all the icons of the different federal agencies that contributed to the writing of this document. It was last updated about a year ago. And so I will be referencing this quite frequently, but this would really be your go-to document when you're trying to figure out certain things with your category A waste management. So just to differentiate, category B infectious substance is an infectious substance that's not in the form generally capable of causing permanent disability or life-threatening or fatal disease in otherwise healthy humans or animals. And then regulated medical waste. Some people like to say category B and regulated medical waste are the same thing, and they're not. I have learned this from Carrie. Very, very important distinction. Waste or reusable material derived from medical treatment of humans or animals, including diagnosis and immunization, or from biomed research, including production and testing of biological products. So What we're really going to focus on is category A waste guidance. And these are some of those planning considerations. So that document, so really the regulatory aspect is controlled by the Department of Transportation and the Pipeline Hazardous Materials Safety Administration, or PHMSA, you'll hear me say, because I don't want to say that every time I talk about it. But they categorize the waste at the federal and international levels, and then special permits are released from the DOT and PHMSA that are required to transport category A waste, and we'll talk about those too. We're going to talk about what additional state, local, tribal, and territorial requirements for handling, packaging, and storing may be in place where you live. That would contribute or expand upon the federal guidance out there. Talk about public health or environmental health agencies. I know like things that our state requires us to do very different than the state of California, where Jonathan is. And so really those state requirements can be very different from state to state. And then waste vendors can really be valuable partners in navigating those intricacies of local regulations and packing requirements, but they may also have additional requirements for packaging that would trump whatever your local or your state or the federal regulatory guidance is. This hyperlink here is a newer resource on NETEC that's really a condensed version of key takeaways on managing special pathogens waste. So it will be included in the slide deck. So here are different waste management options, and Jonathan touched on some of this. Autoclaving, so inactivating that waste on site in your facility. Some of us have that capability, most do not. Incineration, I still think the only place I know of that has their own incineration is at UTMB in Galveston. So we're all jealous of them as the Region 6 RESPEC because they can just burn it all. And that would be a nice capability to have. Alternative methods, chemical disinfection, are called out in the DOT document. I'm not going to talk about that. And then I just listed some of those human pathogens that are category A waste, some of those common ones that we were talking about when we think of what would we see in our biocontainment units. Brief planning considerations around autoclaving. And so I know we have some attendees and there's quite a few Sani packs, which are the larger, more industrial size sterilizer compactors. That's what we have. That's what they have at Cedars. I know quite a few partners up in Alaska have them. Harborview has one. And so they're scattered throughout our region and across the country. And then some places have in-unit pass-through autoclaves, much smaller, but are actually in their unit. Function the same way, a steam under pressure cycle. The CDC guidance says, and also the PHMSA document says, basically you need to run that waste greater than 120 degrees Celsius for at least 30 minutes. But the time and temperature can depend on the type or the state or the volume of that waste. And Dr. Grimes mentioned that as well. So if you have a saturated load of wet linens that you need to throw into your autoclave versus a bag of dried gowns and gloves and masks, could take a different amount of time and temperature to assure that you have inactivation. And then having a validation process for those inactivation procedures that are outlined by either the manufacturer or by your state, local, tribal, or territorial requirements. And that's where it gets very different. Our state, the state of Washington, does not have any additional requirements for us around inactivation of category A waste. Jonathan would like to say the same thing, but he cannot. They have a very different set of requirements from the California Department of Public Health. So really knowing what your state requires, and those are all addressed in the Bible of category A waste. There's a whole table at the back that for each state, they highlight the website and a phone number. I didn't call them all to see if they're accurate, so I take no responsibility for that. But there is a reference for each state on who to contact at the state level around what those requirements may be for where you live. Using a biological indicator, and then considering if you have chemicals, are you allowed to put chemical waste into your autoclave? That can create a lot of different waste stream pathways when you're talking about the waste generated inside a hospital room, and we'll talk about more of that. So having a validated cycle, I will just say, please, if you have questions about that, if you have any sort of an autoclave, happy to dive in deeper with that. We've done a lot of work with that on developing a validation process for ours. Having training in place for whoever's going to run that autoclave and what PPE should they be wearing, and then having a well-defined route internally so that waste of wherever it's been packaged, getting to that autoclave, having a secured route for that, and then having a storage area. I think we've done our best planning, but I do think we're going to generate more waste than we realize, even though we've been saying that for 10 years. I think how fast we can process it through our Sani pack won't be as fast as I think so right now. So where do we have adequate space to store that waste until we have the opportunity to really inactivate it? Okay, off-site inactivation planning considerations. So this is if you are going to package and store that waste and then ship it off with a third-party vendor. So the special permit 16279 permit is the one around the category A waste pathogens that PHMSA has issued it for. So you will hear from Mike on this, but up until November of last year, this permit was released for Ebola and Marburg. And then now losses on it because we had a Lassa fever case here in the United States. This is the only active permit for special pathogens waste. It was last updated on November 4th of last year. So if a patient presented with a different category A waste pathogen, a vendor would have to apply for a new special permit for that pathogen. The DOT and PHMSA would fast track that application as needed. And what waste vendors can proactively apply for, and they will grant special permits when there's an identified risk. Now, one thing I'll call out here, so I put the hyperlink to the special permits database, which takes you to DOT's website, and they say, here are the vendors that have SP 16279 issued to them. And if you have Stericycle as your third-party vendor, you will not see their name, and that makes everybody get a little nervous. And what I have found over the last couple of years, and we found out on a call with our Stericycle vendors, is that they're like, oh, we outsource that to Clean Harbors now. So even if your waste vendor is, you have their name, but they don't show up on that, that doesn't mean that whoever they contract with for their category A waste doesn't have that permit. So it can just take a deeper dive and really finding those key points of contact. Planning considerations. So do you know for your vendors who will be doing? We just kind of talked about that. And if you don't, do you know who to contact in your facility? I know I've been talking with Chris from Samaritan and Moses Lake, whereas they're doing that right now. They're a level 4 facility in the NSPS structure, and they're trying to validate their category A waste plan if they have a patient. And so sometimes it could be your environmental service leader. It could be your facilities leader within your organization. So just really finding out who knows and then finding that right point of contact to really find out what the capability is. Is your vendor able to sign on to party status? We're going to define that in a minute. And do they provide the required packaging materials and supplies? If not, do they have specific requirements for you beyond what the permit outlines as how you have to package that waste? And if yes, they do provide them, what's the turnaround time for receiving those supplies? So just knowing, do we need to have some things on site? Or, Mr. Representative, if we call you tomorrow morning, can you get stuff to us in less than 24 hours? Those are the types of things that I think are really valuable questions to discern with your waste vendor. Party status. So while a single waste vendor initiates the application for that special permit, others may be granted party status. Not really the kind of party any of us are very excited about, but that makes them a grantee. So then the waste vendor should have both the special permit and the letter granting them party authorization available to facilities. So available for you to see when they come to you to pick up your waste. Not all special permits allow party status, but SP 16279 does. Okay. So we've checked off a couple of those planning considerations. Now let's talk about state, local, and tribal and territorial requirements and public health or environmental health authorities. So I know, so this is a screenshot of just a very small screenshot of that appendix that I talked about that's in the back of that document. So here, I know you guys can't see it, but it just says the state of Alabama, what's the agency with waste management, program management responsibility, what's their phone number, and what's their website. So it's a great place to start to find out what is your state requirements for category A waste. I even put the page numbers for you on there. So 103 to 106. So, but they may have input. I would say if you're creating a plan, involve them sooner rather than later, and coordinate with your local public health agency as well as your state. And especially Dr. Grind called this out, but on your liquid waste. So can you flush bodily fluids that have category A, if from a patient who has a pathogen with category A waste, or can you not? Do you need to pre-treat? Or are they going to make you solidify all liquid waste? And if you have an autoclave, are you able to get kill in that solidified waste? There's a lot of, this is where you could just keep going and going. But I think it's important to really partner with your local public health as well, that they can help connect you to your local wastewater company. Okay, let's talk about different waste streams. So laboratory, and so this is where I'm going to keep looking at Carrie to make sure I get it all right, but specimens should not be put into a sample storage inventory. And considerations are equipment that's plumbed directly to the drain. So that kind of goes back to that, just knowing that the liquid waste management plan and what those guidelines are for your local area or for your state. And then do you have a plan for disposing of lab chemicals if they're mixed with a category A waste pathogen? So in the state of Washington, I think one of our challenges we found is that we can only put sugar or salt down the drain. So that means saline or dextrose, D5. And we can't put any pharmaceuticals down the drain. And so we have different waste streams for different types of pharmaceuticals. And so we've had to figure out and we can't put those in our autoclave. Our Department of Ecology said, no way, no pharmaceuticals can be autoclaved. So then we have to figure, and then our third party vendor said, we're not taking that container with pharmaceutical waste in it if it's ever been in a room with a patient. So then we're like, oh, so those are the types of challenges that I think it's really helpful to know. Start with knowing what your regulations are, and then reach out to your local regional treatment center in your region to help you figure out those different strategies for those different waste streams. And so So don't feel like you have to figure all that part out on your own, but you need to know what you're responsible for if you get a patient. Carrie, would you have anything you'd add? No? Okay. Batteries or other durable items. Obviously, we're not going to chuck a battery in our autoclaves. So do you have a process for decontaminating and moving out of that contaminated zone so then you can either discard or recycle it according to your normal processes? And sharps the same way. Packaging sharps in an FDA cleared sharps disposable container and make sure it's securely closed. But then you're going to need to talk with your waste vendor about how they want that packaged as well if you're doing the package, store, and ship. So you can see my takeaway. Check with your vendor, check with your state requirements regarding all those different waste streams so that those can be anticipated. All right, we've checked off those 4 things. Now let's talk about really navigating packaging requirements and regulations. So planning for implementation in your identify, isolate, and inform process, having a designated space and designated protocols, minimizing what goes in and what enters the room, pretty basic. But when you think about people changing out of their PPE ensembles every 3 to 4 hours, taking an IV bag and tubing out of their packaging before you pass them into the room is going to pay off down the road, because you're going to have, I know when we do training and we don and doff people, we've come to some of your guys' locations and done a lot of training with a PPE stations, and you think about the amount of waste that's generated during that. Anything you can do to minimize the volume of waste is going to be really beneficial. Verifying those specific packaging requirements with the vendors. So you'll see what the special permit and the DOT documents say on how to package, but then you also need to find out, how does your vendor interpret what they say and how you should package that? And they may provide you with the exact type of liners or bins or barrels that they want you to use. And so staging those prepared barrels in a clean zone, securely packaging that waste as close to the source of generation as possible, safely moving it to those prepared barrels. So a process of moving it from a more contaminated area, cleaning it and packaging it to it gets to those prepared barrels, and then sequester it securely until you get that result of a presumptive positive or presumptive negative. Don't label anything category A until you know it's category A, but you need to have a secure place to store it until you get those results. And we're going to look at Dr. Grind to get us that testing gap fixed so we can deal with the waste quicker, right? Okay, planning. Do you have the right stuff? So this is verbiage. I can't remember which document it's from, but this is what you have to have. It's either written out in the permit or it's written out in the DOT document, but you need to have 2 plastic film liner bags compliant with ASTM D1709, which is a tear resistant test. And then also D1922, which is an impact resistant test. So these are categorizations of red biohazard bags. You need to have ones that meet those 2 tests for packaging that waste. And then they want an absorbent material in the bottom of the barrel between the outermost liner and the plastic barrel. But if you're using a cardboard barrel, one on the right here, then they want the absorbent material within the outermost liner bag. So those are some of those specific things of just understanding how to package based on what materials you have. And then the outer packaging, so that third packaging can be a barrel or a corrugated fiberboard, 55-gallon maximum capacity. And then a lot of times the vendor wants those 55-gallon drums to then go inside a 96-gallon drum before they're put in the back of the semi that they're going to haul it off with. So that's another, I didn't put that in the slide, but another thing that may be a requirement of your waste vendor. If you want strategies on how to get a 55-gallon drum full of Cat A waste into a 96-gallon one, we've talked about a few ways to do that. So happy to have that discussion. It's not pretty, but if you have larger items, they should be discussed with your vendor and with the Department of Transportation. Thank you. Wow. Planning, so the right process. So we talked about packaging it at the source. Double bagging is recommended. The absorbent material we talked about. They use the terms primary bag and secondary bag to assure they're sealed and disinfected or clean on the outside. And then the outer packaging is that rigid 55-gallon drum. And so this is just a picture of a job aid that we've created that we've shared with many of you during our frontline facility preparedness courses that just talks about options for consideration for packaging that waste. And then having the right space. So really these 55-gallon drums are big. So and I think this is one of the largest challenges, especially for frontline facilities. If you're going to shut down a couple of rooms, like, do you have space to store a number of these 55-gallon barrels until you know if you need to transport them with a vendor? And then having controlled access to wherever they're stored. You really do not want to have unsuspecting EVS workers go grab that waste and take it down to the loading dock, right? So how do you control access to it and have it be temperature regulated? Okay, these are the two main resources I've talked about for your reading pleasure. There's a whole lot of details in there about how to kind of create a plan. And there's some nice algorithms in as well. So don't be intimidated by the number of pages in the document. There are some really good like question and answer things on how to create a plan for category A waste. Whew, how'd I do? Slid under the wire. Do we have any questions?
So I am with you guys today from a non-hospital health organization, and I'm looking at this from the point of view of someone who would likely or is likely to be like a first point of contact for some of these patients. What are some preparedness activities that you could recommend from kind of this point of view?
Not specific to category A waste or specific?
Specific to category A.
Okay. Can I ask you where you work?
I work for Chaz Health, and we have a couple of like urgent care specifically that I feel like are high likelihood to be first point of contact for something like this.
Sure. Yeah. Great question. I think really just that focus on as far as regarding waste would be really having biohazard bags I'm sure you have biohazard bags available, right? And so and I would like to think that the likelihood of someone presenting to your facility is going to be on the less sick side than on the most sick side, right? So just having an ability to safely package that waste, double bag, tied off, and we can talk to you. I can send you some resources offline as well that would give you that guidance. But I think knowing how to package it at the point of inception and then a place to hold it until you can figure out further, is this somebody that we really need to be concerned about to go down this certain pathway? For sure. And so happy to share those resources with you. And then I think Drew's in here. Drew? Yeah. So knowing your Spokane Regional Health Department key points of contact as well, that they'll be a great link for you in a reach out, because if this is somebody that could have a potential special pathogen, you're going to be talking to them anyway, and having them connect you with resources as well of all those specifics will be important. I don't think you need to go out and buy 6 55-gallon drums and have them in the back of your facility, though. Yeah. Yeah. Oh, man. Yeah. Oh, Adrian.
I think you shared this and I missed it, but what are you using for the absorbent material that goes in between the bag and the drum?
Oh, yeah. It's vermiculite. Yeah. And they call that out. It's easy to find. Amazon, but I know that you can get it from waste vendors too, but it's not hard to get your hands on.
You'd kind of joked about managing these barrels, but I tried to manage the barrels empty and it was a little bit of a mess. So I was curious, do you guys have a written process for how the barrels are managed when they are full and how they get into the next step, whether it's a different room outside of the unit or outside, and how that's safely done ergonomic wise and to reduce any potential spread?
Yeah, so we had them pre-positioned on big carts. So we've transitioned to our Sani Pack process, but we still have that package, store, and ship process. So we had a cart that 3 of them would fit on, and we would just kind of transition them from, we never put the barrels in they were always in a clean space. So once they were full, we worked with our EVS department to do an exchange of 3 clean barrels to 3 full barrels and trade those off and then transport them down to people. And they're clean on the outside. They have a locking lid. So they would wear gloves and transport them down to our loading dock. And we have a pre-identified space that we can lock down to store those drums in. They're not easy to, that's why we kept them on a cart, and then they would just kind of shimmy them off into the space. As far as getting the 55s into a 96, I mean, that one's a little harder, but I'm happy to talk to you about that. But you're right, they're big and cumbersome. Yeah. Any other questions? All right. So Diane's going to come up here and change out the slide deck. And it is I got to put my glasses back on. It's my honor to introduce to you our colleague, Mike Hartley. He is retired as University of Iowa's Healthcare's Emergency Manager in 2021 after 30 years working for that institution. And as a member of the leadership team for the University of Iowa Special Pathogens Unit from its inception in 2014, he served as its operations manager working with a multidisciplinary team overseeing the design and construction of the unit. Do you want to do this while as well as managing the quarterly training of the unit's core team and conducting annual exercises. At the onset of a recent SPU activation for the management of a Lassa fever case, he was asked to return to University of Iowa and serve in a consulting role. So I think, Mike, the first time I met you was in 2016, and our colleague Angie out of University of Nebraska Med Center, we were just trying to figure out our program, figuring out our doffing protocol, and she said, let me connect you with my friend Mike, because you guys have a similar PPE ensemble. And so Mike, this was before we lived on Zoom. I think we sent pictures back and forth and talked on the phone, and he showed me their process of how they disinfected and rolled up, he called it the Iowa roll up of the Papper hood. So we are exceptionally grateful that Mike came all the way here. After speaking at Cedars last week, he took a tour of the Pacific Northwest, and we're very grateful that he joined us to share their really valuable lessons. So please welcome Mike Hartley.
Well, good morning, everyone. Boy, you know what? It's been a long morning. Everybody stand up. just give your posteriors a little bit more circulation before I get started, because I know how these things are. And boy, I congratulate you. Great venue, great symposium. And really like to thank Krista for inviting me out, and Dr. Grine and Jennifer for inviting me down to Cedars. Really great opportunity to see how other units in the country operate. I'd only been to Emory and Nebraska, and so coming this direction is very educational. Okay, you can sit down now. Hopefully you've feel more, I guess, perfused. So, geez, you guys, I listened to a lot of the things that I heard down at Cedars last week, and I listened this morning to the discussions you were all having. My God, I think our case in Iowa is a poster child for just about everything you folks have been discussing, both good and perhaps bad. Okay, so this was a challenging case. The last thing we ever expected to walk into a clinic in the state of Iowa. But as Dr. Grine mentioned this morning, this may be the most exportable viral hemorrhagic fever type that could actually make it into this country. And so, I'm going to share with you some of the ins and outs of what happened with us, a little bit about our case, how we managed it, the challenges we faced, and maybe you can identify with some of this stuff. And hopefully, you can get some sort of benefit from learning how we did things or what we experienced. So first of all, a few disclosures. I have nothing to disclose. But I am a recent retiree, so things that I might say over the next hour do not necessarily represent my former employer. Okay, so these are my own feelings, my own observations, and so please don't hold the University of Iowa accountable for any of those things. And actually give a shout out to Dr. Karen Bruss. She's our lead epidemiologist. Her and I partnered on this case, obviously, and we partnered on a presentation we did for Massachusetts General out in Region 1. So I thank her for doing things with me. All right, so Iowa. I'm curious, how many of you folks have ever been to Iowa? God, more than I expected. That's amazing. I don't know why you would come to Iowa. Maybe family or something. Not exactly a vacation haven, in the United States. But, what can I tell you about Iowa? We are a Midwestern state. We are in Region 7. Region 7 comprises Nebraska, Iowa, Missouri, and Kansas. And obviously, the University of Nebraska's Medical Center is our respect. And oh my gosh, Kristen named it. I've been there so many times, and they've come over to help me so many times over the last decade. We have this incredible relationship with Nebraska. And boy, I'll tell you what, did it pay off. It paid off in spades. And so my message to everybody out there listening is that you need to have that relationship with your respect. Get that established, maintain it. We maintained it, and we were very close for the last decade, and all it took was a phone call, and we got incredible assistance with the case we've had. And so what was fortunate is that the people we had come had actually had experience in taking care of viral hemorrhagic fever cases. And so, when those people walk into your unit, I have to tell you, it was phenomenal. And so a little bit about Iowa. We're not very big. We have more pigs than we have people in our state. We've got about 3.2 million people. Okay. And my understanding is that there are conclaves of people who emigrated or come over from West Africa. And apparently Iowa is one of those states that they picked to emigrate to. Didn't really know that so much until we actually had this case. But at any rate, I come from an academic medical center, the University of Iowa Hospitals and Clinics. We are an 860-bed academic medical center. That's our mothership. And we have 2 other hospitals in the community as well. We are state-owned and operated. We're the only one in the whole state. And being an academic medical center, when things sort of rolled around in 2014 with Ebola and whatnot facing the entire country, you can kind of understand why we made the choice to try to pursue making this capability happen. And so, quite a few people have been to our state, which is great. Here's a question. How many people know who this person is? Seriously. Okay, a few more. Caitlin Clark. Yeah, if you watch basketball, Man, I'll tell you what, she played just yesterday, as a matter of fact, at our home court with the Brazilian national team being the first off-season, or I guess preseason game for the Fever. Pretty cool. I've been to games. I mean, she's probably the most noteworthy export that we've got in this country right now. And what she's done for basketball in general and women's sports is just phenomenal. And I remember I did see one of her games her senior year. I had courtside seats right up by the half court line, and I was just sitting there right near the logo, and she's standing in front of me practicing these threes. First off, I stood up because I wanted to see how tall she was, because she's kind of tall. She's about 6 foot, taller than me. And so I tell you what, watching her drain those threes in practice, the girl is legit. Okay, this girl is a phenomenal thing. So anyway, we appreciate the opportunity to be able to export her for the rest of the world to enjoy. All right, so our facility is kind of an odd thing. I worked a lot with, we're the first in the country voting kind of thing. We've had that moniker over the years. And so working with lots of folks coming into the state during presidential elections is kind of the thing I dealt with a lot as emergency manager. So dealing with the Secret Service and the White House medical team and all that kind of stuff. And I can remember when those folks show up and they look at our place and go, "What the heck is this thing doing in the middle of a bunch of cornfields? This is an urban medical center." I go, "Yeah, that's true." People don't expect to see the kind of thing we have in Iowa, but I was just fortunate to be part of it for the last 30 years. Now, I told you that, 2014 was kind of the instrumental year for us all to get into this business, right? And we were no different. And so my leadership came to us and said, "Look, we're about the only folks in this state that could possibly deal with a viral hemorrhagic fever." So our team was tasked with trying to create the environment to be able to take care of these patients. Now, we had the medical knowledge, we had the technical capability and all the, sort of things that you need to do that kind of care, but we certainly didn't have the safe environment like a biocontainment unit to do this kind of care safely. And so our job was to create that. And so I think probably October of 2014, as maybe Dr. Grind mentioned and others, that was probably impetus for stuff to really accelerate after what happened in Dallas to really make this capability for real. And so we worked very diligently. It was the most intense time I can remember before the responses of late in my preparedness career. I've never seen so much money go out the door in a short period of time. It was amazing. But by about mid-November, we felt that we had something that could be possibly approved to be able to take care of a viral hemorrhagic fever. So we invited the state in. They came in first, spent a couple of days, give us that virtual colonoscopy for 2 days, to kind of see if our unit's set up right. And then they said, "Yes, we think you guys are ready." So we were designated as the state's only Ebola Treatment Center, ETC. That's what it was called back in the day before the National Special Pathogens System program that you're being taught about today. And so by February, we had a visit from the CDC. The CDC back in those days had what was called a REP team, Rapid Ebola Preparedness Team. So they were going around the country, going to state designated centers, verifying whether or not they had the potential capability of safely caring for viral hemorrhagic fever. We were the last hospital in the country to be visited by that team. And that was the second week in February, and I remember this well. So they left on a Thursday or a Wednesday or Thursday after spending 2 days with us. They approved us, and then that Friday, the CDC published a list on their website of about 20 hospitals, and yours may have been one of them, that was actually designated as an Ebola treatment center. We were not on the list. Back in the day, though, if you remember, that a lot of administrative folks weren't real thrilled to have that moniker tagged to them. You know what I mean? There was a lot of scary things coming out into the public. The public was kind of thinking, "Oh, I don't want to go there." So our leadership wasn't really all that upset that we didn't make the initial 20. We were fine. So we're flying under the radar, okay? But the good news with that is that because we were approved and had a successful rep team, Region 7 out of Kansas City, those officials came to us and said, "Hey, since you guys had a successful rep visit, would you be willing to serve not only the state of Iowa, but would you serve all of Region 7? Because there is no other treatment center other than Nebraska." And we thought about it and said, okay. So that made us eligible for funding. And so funding was now made available to us. So over the next probably 5 years or so, we were able to make the biosafety enhancements that a biocontainment unit should have. And I sort of led the way on that. And I have to thank Dr. Phil Smith out in Nebraska. He was our mentor. Him and a couple of the other docs helped us design and build into our biosafety improvements. And so by March of 2020, we felt, actually February of 2020, we felt we were done. Money sort of trickled in. Our institution gave us quite a bit of money as well. So the several $1,000,000 that it's needed to convert a unit for biocontainment care eventually, was used, and we created our unit. And so NETEC came in February of 2020 and visited us, did that 2-day visit with us. And I remember Dr. Laura Evans out of Bellevue. She's now out here in Washington. She led the team that came in to look at us. And they basically said, yeah, okay, you're approved. You're now a level 2. And so 1 month later, we got the first COVID-19 patient admitted into our unit that popped up in our state. And so we had our first COVID patients come in. And then, of course, the rest of the story. We all got overwhelmed. And so, present day, what we are is a level 2 special pathogens treatment center backing up the University of Nebraska in Region 7. And as you may also know, the University of Nebraska has the country's only national quarantine center. How many knew that we had a national quarantine center? Not very many. So they had some additional monies given to them, and they built a beautiful building right next to their medical center. And in that unit, in that building, is a 20-bed, you can kind of consider it like a motel, but it's a biocontainment motel. They don't do treatment there, but they can do testing. They have an autoclave. They create a biocontainment safe environment to put somebody in who might need to be quarantined for up to 21, 28 days, whatever it might be. If they do become sick after a significant exposure, then they can be immediately moved into their biocontainment unit, or they could be sent to us. They could be sent to Minneapolis. They could be flown to you guys. And so it's just hard to say, but it is nice to know that we do have a facility like that. All right, so a little bit about our unit. We are not unlike a lot of units, like Cedars, for example. They don't have dedicated space. You folks here at Providence, you are so lucky that you've got a dedicated unit. 8 of the 13, it's my understanding, respecs in the country actually do not have dedicated space. They actually have to be converted, and that space is used for something else when there isn't a special pathogens case. So when I learned that, I didn't feel so bad that we don't have a dedicated space. Now we're going to have a dedicated space, I think, in about 5 years. They're rebuilding our ISS division towers, intensive cares, and whatnot. So they are going to build a new space, is my understanding. And I'm not going to be around. I hope I'm alive to see it, but I am not going to come back for a 4th time out of retirement to work in it. All right. So, what we've got are 4 rooms. 4 rooms that are within a 36-bed surgical and neuroscientist intensive care unit. These 36 beds are constantly occupied. They have the sickest adult patients of our entire state or a region that come to us. People either go to Mayo or they go to us. That's what it kind of boils down to in the middle of the country. Okay. So what we have is to start with, there was this separate 4-bed pod that was on its own air handler. Just so happens. And it's exhausted out to the rooftop, 25 feet from anything else, HEPA filtered. So it was kind of like the ideal space to convert for biocontainment care. Now, that 4-bed unit was easily locked down, and it was, it's not a large space, but it does have 4 patient rooms. And we figured we would have 1 primary patient room, which is what you see here at the bottom on the right. And then we would have a secondary room, but we would only like to offer the region 1 bed, if at all possible. I like to keep that 2nd bed for one of our own. If one of our own gets exposed and potentially becomes ill, I don't want to ship one of our nurses, RTs, physicians, whatever, to Nebraska. I want to keep them. And so we kind of like to keep that bed empty and not have it for anybody else per se. The other two rooms, which we can use for airborne, I mean, we filled this unit up quickly with COVID. The other two rooms are to support biocontainment operations for viral hemorrhagic fever. We have one room, as you can kind of see off to the right here, with little red dots. We have rolling red bins that we stage our waste there before it's autoclaved. There's an anteroom between the main room and that room, as you can kind of see. And then on the opposite side of the unit, we have another patient room that we convert into an in-unit laboratory. So we have laboratory space. There's an anteroom that serves that space and the spare room next to it. In the center is the warm zone. That's the nurse's station. And so they have good visual eye contact through sliding glass doors all the way around to see our rooms. And then what we did was I chose a large pass-through autoclave, same ones I had at Johns Hopkins. Shout out to Dr. Garibaldi for helping me with the settings and that sort of thing for our biocontainment autoclave. So we have a pass-through biocontainment air autoclave next to our staging room that we move the waste into and autoclave it. We can do about 3 bags, probably 3 red bags per cycle. So it's not huge, but we do have that capability. And then on the other end, on the right side or left side of your screen, we were able to construct a shower out decon facility. And so when the staff leave, they doff completely, shower out, and then go into a changing room to put clean gear on. And like with Krista, I'm sure, and the other biocontainment units, nobody's allowed to wear their own stuff. All jewelry comes off. Their undergarments are provided by us and are disposable. Our scrubs are, quote, disposable. And so everything gets doffed into red bags, and they end up going through the autoclave before they leave. And so they're not allowed to wear anything out. We have these cool little plastic shoes that they wear. They're double bleach dunked, put back on a shelf in the cold zone for reuse. So they never leave the unit. So that kind of thing. Now, with all of those facilities, then we have an activation time because generally, there are 4 patients in this space at all times. It's very rare that there's an open bed. And so to convert our unit to biocontainment care, it takes about 4 to 6 hours. That's the best we can do. Sometimes it takes longer. Maybe we have a hard time getting patients moved out, found other ICU space within the facility, but about 4 to 6 hours. This is a photograph. Pretend you're one of my core nurses or core team physicians. You're standing in the doorway to go shower out. You're going to doff. You turn around and look back. On the photograph on the left side, that's our cold zone, and that's where people get their gear on, get their PPE on, etc. And as long as you don't go past the red lines on the floor, you're good. As soon as you step across that line, you have to be at minimal PPE. Okay, minimal PPE in the nurse's station is generally our scrubs, our shoes. You wear a gown, they have gloves on, and they generally have a mask on, not a N95 in this case, but generally a mask. And we also encourage eye protection as well, just to be wearing in the nurse's station to create an environment, kind of a culture that you just don't touch your face. You don't do anything up towards your face. So when they work in the nurse's station, that's how they're garbed. And you can kind of see across the way there, one of the main room and the anteroom next to it where we put our patients. All right. So the clinical case, this is what walked it back into the state of Iowa, and this caused us to activate our unit for viral hemorrhagic fever for the very first time in its history. And so I'm not going to go through a lot of the things that Dr. Grein has already gone through. Clearly, Lassa fever is the most exportable viral hemorrhagic fever that we might see come here into the United States. The whole thing about rodents is a cute little mouse. It's a rat, actually. A cute little rat running around with, its saliva and urine and feces. And it just so happens, there are certain parts of the West African region area that are, a little bit more endemic in terms of Lassa fever. Liberia is one country that is very much endemic where Lassa fever exists. And as Dr. Greinen mentioned, most people that contract Lassa fever, 80% of them either are asymptomatic or they may have very mild symptoms. And so only 1 in 5 will go on to severe disease and need hospitalization. Overall case fatality is only 1%, But like he mentioned to you, if you have a third trimester female pregnant and that subsequent newborn, now you can end up with 80% mortality on the fetus and 30% mortality on the mom. Why do I mention that? We faced that. That was another piece to our saga I need to tell you about. So the county that we are focusing on for this discussion is called Bong County. They've had an ongoing outbreak, kind of off and on, cycling up and down since about 2022. And so they've had 143 cases in Bong County confirmed and 42 deaths. So that case fatality rate is a little scary at 29% case fatality, which is unfortunate. Now the contacts, a lot of healthcare workers. There's been over almost 1,200 contacts that public health officials had to trace. 399 of those have been healthcare workers. So if that's not a prognosticator of what you might encounter if Lassa fever should ever come your way, I don't know what is. All right, so here's our case. And by the way, there's Bong County right in the center of where this outbreak was. So our patient was a middle-aged male. He was a resident of the state of Iowa and been there for 20 years. He had immigrated from Liberia, and what he did was he had purchased some property back home in Bong County in Nigeria, or in Liberia, and he had gone there early in the summer and spent 4 months constructing one of the dwellings that Dr. Grine had mentioned, a thatched roof hut, mud sort of brick walls, things like that. So he was spending time creating a dwelling in this county. And so by October, he was ready to come home. And so on October 7th, he flew back to the United States. He was completely asymptomatic. Okay. No fever, no nausea, no nothing. And so things were fine. But about a week into his return home, he started feeling symptoms on and about 15th of October. He didn't think much about it. He just thought, oh, something I picked up, malaria kind of entered his mind, other kinds of things. So he really didn't seek any medical care at that point. But he started to get worse, and since his symptoms were not resolving, he decided to go be seen. Now, I heard somebody talking about a walk-in urgent care kind of doc-in-the-box clinic. Guess what he did? In small town Iowa, he walked into a doc-in-the-box, all right? And he said, I'm sick. I need some sort of help. And so I credit the provider, and I don't know whether it was an advanced nurse practitioner, a PA, or a physician that saw him, because I didn't see that in the chart. But the bottom line was they at least recognized the fact that his travel history might make this a little bit more than just a common illness that could be happening. They decided to call EMS and have the patient transported to a level 4 facility in a larger community on the east side of Iowa. And they are not a special pathogens treatment center in any way, shape, or form. That hadn't even entered their minds yet. So special pathogens were not even on the differential just yet. So I think about the EMS crew. Any EMS folks in here? Transport? Okay, I'm a 42-year veteran paramedic. I hear you. Okay. So what were those folks wearing for PPE likely as they transported this patient? Standard precautions. Now, somebody asked earlier in an earlier session, are universal precautions or standard precautions enough if somebody would present with a potential special pathogens case? And I like the answer that the doctor gave, but I have to tell you, that's all there was in this situation. This was not a special pathogens transport team. We have 4 of them that we've trained in our state. That was not what the case. Now, he was symptomatic, but he wasn't grossly ill. And so I think his viremia, his viral load, probably wasn't that high yet. That was probably to the EMS folks' advantage. So he gets transported to a level 4 facility. Now, he spends about 4 days at this hospital, and they're going through everything they can figure out to try to test him for to see what this case might be. And so for those of you of a clinical nature, when he presented to hospital number 1, he had a 38.5 Celsius temperature. His vital signs were stable. He was conscious, alert, conversive, oriented. He looked ill. He presented ill, but he was not toxic ill. Okay. Some notable labs. WBCs were 3.5. Platelets were at 58K. His AST at that time was about 155. His ALT was 63, and creatinine was 1.27. Then the folks are going, I'm looking at these labs, and they're wondering what's going on. All right. They did a respiratory panel on him, negative. They did a malaria smear and a PCR, negative. So it wasn't malaria. They did urine and blood cultures. Those were both negative. They did some imaging. They got x-rays, CT of the chest, etc., all negative. And so they're scratching their heads, all right? So he spends about 4 days there, but his condition worsens in that 4-day period. As we're approaching about day 4, he started to become more CNS lethargic. He wasn't as responsive, and he had some changes in his enzymes. So what happened? He was afebrile at this point. He was alert, but again, slow to respond. He had one episode of witness emesis, vomiting. And look at his labs. His WBCs are 11, platelets 81,000. AST was over 2,000. And ALTs 300, and creatinine 1.27. His INR was 1.3, and his lactate was 3.7. So clearly his liver is not doing so good. So he's gotten some major issues going on. And at this point, they decide to transfer him to our facility. And it just so happens, this always works, right? EMS, this is at 2 o'clock in the morning on a Saturday night, all right, or 2 o'clock Sunday morning. So they had the wherewithal to say, all right, we need to admit him into our medical intensive care unit. So they put him into our MICU. That's about a 28-bed medical intensive care unit for adults. And they had done all of our heavy lifting for our worst COVID patients. So it's not like they're unfamiliar with how to take care of serious infectious disease, but they are not biocontainment trained. Okay. So the patient was admitted. And this is an interesting story. So who works in an academic medical center at 2 o'clock in the morning? Who does the physician's coverage? Residents, students, sure, residents. So we've got senior residents on duty in the MICU. One of those senior residents talks to a senior resident in infectious disease, and they decide they're going to order. So Epic order was put in for a test for Ebola, viral hemorrhagic fever. Now, that hits the lab supervisor in the middle of the night. Is anybody in the lab world? Can you imagine that you're at 2 o'clock in the morning and you get a lab order for viral hemorrhagic fever Ebola test? Immediately, God bless that supervisor. Lab people, I'm telling you, you're sharp. Immediately gets on the phone and wakes up the path lab director. And he answers the phone. He goes, what? They're ordering Ebola? What? And so, they're debating this. And then he picks up the telephone and calls Dr. Brust, our hospital epidemiologist, and wakes her up at 2 o'clock in the morning. And she went, what? You kidding me? So she gets online with the senior resident in infectious disease, and they start talking. And they're looking through the Epic order and looking at the patient's background. And there's not enough history here. So what Dr. Brust did is this. She goes, look, I want the MICU people on enhanced PPE. And I want you guys to go talk to this guy and try to get more history. And so make sure you're gowned up, gloved, everything, full PPE when you go in. So they went into the patient's room early that morning, and he just happened to get 2 visitors come in, relatives. And so between the visitors and the patient, they found out much more history, what he was doing in Liberia, what county he was in Liberia, and what his activities were. So then they went back to the office, put their heads together, started searching the data that's out there, and went, Bong County. So Dr. Brust immediately picks up her cell phone and calls the state epidemiologist, the state medical director, who she had serendipitously just met 2 weeks before face-to-face. He's relatively new to our state, and they just happened to exchange cell phone numbers. So she calls him up. She talks to him, says, here's what we think we have. And he goes, you know what? I think you're right. And so he calls CDC. Region 7 gets involved. The respec gets told. And so you can kind of see how it can kind of cascade from there. So the next thing over the next several hours is we're talking about, all right, the patient's epidemiological history matches the incubation period, which remember with Lassa could be about 2 to 21 days, right? Incubation period fit, signs and symptoms evolving could fit. There's supportive laboratory evidence that fits. Clearly, this patient is now a PUI, person under investigation. And so what that triggers would cause to bosses, division heads, on-call administrator, CEO gets notified, and bottom line is incident command is started. And so by 2:30 in the afternoon on Sunday, incident command met. Now, normally I'm the guy up at the head running incident command, but I've been retired for 3 years. And so an interim guy is up there, and we've got a kind of reduced group. My incident command system has about 110 positions, which is huge. It's amazing and it works. But the bottom line is we didn't need all those people, and we did largely virtual on a Sunday morning. And so the CEO of our facility is the incident commander. He's in charge of everything. And so after hearing the presentation of the case, patient symptoms, and what state epidemiologists felt, they decided that we should activate the biocontainment unit. And so that order was given, and they began the processes. And so just in a quick summary as far as the clinical care of this patient, from the time we received him, his condition deteriorated. He was, again, lethargic, liver enzymes were going south. Patient was starting to become more and more neurologically obtunded. His vital signs started to become unstable. And so by about 3:30, 4 o'clock in the afternoon, he had to be intubated, put on a ventilator. And basically he was started pressor support for his blood pressure was starting to oscillate. And so the decision was made that, you know what, they thought about transferring him to our Respect in Omaha. That's a 4-hour trip. And so they decided he was too unstable to move. And so we decided to keep him. Now, when we notified the Respect of this, I know Shelley Sweethelm, as I know some of you folks know, she was listening to this case and she thought, God, should we go to Iowa and help them? And so they started talking amongst themselves and they said, yeah, let's see if they want us to come over. So they called our incident command center and talked to our leadership and said, hey, you know, we're willing to come over if you're interested. And they said, come on down. So, you know, 2 nurses and the coordinator from the Respect jumped in a car and started heading for Iowa City, a 4-hour trip, which was just fantastic. Now, when all this was going on, I had no idea. But just the fact that the Respect was willing to do that, to come to our aid, is just phenomenal. Now, unfortunately, and I'll go through this a little bit more in detail, we were able to get him into our unit by just before midnight. We had it ready and had him moved up there. But his medical course just really was very unstable. We had 3 nurses in full gear and an ICU, one of our ICU docs. He was on our team. He actually took care of the first COVID patients in Iowa. He was very well versed in our PPE and working, and he's just a rock star, Dr. Nick Moore. He was at the patient's bedside, and so 3 nurses and the doc worked very hard for about 3 hours, almost 4 hours to stabilize him. He ended up on dialysis by CRRT. He had 2 cardiac events while I was there. I was doing things in the hot and the warm and cold zone, moving instruments and things in. They called for a defibrillator. It's like, okay. By the way, don't put anything in your room that you don't immediately need. Before all the things that Krista was telling you, it creates more waste and creates a disinfection nightmare. Well, we had to move a DC cardioversion machine in there because he had to be cardioverted twice with unstable atrial fib. He was started on steroids and anakinra, ferritin over 202. He had multiple tag infusions. He had an INR greater than 10. And by that morning was even more unstable. And by about 11:30, he suffered full cardiac arrest. And we did do what you would call a chemical code, but CPR was held. CPR was not going to be done, chest compressions. Dr. Moore made it very clear of what our team would do and what our team would not do. And chest compressions was one of those things we would not do. And so despite our efforts, unfortunately, the patient expired. So just a quick summary then. He was in Liberia for 4 months. Came home, a week later became symptomatic in Iowa, presented to a doc in the box. was transported to a level 4 facility where he spent 4 days. He was moved to us when his condition was starting to deteriorate and moved to us, and he only was in-house with us only about 34 hours. And so here's the thing with our respec team was at our side and at our nurse's side within 22 hours. After 22 hours into that course. And so, their response was just phenomenal. Now, activation, this is where I come in. I'm the ops guy, right? And so converting that space, here's sort of the timeline on how it all worked. Hicks activated, 2:30 in the afternoon, CEO gives activation order for the special pathogens unit. By about 3:30 in the afternoon, those patients are starting to be relocated. And it took us a little while to find space for those 4 patients. By about 5 p.m. that afternoon, early evening, we were able to start working on the unit, bring EVS in, do a terminal disinfection and cleaning from the previous 4 patients, started doing some testing of the autoclave. And I'm not on scene yet, but they started to test the autoclave, and guess what? It didn't work. They fired up the autoclave. It wouldn't cycle like it should, and it would not fully boot up, and the doors were frozen. They wouldn't open. And so it's like, oh, great. Now we don't have an autoclave. And so our facilities people got a hold of our autoclave vendor, and they said, hey, yeah, emergently, we can't be there till sometime tomorrow. It's like, great. Okay, so we have no autoclave. Supplies, we have a bunker in another pavilion in the lower level of our facility where we keep all of our special pathogens unit stuff. So the staff are starting to move the stuff up while EVS is doing the cleaning and whatnot. And that's about the time that I got this strange text message. I was up at my grandson's baptism in Wisconsin, and my phone buzzes. And I look at it, and it's our lead infection control nurse. Any IPs, infection preventionists in the room? God bless you people. They're my favorite nurses in the whole world. Okay, that's just the bottom line. She's texting me, and she says, hey, where are you? Are you in the state? I go, no, I'm not home. She goes, you might be getting a phone call. I'm like, for what? I said, we think we have a Lassa fever case. And I look at this thing, and I showed it to my wife, and she goes, what the hell's that? I go, it's not good. And so I thought, God, if they think they have a Lassa case, maybe we ought to start heading back to the States. So my wife and I said our goodbyes. We were in Madison, Wisconsin, and we're heading back to Iowa City. And it just so happens I had retired 3 years earlier. Okay. My successor came from the military, and he had just gone back into the military 2 weeks earlier and left the position and ended up in Colorado with the Space Force. And so we had no operations manager, no emergency manager for the facility during this time. And so, okay, I didn't know that until my phone rang, and it was the COO of the hospital, and said, hey, will you talk to me about a case? I said, well, sure. And she's telling me all this stuff, and she goes, will you come back? And I'm like, well, of course I'm going to come back. These are my nurses. We trained these people. I mean, if they really have a viral hemorrhagic fever case, of course we're going to do everything to make sure things are done safely in the right way. 3 hours later, I found myself with an emergency appointment walking into the facility at 7:00 p.m. And I have no idea what the situation is with our unit because I hadn't been there in 3 years. We have had no funding. They had no funding because we're level 2, right? So there had been no exercises. There had been no drills. There had been 2 trainings that I understood. And when I arrived, I found out that my 35 nurses that I left the place with are down to 14 through attrition, burnout, COVID, that happens. And boy, I don't know what to expect. So walking into the unit, starting to notice things that need to get done. For example, the red bag waste that Krista was talking about, you can't use regular red bags in a biocontainment unit. They have to be autoclave bags. All the waste bins were filled with regular red bags. Nobody had put autoclave stuff in there. So that was what I was doing, immediately going around trying to fix all that stuff, right? And there's bunches of things that I'm checking off a list to get done. And so scurrying around about 10 o'clock that night, we're getting close to having the unit ready to bring the patient up because the MICU nurses are freaking out, right? Because if they're thinking this is Lassa, they're not trained in biocontainment. And so you can imagine their mindset at this point. I was in the patient's room with the nurse manager, and we were getting things ready for the lab draws because they'd already drawn some labs. And as Dr. Grine had mentioned, we got a problem with testing for Lassa in the state of Iowa. Can't be done. Nobody can do it. Our state lab is on our campus or on our satellite campus, and they can do Ebola, but they can't do Lassa. Okay. So we have to ship this sample 4 hours to Omaha to have Nebraska's lab do it. So that's on its way and heading that direction. And so we're going to draw more labs. We're going to get some routine stuff done. We're setting it all up in the room. And I turn over and look over my shoulder. And ladies and gentlemen, I saw the most welcome sight I have ever seen in my career walk into the room. It was the team from Nebraska. Jackson, the coordinator for the Respect, Kate Bolter, who is the nurse manager of the biocontainment unit in Nebraska, and Angie Vasha, who's the director of their special pathogens group. Those two nurses had taken care of 3 Ebola patients back in 2014. So not only is our Respect coming to our rescue, these people have experience. And do you know how rare that is to have experienced individuals? They just walked into our unit. I mean, I choked up. I'm not kidding you. And they looked at me and go, "What the hell are you doing here?" And I go, "What the hell are you doing here?" It was this mutual, we didn't expect each other. And they said, "You know, we were talking about you on the way over." It's like, "Oh, too bad Mike's retired, blah, blah, blah." And then walk in and here we all see each other. It's fantastic. They immediately got to work. And so they got working with our team, starting to get them into their PPE. We put 3 nurses in full gear to start with, plus our physician. So the initial team was going to be 4 going to the patient's side and bringing the patient up from the other unit. They started working with the team, talking about the plans, what they're going to do for lab draws, looking over their PPE to make sure it's donned properly, et cetera. And they made it very clear they are not going to be doing patient care, the team from Nebraska. They are going to be, as far as they would go, is in the warm zone. They were in basic PPE, but they were going to be our guardian angels, watching from the outside, guiding the staff through various things, and basically guiding the doffing. And so that was just phenomenal. And so we did some just-in-time training for our facility security people and our EVS spill team because they hadn't done anything in a while. So we got all that ready to go, went down to get the patient at about 11 that night, and were able to bring him up. So he was admitted into our unit, kind of a small picture, but you can kind of see I'm in the cold zone at this point, shooting a picture through a window past the nurse's station into the patient's room. They were working diligently, trying to get him stabilized, and so, starting dialysis, getting more pressors. He had multiple vasopressors, keeping his blood pressure supported. And then he had his first cardiac event of that evening. And I remember my phone buzzing at about 1:20 in the morning. I'm standing on the border between the cold zone and the warm zone talking to Angie, one of the nurses. And she was in her gear, and we were talking back and forth about something. My phone buzzes, and I look down, and it's our infection control nurse, as I talked about earlier. She said, "Yeah, lab results are back from Omaha, presumptive positive." And I said, "Angie, look at this." Her eyes go like this. They had no expectation that this would be positive. The Nebraska people thought, "Nah, we'll get in there, get a couple of negatives, come home." It was presumptive positive. She goes, "Well, I suppose I better go tell the care team, huh?" I go, "Yeah, go ahead and tell them, Angie." So I went in and she told the team that the guy was presumptive positive. So working diligently through the rest of the evening, about 4 a.m., they were able to get him stable enough to where the doc could shower out. The initial 3 nurses showered out and replaced him with our next shift of nurses. And about that time, Nebraska folks showered out and they went to a motel to get some sleep, as did I. We all had been up for about 26 hours at that point. And so things were pretty stable. And so we knew the next morning was going to get real interesting at the incident command briefing at 8 o'clock, because now we have a totally different situation. Now communication starts, and you can all envision how that's going to work, right? Now we not only need to tell the people in the hospital that this is positive, we got patients, families, we need to tell our staff, we need to tell the community, we need to tell our campus, we need to tell the state, and of course the country is going to get notified about it. And who takes the lead in all of this? CDC. CDC led the charge. They were the ones responsible for making this happen. So CDC worked with our state and worked with our county and campus in getting the word out. And we thought, oh my God, are we going to have satellite trucks in the parking lot in the hospital and whatnot? Guess what? It didn't happen. We got very little media attention. Why was that? Why do you suppose that was? I mean, it's great. No satellite trucks. It's great. Why do you think? This was October 27th, October 28th, last year. Presidential election. Right. The media was so engrossed in the presidential campaign. That's what they were interested in. We got one little blip, and that was about it. So that was spectacular. Nobody freaked out. Nobody, raided our facility and did anything like that. So anyway, unfortunately, after our press release and things like that, patient started to deteriorate, and he fully arrested. And I'll tell you what, folks, if you're on the core team here or anywhere, we only had this patient 36 hours. He was only in our unit less than probably about 12 hours. This hit our team hard. We didn't build this program and build this unit to have this kind of outcome. We built this unit to do the patient and the patient's family do the best we can for them and have positive outcomes. And so this was tough on our staff, and the staff that was on duty at the time, they just paused, and it was like shock hit them, and everything was real quiet in the unit. And then I remembered they started a prayer service for the patient. And so absolutely. And so they did that. So by about noon, then we could start to begin our decedent care protocol. And obviously, this is nothing you ever expect to have to do, is to deal with a decedent that's dying from viral hemorrhagic fever. But again, fortunately, our ReSpect partners, they had already had one of these cases. They had 3 Ebola patients taken care of in Nebraska in 2014, and their final patient died. Similar situation. Got him very late in his course, and he did not survive. And so we now have experienced people to help guide our team through decedent care. And that began immediately. Immediately, the entire patient room was cleared out of all Category A waste, which was just getting staged at this point because we had no autoclave, remember? And so we're staging it in the room next door, and I didn't have enough. I have 55-gallon rolling red barrels that we stage our waste in before it rolls into the autoclave. We filled those up, and I needed more. So I had to get the EVS people to bring me some more containers to hold the Category A waste. And then once that was out of there, the staff from Nebraska and my staff nurses, we now bleach the entire room. So everything, you can even see the fogginess on the windows, walls, ceiling, gear, floor got mopped, everything. And this is with the patient still in his bed. So he was covered, but we began immediately reducing any kind of bioburden that might be in the room. Once that was done, then the staff walked out and showered out. And now you leave your negative air pressure system on, because we got some advice from our colleagues in Nebraska that Lassa fever is a pretty fragile virus. If it's on an environmental surface, they said, about 70 hours of desiccation. And really, if you have any virus that's on a surface, it's probably dead. So you begin that desiccation process as quickly as possible. So we just left the negative pressure system running, and basically everybody came out of the room. And now it's a matter of trying to do final disposition for the patient. Now, I'm not going to go through our decedent protocol. I'm sure you have one as well. But our biggest issue was we had no mortuary service willing to deal with this type of case. We tried to get one on contract back in 2014 and several years after that, since we built our unit, and working with our public health folks. Nobody was willing to go on record. And so here we are. The state is now trying to find somebody who's willing to provide funeral service, mortuary service for this patient. They made 18 phone calls that afternoon. Everybody says, no, 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 I'm sorry. Well, we had a premonition of this back in 2014. So I had purchased a separate single body cooler that I put down in our decedent care center. Our decedent care center is quite large. We can hold about 16 decedents. You certainly don't put a case like that in there. So we had a separate cooler built, put into our loading dock in our garage space for our decedent care. So our backup plan was going to be to put the patient there until we had final disposition. Well, fortunately, late that afternoon, there was a provider who agreed to take the patient. And so we began the process then of getting this done. Now, we have a great relationship with our medical examiner. We had drilled this a couple of times during my tenure, and they were the same people. And so they want to be on site. They came into the facility, sent a 2-person team in, the medical examiner and an assistant, and combined with our decedent care folks, they were going to be the team that helped our staff. And so we start to put together all the things that you need. The patient's bed stays in the red zone. Morgue cart comes in, that's going to bridge into the warm zone. A second morgue cart will bridge into the cold zone. And each cart is going to have a body bag opened up on it, large 22 gauge, real heavy ones. The ME brought them, one on one morgue cart, one on another morgue cart, and slider boards. So we had 2 slider boards on each cart that the body will be slid on. And then we began the process of containing him in the room. Now that's a process, and so it starts with our Hoyer or Arjo. We have an Arjo lift about 600 pounds. This is the key to dealing with the decedents. Nebraska does not have lifts in their biocontainment unit. They're going to try to get him after this experience. It made it so much easier and so much safer to get him contained by being able to shroud him, lift him up, put a BioSeal material down onto the bed. And if the bed had any moisture, bodily fluids, or whatever, you put plastic over that first to kind of keep that away from the BioSeal, safer for the staff. And then take a standard hospital body bag, put that on top of the BioSeal that's opened, lower the patient into the original body bag, zip them up, bleach wipe the whole thing, fold the BioSeal over. And this is when it gets dangerous. If you've been trained with BioSeal, the little irons that you seal it with, this is when you're most at risk. You really got to pay attention to what you're doing with those irons, because you could harm yourself by burning your fingers, burning through your gloves. And so this has to be done very slowly and very meticulously. Now, this guy was about 200 kilo, was approaching 100 kilo. And so he's a pretty big boy. We had a little trouble getting the BioSeal all the way over. We didn't have much of an overlap after we folded it over. I bet we only had 2 inches. You'd like to have 4 or 5 because you want to make a double seal on your BioSeal. We were able to double seal it, but those 2 seals were very, very close together. Okay. Bleach wipe. Okay. Now you bring the bed head to foot, bridge into the warm zone, slider board right into the body bag, the big heavy body bag. That's zipped up, and then bleached again, moved over to the cold zone barrier, other cart brought up, head to foot, slider board into the body bag. So he's got 3 body bags and BioSeal is basically how he's contained. And by the time you get to the final body bag and the cart in the cold zone, at that point, after bleaching the whole thing, you really don't need a whole lot of PPE at this point. So now he can be transported down, and this was the EMS crew that was brought in to transport the body. This was one of our 4 biocontainment transport teams, and they were able to come on site and transport him to the mortuary. Cremation rites were accorded. And as far as PPE goes, I think the EMS crew is a little overdone here. They didn't need that much PPE, but I'm not going to argue with them. If they want to wear a bunch of PPE, fine. It's okay with me as long as it's not too burdensome or cumbersome. But they had already done 4 other transports anyway on some PUIs, so they were pretty well tuned up at this point. And what they did was, as soon as they got to the mortuary, right into the crematorium, they doffed all their gear, all on top. Everything got burned up all together. All right. Well, I'm not going to go through deactivation that much, but we have 2 spaces. So disinfection is now my job. So I'm the waste guy. I'm the disinfection guy. I don't do patient care. So the processes are the same for both space. Get all your category A waste out of there. We didn't have an autoclave yet. They were going to repair it. It didn't get repaired till the following Tuesday. And so that was a real problem. And so we handed up between the medical intensive care unit and our unit 80 red bags of waste. That's a lot of waste. We were told to expect about 20 bags per patient per day. That's not the way it is, especially when we are not sharp and trained to not produce so much waste. So I think we produced more waste than we needed to because we hadn't done many drills or exercises. So that's an unfortunate thing. Once that gets all done, gets the category A waste out of there. Now we do that initial bleach wipe when the patient had expired. Now we go in and do another full bleach wipe. Now these are our core team nurses doing it. So the nurses go in and do this. They did the whole bleach wipe down to the whole unit, all the equipment, etc. in patient's room, etc. And now we desiccate for 72 hours. So the patient, we just walked out of the unit at that point, let it dry up for another 72 hours. They go back in for another bleach wipe at that point, and then 24 hours later, I went in there with ionized hydrogen peroxide. So we use an ionized hydrogen peroxide technology. It's not vaporized, it's ionized. And we find it very, very effective and easy to work with. And so by about Tuesday afternoon, they did get the autoclave fixed. And so we are now able to start feeding bags into the autoclave, and my nurses do that. And so the nurses were starting to autoclave at that point. We also found out that the Respect up in Region 5 in Grand Rapids, they don't have an autoclave. Can you imagine a Respect without an autoclave? They don't need one because their waste vendor will go ahead and move their Category A waste in 55-gallon drums like Krista had mentioned. And the price of this is not like it used to be. Back in the old days in Ebola times, to move that waste to incinerate down in Texas was about $1 million for one patient, right? Now you can get that waste. We got a vendor quote. They could do it for about $18,000. And so we ordered up 24 55-gallon barrels from our waste vendor, brought those in, and so we had simultaneous processes going. We're barreling up the waste and we're autoclaving at the same time, so we're doing two waste streams simultaneously. We eventually get it all done and got the unit cleaned up. It took us about a week to get the unit ready. It's probably a good thing we did. These are the barrels. We used 24 barrels. I had to order 18 more because we filled them up. And we were still autoclaving waste. And so we used about 8 of the next 18. And so we're going to always keep 55-gallon drums always on site to back up our autoclave. Another thing to mention with Krista had mentioned earlier with waste, the process that we're supposed to follow to put waste in these barrels was not particularly thrilling to NETEC, and so they had me modify it over what the manufacturer waste vendor wanted us to do. They were, for example, using zip ties to close red bags. Zip ties are sharp. You could puncture your gloves with those. So we changed things up a little bit. They want us spraying hydrogen peroxide on the bag before putting it in the barrel. NETEC said, oh no, we don't spray anything, right? So we did not do exactly what the vendor wanted us to do. And this is me doing the ionized hydrogen peroxide. This is a company out of California that produces this. Had a lot of barrels to clean, to bleach and ionize hydrogen peroxide. Had a lot of equipment. I had, I believe, 12 IV pumps, a dialysis unit, a ventilator, ultrasound unit, heart monitor, defibrillator, you name it. A lot of disinfection. All right. And finally, for our public health folks, God bless you people. Thank God for Qualtrics. That's our monitoring software. Keep in mind, we started out with an urgent care staff. Then we had an EMS crew. Then we had the staff of the first hospital. Then we had another EMS crew. Then we had my staff in the MICU, my staff in the special pathogens unit, and we had family members, etc. So the whole spectrum of NSPS is sitting in front of you. Out of all those people, there were 180 people exposed. I was one of them. And so every day we got a Qualtrics email and we had to put our symptoms, signs and symptoms in for 21 days. And so out of 180 people, 172 of them were healthcare workers. 8 were family members. Guess what? No additional transmission. Do universal precautions provide some value in a special pathogens case? I have to say yes. For the most part, you don't want to count on it, but it had to have helped. And the fact that maybe early on his viremia wasn't so high. And I'm just going to kind of flip through here, but bottom line is we ended up then getting a PUI, one of our own, 40 weeks pregnant and 3 days, high risk exposure. The patient, she started to become symptomatic. She was due to deliver any day, her 4th child. And so this was our PUI that we had to admit into my freshly cleaned and disinfected unit. And so enter our OBGYN chair who had been trained in all of this on the East Coast. He had no problem. He goes, oh, I'll do a C-section in here. That's not a problem. Or we'll do vaginal. He goes, the only thing I'd like you to do, Mike, is could you get me some better PPE? to cover my lower body. And so I said, well, Dr. Petker, I have an idea of how to better protect you. So I went down to my decon facility in the ED, got one of those big chemical Tyvek suits with the footies and everything, you know, that we use for chemical decon. I cut it, fit it to him, cut it at about rib cage level, went to Walmart and got some suspenders. And basically I created head fitted basically hip waders. And so he put on his regular gear, but then he would use this to cover his lower body. He goes, okay, make me 2 more sets for my attending and my anesthesia guy. Okay. So I made him his extra PPE, and we were within hours of having to do this delivery in our unit. And fortunately, though, our state, where's Dr. Grind, our state had allowed, or CDC sent a 7-person team in to help our public health folks track all these patients. They also sent a laboratorian person to our state lab, and we were able to get the Lhasa test up and validated. So all the testing we did for her was done in our own state lab, which was great, and then flown to the CDC. Oh, we had plans for the amniotic fluid, all the blood. He wanted a special headlamp on our capper so he had better light to do surgery. I did all that for him, and he was happy as a clam. Good news, she was negative, presumptive for us, and then the good news is she was definitely negative for the CDC. 3 hours later, she had her child up in regular labor and delivery. So that was good news. Folks, I'm going to wind up. I kind of went over, you know, the system. We had every piece of the system involved in this case, everything, right down to EMS. Public health was essential. They were instrumental. They were brilliant to handle what they did. I won't even tell you what they did for waste for all those places. It was challenging. But a big thank you to our friends in Nebraska. They did an incredible job of helping us. Our team, I don't know what we would have done without them. And so that's our story. And like somebody said at Cedars-Sinai last week, it's not a matter of if, it's a matter of when. We're your poster children. There is a when. Thank you.
Thank you so much. Am I on? Okay. Thank you so much, Mike. Such valuable lessons from a real world experience. And I think the pregnant PUI sounds like an exercise scenario that somebody wrote up, right? But just amazing work that your team did. Brooke, do we have a question? We're going to limit questions just because lunch is right out there.
Yeah, we do. We've got a couple of questions in the chat. The first one is around EMS. Coming from an EMS perspective, did the second transfer crew wear HCID PPE? And if so, who doffed them and managed their waste, including the PAPRs?
The answer to your question is no, they did not. So the first EMS crew from the urgent care to the hospital, just universal precautions. The crew from the level 4 to us, they added a mask.
Wow. Okay.
That was it. They were not in full gear at all. That special pathogen was not even on the differential yet till he got to our place. So good question.
And I've got one more. We'll try to make this quick so we don't keep people from lunch. But regarding the patient's family and the decedent care, were they able to view him at any time prior to decedent care?
Yeah, boy, Angie did a great. Angie and Kate were both the nurses in our unit when we were doing that. Getting the patient ready for viewing by the family. We did do a secure video chat with an iPad with the family, and that took 2 hours. And one of the things that is really disconcerting for the family, I'm sure, is that here they got to visit him on, the Sunday morning, and now they'll never see him again. And so it's very unfortunate that he had the facial edema that you expect with Lhasa. He had an endotracheal tube sticking out of his mouth because we always tend to leave lines in, like the ET tube and the NG tube were all left in. Angie brings up a good point, and they're discussing this at NETEC on whether or not it would be better if we could safely remove those kinds of things for the family viewing that's done virtually, so it's less shocking and less, emotionally disturbing to the family. We had a prayer service. Their minister of choice all was involved when we did this 2-hour session before we were able to get him out of the room. So a lot of decedent care stuff, I think, yet to come. We're looking at our protocol too to see if we can make it a little more comforting for the family. Great question.
Thank you so much, Mike.
All right. Good afternoon. I hope everyone enjoyed the lunch. I'm not sure if I heard it yet for the nurses, though, that are in the room. Happy Nurses Week. Thank you all for the clinical magic that you do that I often dumb things down to. So my name is Daryl Ruby. I'm the regional coordinator, and I have the great good fortune of supporting the team here at Sacred Heart. This afternoon session is going to be a transportation session, so I'm going to give just a really brief overview on some regional planning that we're doing, and then we've got an amazing opportunity to listen to Cassie from our team talk about the training she's been working with AMR Spokane, and then Jesse did a great exercise excuse me, this past spring, also with the AMR team down in the Portland metro area. And so she'll give an overview on that, and they can introduce themselves when they get there. So a lot of you that join us regularly for our regional coordination, our special pathogens coordination committee, our Region 10 EMS and transport work group have seen some of these, but just the focus for us this year is working with our states to update their plans, support them in the update to the plans. As we've heard a couple of times today, transportation continues to be a challenge for the entire country, and so we're trying to put some additional emphasis on that. I'll touch on that in a little bit more detail and some upcoming training that we're doing. And then our goal for next year for us is to work on an update to the Region 10 CONOPS, and we'll use the planning and everything else that we've done this year and previous years to inform that update, and also transportation will be a focus for that. So this slide likely looks familiar, especially if you've seen some of our presentations. What I'm trying to highlight here is really both the hospital network, but the regionally designated teams that we've been working with. We're really grateful for AMR's commitment both in Washington State and the Portland metro area to support training. So last September, we hosted a NETEC EMS training at AMR Seattle. A couple of those folks are in the audience, so thank you all for coming over. This fall, actually in a few weeks, we're going to be up in Anchorage before the Halle Borealis conference, and the LifeMed Alaska team will be primarily supporting that training up there. But what I really want to kind of show is what we're talking about is, although every EMS team needs to identify, isolate, and perform, identify, isolate, and inform, and perform life-saving interventions if they need to. The risk that we believe that, especially for those cases where we're monitoring people that have been in outbreak areas, is that we're hoping that the interventions won't be necessary right away, but then we need to transport them to a higher level of care. And so what our focus has been on, which is consistent with some of the other regional centers as well as the states that are supporting it, is to have regionally designated teams. So what we're trying to show here is, and the circles are not to scale, is that in Washington State, we feel pretty good about the teams that we've been identified. Alaska, as you'll hear this afternoon in particular, has a lot of unique challenges, but the LifeMed team is committed to some additional training and supporting that. And then we need to continue some work with Oregon and Idaho as we build out these teams. So just a really quick snapshot of what that looks like. This last slide I've started to touch on, but really just some of the assumptions that we're making and the priorities around EMS and transport. So providing a baseline level of training for all EMS agencies, but really focusing on those regionally designated teams, providing some foundational training for them, and then working with them and supporting them. And you'll hear how Cassie has kind of led that work with the AMR Spokane team here in just a little bit. So what that looks like for the transport is we talk about a just-in-time transport program. So a patient comes in most likely to the tiered system to a level 4 or a level 3, or they could report to another. They might show up at an urgent care or as Summer was mentioning this morning, that the CHAS clinic, the federally qualified clinics here. And so there will be some coordination with 911. Hopefully they identify it, as we heard from Mike, that's not always easy to do. There will be some coordination that happens, and then we'll develop that just-in-time transport plan. And so ideally, just like the concentric circles showed for the Eastern Washington, North Idaho area, that would be the AMR Spokane team. So we're recommending we don't rely on our primary interfacility transport teams, but through coordination with public health, EMS agencies, our local, as well as our state public health, and us as the RESPECT will develop that just-in-time transport plan. So you'll hear a bit more about that in detail as Cassie talks about the AMR Spokane work she's done. You'll also hear a little bit more about that with the exercise that Legacy did this past spring with the AMR Clark team, as well as Portland team. So I think we have one question. I don't know if there's any online. The more important stuff is coming. So happy to take any questions here. Otherwise, I'm going to sit and listen to the next two updates. All right, fantastic.
Daryl does very important work. We need him, as you will see. My name is Cassie Prather, and I'm a clinical educator here at Sacred Heart Medical Center with Region 10 Special Pathogens Unit, and I have been able to work with the Spokane AMR transport team, ground transport team, over the past year, developing their team. So it has been a very fun year. I am just going to give a quick overview. So we're going to go through Region 10 and where the ground transport started. And then we'll talk a little bit about the Spokane team. And I'm really going to highlight them because I am just so proud of them. I'll talk about goals that we have, and then the quarterly trainings that they have gone through this year to build their team, and then talk about what's next and what we have in store for them. So just a little bit of the background, and this is for Special Pathogens Unit and ground transport, but primarily geared to ground transport. So if you have any questions, feel free to chime in or ask those questions. But so starting in 2015, the grant was awarded through DOH pass-through funding to Sacred Heart, and at that time they needed to identify a ground transport team. So in 2015, they had identified Spokane AMR as that ground transport agency for the RESPECT. And then from 2015 to 2019, they have independently built and maintained a team. So they really, to build that team, they consulted an outside agency versus the RESPECT. And I'll get into why that's important a little bit later. But they really developed their training and learning opportunities, participated in exercise with Sacred Heart, but really were pretty independent otherwise of those exercises. And then in 2020, I do not need to tell you all what happened, but staffing turnover, limited team members, they had COVID challenges just like everybody else, limited to no capacity to train and maintain their special pathogens transport team. So it kind of fizzled, but it was still there. So there were still individuals, but a lot of turnover at that time. And then in 2022 was really when that direct cooperative agreement between ASPR and Providence happened. So there was a little bit of an increased capability for funding to support ground transport. And then in 2023, ASPR increased that scope of work, and they directly called out EMS and ground transport within the region. So that was an avenue for Sacred Heart to be able to support ground transport a little bit more. So that was PPE, staffing, and training. They were able to give them a little bit of money to do that as well. And then in 2023, because of that grant call out, is when they actually added that operations advisor and medical director, which for EMS specifically. So that's Brian Rogie and then Micah Dang, and Brian's in the back over there. And I'll talk a little bit more about him later. But fast forward to 2024 and 2025, we I'm so proud to say we have a full rostered team and they participate in quarterly trainings and they're so engaged and they're doing very good work in Spokane. We've created new policies and procedures and expectations within that team. So that's something that we've worked really hard on, created a lot of checklists and documents and more checklists and have revised a lot of those because we actually have practiced everything that we've built. So that's something that we have been lucky enough to work with and been supported by AMR as well. So a little bit about the Spokane AMR team in general is, again, I mentioned the medical director for EMS is Dr. Micah Dang, and he unfortunately couldn't be here today. We have a lot of our EMS folks that are at a different convention today. And then our Respect Operations Advisor, Brian Rogie as well. And then the Spokane AMR leads, Julie Clayton and Liam. They both are paramedics by training, and they have done a wonderful job just leading the team and also training the team and working with us and allowing us to help them along the way. So I'm very grateful for them as partners. We've created team expectations, and that's just mainly around safety. I would say that a lot of these expectations have developed. Again, it's an all volunteer team, meaning that they do not have to be on the team, but they are participating in the team and they get paid for their time. So there's 10 to 12 team members. They are paramedics and EMTs. They are paid for their training and education, and they are required, loosely, I use that word loosely, to participate in quarterly training. We do ask that they attend 3 of the 4 trainings, and that is something that Dr. Micah Dang has said that he's pretty firm on just because of the safety aspect of this. We want to make sure that everyone feels comfortable with their partners in the back of that ambulance in the front and the team transporting, and that they feel confident and comfortable to go out and transport that patient as well. So our team also has a Washington and Idaho license. So that is something that AMR has supported us with throughout the year. So they're working towards that as well. And then again, they all have the option in participating in exercises and trainings that we have done. And we recently have been able to integrate both our clinical team at Sacred Heart and our ground transport team at AMR, which has been such a huge value for both of them. So it's been really fun also. So again, we're all working towards the same goal. And I know Daryl had mentioned previously that we have a few other AMR agencies that we are working towards having regionally designated so that they all have a similar capability, so that if we do have to do a longer ground transport, we can get from point A to point B, but we have the same competencies across those agencies as well. And then we do have a team of individuals that have been dedicated to learning best practices since 2015. I think there's still a couple individuals on that Spokane AMR team that have been with us since 2015. So that is exciting as well. And one of our goals is just to create a standard approach to preparedness in Region 10. So we can strengthen those IPC protocols and for all infectious threats, whether or not it's a HCID or not. But we really work towards making sure that they feel confident and comfortable in their policies and procedures too. All right, so I'm going to go ahead and get into our fall quarterly training, and I'm kind of just going to go through our quarters of training so you guys can kind of see how this worked from the ground up. And I'm missing quite a bit because they have done a lot of work. So just know that if you have questions or anything like that, just let me know. But in the fall, we had an EMS biosafety course in Seattle, which was supported by Need Tech, and they actually came out there and they were able to train, and we had a few different agencies that participated in that training. So that was part of fall training. And then in addition to that, Spokane specifically had quarterly training where they did donning and doffing of high-level PPE. And they have actually transitioned to the same PPE that our clinical team at Sacred Heart wears, just for ease and continuity of care. And they're able to help each other in the safety as well. So we did, those AMR folks came to the special pathogens unit. We did a unit tour, and then we also did an NSPS and NETEC overview, and then also identify, isolate, and inform, just so that they had the same awareness and education that our team does as well, so that they know why they're doing what they're doing instead of just being out in the field with no context. So that was fun as well. So in the winter, these are all really fun photos. We do have fun while we do it. You know, Krista's up there and she got to fake vomit on these guys in the back of an ambulance. So, and then we have Liam trying to change his boot cover in the back of an ambulance. And this is when I say some of our policies and procedures have changed because that's not doable. So just know that the basic infection prevention and control practices are kind of those fundamentals that we want them to learn. They are learning, but we do have to modify because it is the back of an ambulance and it's not a hospital room. So some of those things that we've worked through and we've been able to develop mitigation measures for something like spills, for example, that have really turned into an actual policy for them. So that's been exciting. Each one of these trainings have been 2 hours in length, and we do have them. Some of you may or may not be familiar, but since AMR is 24/7, we do have a Friday and a Monday so that we have shift 1 and shift 2, and they can both make it to a training. So everybody is able. Also in the winter, we practice safety and communication, some breach management, and also donning and doffing of high-level PPE. In the middle here, we have a couple of different kits that they have built, and that is really a sparse kit of what they normally take on the back of an ambulance. So we really just took exactly what they would need and put that into a kit, and then we have been revising ever since, but these have seemed to work pretty well. So at the bottom, we have a spill kit, and then at the top, that would be we call it the Pelican case. And so their hard Pelican case has all the good stuff in it that they would need to care for that patient and then also themselves. And again, you probably see the blue in the back, and that's draping the ambulance to make sure that we can also safely transport that patient. And then in the spring, we just got done with a 4-hour simulated based training, and this is really where Daryl comes in. Although we work closely with our Spokane AMR agency, Daryl was able to get us an appointment, if you will, a couple of times out at the airport. So we actually took the team through a full activation. So they started at AMR, they went over to the airport, and they were able to don their PPE. And then I think in here we had one of our leads, and then Dr. Dang was the patient. So we actually got to simulate bringing one of them to Sacred Heart. And then we have developed their doffing process as well at Sacred Heart. So that has been something that we were able to fully practice, which has been fun in these trainings, even though it's a simulation-based training. And then we also practice containment wrap and then category A waste management, which we all know is hard. So in this case, for our category A waste management in the back of an ambulance, they Sacred Heart would receive that. So we went through that process and were able to finalize and revamp and revise that process as well at Sacred Heart. So this is just us at the airfield and then at Sacred Heart, and then wrapping our good friend Julie up in a little containment wrap. All right, so what's going to happen next is we are going to continue with our quarterly training. Like I said, each quarterly training is 2 hours long, and then we pick one quarter throughout the year that is going to be a 4-hour training. So that's a little bit longer, and that's kind of applying everything that they learned in the year to that 4-hour training. So it's more of a simulation-based training. We meet, as in the leads and I, we meet almost weekly to develop this and work on these policies and procedures, which has been a really fun process getting to learn them. I've also done a couple of ride-alongs myself to learn their side of things, which has been very eye-opening to myself as well. And then we're going to go ahead and assist in developing other regionally designated EMS special pathogen transport teams. So the goal here is I've worked really closely with Spokane AMR the past year, but the goal is to be able to do that with all of our regionally designated teams and create a toolkit to where we can actually take a team and they can fill out, the odds and ends of this toolkit and have a training plan for their own team so that they can train independently as well. And of course, I will always be a resource, but I can't be in 5 places at once. So, and then we're going to continue and build and maintain relationships across the EMS agencies. So if you guys have any questions or comments or concerns or anything you would like to share, I'm all ears on that one. But with that being said, that kind of wraps up with any questions that you may have.
We have a couple questions from the room here.
Hey, Cassie, I'm just curious if any of this information is being shared with the rest of the EMS personnel that aren't involved maybe with the training, if they learn like different signs to look for and different things they need to do if they were out in the field and already on a scene.
Yeah, that's a great question. So we are trying to say the least. So I have reached out to our EMS school that's through Providence. So kind of getting in there, and then also new employee orientation that maybe they're not on the special pathogens team, but rather just a new employee at AMR. So giving presentations there just about special pathogen awareness. And then the idea of this toolkit is that it's able to be dispersed not only to our regionally designated teams, but further than that, so that they're all able to have access, if you will. And then a couple other things I've done this year, I went on to EMS Live at Night. I don't know if anyone is familiar with that. So presenting on a podcast and things like that to try to get the word out about HCID transport.
Yeah, the one other thing
that's not on.
The one other thing that came to mind with that is Brooke puts together monthly Identify, Isolate, and Inform situational awareness tool. And so we've started sharing that with both hospitals and EMS agencies. And the goal there is, especially when there's an outbreak, there's some situational awareness that all of the EMS personnel are thinking about that super important travel screening question that typically doesn't come top of mind. But I think there's still a lot of opportunity with the EMS community at large.
I was just going to say, if you have any ideas, let me know.
Do we have any other questions in the room? Okay.
Hi, everyone. My name is Jessie McGinty. I manage the Biological Isolation Care Unit in Portland, Oregon at Legacy Good Samaritan Medical Center. And I'm going to be talking about our transport team drill. But first, I'm going to give you a little overview of why I'm here and kind of the work that my team does. So as I mentioned, we're located in Portland, Oregon. We are licensed at 539 beds, just for reference of size. We're staffed to like 220-ish of those beds. Earlier, someone was talking about the early days of the designated Ebola center. So in 2015, we were designated as one of those Ebola treatment centers, and we're still the only team in the state of Oregon who is managed to care for viral hemorrhagic fever patients. The capacity of our unit is up to 2 patients that have a VHF, and then we have the ability to overflow into an additional ICU space in the event that we have a respiratory illness outbreak. Back in 2020, we thought we'd contain all of the COVID in Portland to our little pod. We know that didn't happen, but it was really productive thinking and practicing to potentially have that happen. We also have a lab in our unit. So our unit is set up as an ICU pod. All the rooms are connected. So for the IPs in the room, it's kind of cool. We can go from the cleanest zone all the way to the hottest zone with never actually leaving an isolation room. And our lab is located directly next to our patient care room. A little bit about our team. I have about 45 caregivers on my team, physicians, respiratory therapists, registered nurses, and a lab team. We have 11 new nurses, I think 13 actually. I submitted these slides a little bit earlier, and 4 new providers in the last year. So our team is growing and changing. We often will lose folks when they maybe leave the hospital system, or often people go and have families and then don't necessarily come back to the team, but we're continuing to grow. I listed just some of the different departments that our team comes from so you can see the diversity within the skill sets of our caregivers. We have training twice a year. We always do donning and doffing during training, and then we mix things up with whether or not we do hands-on skills like IV insertion, spill cleanup, telemedicine. That's one of our physicians there on the telemedicine robot. And more recently, we just did decedent management for the first time. So it was really exciting and really sweaty, and I think everyone learned a lot and had fun. And then every other year, we've been doing a full patient care simulation. So our caregivers are in their PPE for their full shift, and they actually take care of a patient who's often a nursing student. So that's really exciting for the nursing students too, to come hang out with us for the day, get some free lunch, and practice their acting skills. So how do I get to do all of this work? Because we have a memorandum of understanding that this is a community resource. So the BICU lives at Good Sam, but the BICU kind of belongs to everybody. We partnered with OHSU, Providence, Peace Health, and Kaiser to fund our unit after the initial Ebola outbreak in the early days of our unit being opened. Everyone else kind of went back to normal life, normal healthcare. And Susan, who I know is listening, hi Susan, my boss now, she was like, I want to continue this work. This work is important and this lives within Good Sam. So OHSU offered to provide some financial assistance and the understanding that we would take their patients. We're going to take everybody's patients, but we also love the financial support. After 2020 and the COVID pandemic, we realized that our healthcare system is not ready for any special pathogens as a whole, any high consequence infectious diseases. It's very limited. And so then insert the other facilities who made the decision to support us. So we're supported by, again, Providence, Peace Health, Kaiser, and OHSU. And in return, we will take their patients within a certain amount of time and support any other subject matter expertise or training and drill facilitation that they might need. We're like a little mini hub and spoke model. Emphasis on mini, but we're here. Okay, so a little bit about the transport team drill. This was on March 6th, and Alice is back there. Alice, can you wave to everyone? This is Alice. Alice is with AMR, and I'm kind of embarrassed that I'm presenting this without her because she was such a huge part in all of this work. So Alice, thank you for all the work that you did. This drill happened, started at our hospital in Silverton. Has anyone ever been to Silverton, Oregon? Cute small town. And we took a 44 mile drive to Legacy Good Samaritan. So you can see on the map there, it's right along the I-5 corridor. How did this happen? I think we all know there's a lot of gaps within transport everywhere. We function as a level 3 assessment center, but we are a level 3, but we really have to function as a level 2, knowing that there are gaps in transport. We might be keeping that patient longer than 12 hours, so how could we make sure that we're ready to do that? So now onward to transport. How did Alice get involved? Alice did one of Cassie's amazing trainings, and she was willing and excited. And I think willing and excited was all I really needed. If you're willing and excited and have an ambulance, I'm ready to hang out with you. So Alice and I planned this drill. We put our heads together to create what this transport team could look like. A lot of the transport teams are strictly AMR. We wanted to work closely with paramedics and our ICU nurses on our team who were willing to do the work. After we ruled out the folks who get car sick, who weren't interested, we had a few nurses left to choose from for the drill, who then were able to model what this team would look like. I want to put an emphasis on how much of an effort AMR made ahead of time. They learned about our PPE. Alice made sure that her team copied our PPE ensemble so our ICU nurse could keep that person safe and vice versa. They could see breaches. They knew what this PPE looked like. My team could successfully doff Alice's team when they came to the hospital and so on. Alice worked closely with myself and we had a DNP student also who worked on this project to ensure that we had SOPs that we maybe used in the BICU that were appropriate for an ambulance and how to help translate those from inpatient hospital world to ambulance world. The PPE or the ambulance was donned in gear as well, which you'll see. Luckily, our patient happens to be a member of the team, and so we're able to have her help get the ambulance ready, which you'll see more about. This drill focused on 3 key areas, essentially what was happening in the emergency department in Silverton, what was happening in the rig before people got in and after they got out, and then what was happening at Good Sam in the BICU. So this exercise began at Silverton with a symptomatic patient presentation, continued on to the patient transport, and then ended at the BICU. The exercise reviewed kind of 4 main areas. 2 of them talked about the Emergency Operations Center, which I'm not going to go too in depth on today. And then really the ability for our friends in Silverton to be able to identify, isolate, and inform. That was maybe a selfish part for me because I've been doing training with all of our hospitals. And I'm like, have you guys been listening? They were listening. They did a great job. And then lastly, really focusing on our BICU team's collaboration with AMR and making sure that we could create a safe and successful transport. You might recognize this patient. She's cured, don't worry. This is our patient, last name test patient 7, first name Gertie. So that kind of gave things away when we got to the hospital. She looks great for 65. This 65-year-old female returned from work-related travel in Uganda. She received medical care while she was abroad, and I put in parentheses there for unrelated to any VHF symptoms. I told her to tell them that she broke her arm to try to just like focus on like there was an injury. And then they were really worried that they needed to care for her arm. And so less is more in this situation. I gave her this like script this long and she's like, Jessie, you're confusing them. And then on March 6th, she presented to the hospital with a fever, headache, fatigue, muscle cramps, abdominal cramps, and nausea. She made clear to make sure that they knew that while she was at the hospital, outside of the United States, that she saw a lot of people sick and her doctor threw up to make sure they really, drove that home. So Silverton is one of our smaller community hospitals. We only have 48 beds in the hospital, so it's really small for reference. And this was a minimal notice drill. I don't want to say it was no notice because I did tell people, but they're still kind of surprised when we got there. The nurse that was there knew she was participating in the drill, but didn't really understand the extent of what was going on. She had questions about Ebola as a whole and definitely didn't know what a viral hemorrhagic fever was. So it's kind of the perfect opportunity to see what would happen in a real life scenario with maybe a nurse who's not as familiar with those things. Any infection preventionists in here? Show of hands. Okay, you guys are going to love this. So partially why we started the drill at Silverton is because we have a brand new emergency department. It's stunning. There are 2 isolation rooms that are connected to one another, which then goes into an ante room, which goes into a decon room and out to the ambulance bay. So like perfect situation for any decontamination situation or a viral hemorrhagic fever, like our example. So that's exactly what we did is we had the patient placed in one of those rooms after they were identified. We have PPE boxes. So I know that Providence uses like bags, PPE in a bag. We have PPE in a big box. And I was just so grateful that those nurses there knew that the box existed. I don't know if they knew exactly what was in it, but they're like, oh, I remember that we have a box somewhere with PPE. So they did a great job being able to isolate and put that PPE on. This photo in the middle where Cassie's looking directly at the camera, behind her you see the nurse donned in her PPE, and then with Angie from our knee tech team, and then the person with her back turned, her name's Alyssa, and she's one of the nurses on our team, but she is an emergency department nurse. I'm not a nurse, I have a public health background, and I've learned very quickly that all nurses do not do the same things. So we have created an ED deployment plan with a big uptick in employees coming to the BICU team from the ED team. Any ED folks in here? No. A couple? Okay, the Chaos Chasers. I presented on ICO 70101 in the ED and they all were like, put me on the team. So now we have this big ED group and we've created this deployment plan and Alyssa was able to deploy to this emergency department and support the nurse, be there as a PPE subject matter expert, be willing to put PPE on and help her if she had any questions, walk her through any epic challenges that might exist. And this was a huge win for us and we're going to continue to do this work. Okay, I think that's it for Silverton. This last picture is Cassie getting ready to go into the burrito, the patient transport wrap. Our transport team, the person in the front is Ben. He's one of my ICU nurses, and behind him is Patrick. You can see the ambulance is draped like Cassie's photos. Cassie actually did the draping with Alice and her team. I mentioned this is a multidisciplinary team. So Ben and Patrick both have their specialties. Patrick knows how to provide medicine in the back of an ambulance. Ben knows how to be an ICU nurse anywhere, but he just has to have some expertise that Patrick was able to provide, like what's in the ambulance. Things are really loud back there. Ben was like, I had no idea it was so loud. That was a challenge that we dealt with. But their collaborative approach was really essential to this process. And for those out there who maybe don't have transport teams, I think it's a really great opportunity to have an inpatient caregiver as well as a paramedic partner up to do this work together. At the emergency department, as we were getting ready to get this patient going back to Good Sam, I will say too, we had to simulate a lot of things because we didn't have all of the time that it would take to do everything that we would do with public health. A lot of the phone calls had to be simulated, which obviously created some gaps, but that's next on my list of things to do. So this call or this transfer was facilitated through a conference call. We have a legacy internal team called One Call. It's just like they set up conference calls to transfer patients to higher levels of care. So we utilized our BICU team, our infectious diseases provider, the ED provider that saw Gertie while she was in the ED, as well as our receiving provider within our ICU to facilitate what that transfer would look like, what medications Alice's team would need to have before they leave, any special things that they need to be thinking about outside of obviously their PPE and the care that they're providing to ensure that we had a safe and collaborative transport. All right, so now we've made it to Good Sam. Such a quick drive. Cassie said it was a lot colder in the ambulance. I forgot that she was just wearing like her regular clothes. So I think she froze back there in the back of the ambulance. But you can see that this tent is set up outside of our administrative building. So we have a very discreet route that we bring patients into our facility. We don't go in through the ED, we go in through a tunnel system. Our BICU team followed our activation procedures facilitated by our Emergency Operations Center as well as BICU leadership. We tested everything from our staffing calls, emergency pages. I worked with our PR folks ahead of time to orchestrate some emails that we could send out. We obviously used the "this is a drill" a million times in the email, but made sure they knew what was going on, because when you see a tent and ambulances and people in scary PPE, people always have questions, even if it's a drill. The team that deployed down from our BICU to pick up this patient consisted of 4 different people, 2 inpatient nurses who were accepting the patient and would care for them for that initial shift of care, a charge nurse who was our clean nurse. So she was the only one allowed to touch anything. She was opening doors, pushing elevator buttons, etc. She had a badge available. We learned from the last time when no one had a badge and they were locked out of the unit. And then we had one nurse that was the trained observer. So her job was to go down and actually be the trained observer to doff our nurse and to doff our friends with AMR. This was one of the first opportunities we've had to utilize some new procedures to set up the tent in the receiving area. So you can see that in the photos as well. One opportunity right out of the gates was that we had a PPE failure. I was walking down with our 4 nurses and someone was like, "Oh my gosh, my battery died." It's like, we tested everything, we checked everything, and we still had a failure. So her battery died. Luckily, this was our trained observer and she was able, or it was one of our inpatient nurses, but our trained observer had a battery and she was able to provide it to her. And we just paused and we had AMR and Ben, our BICU nurse, wait to get doffed until we could get her an appropriate PPE. That was a huge learning for me because I didn't have like a secondary go bag with extra batteries because it said it was charged, but it was a good learning opportunity. Lastly, our drill ended up on the unit after we admitted the patient, and she had a miraculous 10-minute recovery, I think, once she got admitted. But we're able to go through the entire epic process of admitting a patient. We got special access from our IS colleagues to admit a test patient to the real environment, which I learned is kind of a no-no, any IS folks, but I forgot to discharge them. So I got a phone call 2 weeks later and they're like, "Gertie, test patient 4 or 7. I was like, "Sorry." So we were able to discharge her officially a couple weeks later. I'm telling you, I had a lot of opportunities for improvement as an individual after this drill. I reached out to my BICU leadership team that consists of 3 of our IP nurses and then Susan, our director, and asked what they thought the opportunities for improvement were and what went well. This is like last week. Mind you, I have the after action report with everything already listed, but I was curious after time had settled what they still thought were the most important pieces, or what Susan and I like to think about as the things that keep us up at night. So the first one actually came from our nurse who was in the ED, that the ED felt a bit chaotic at the start of the drill. When there's chaos, there's opportunities to miss big steps. And when we miss big steps, there's potential for exposure. So we never want any of our caregivers to get sick when we're caring for these patients. And I think that was a huge lesson of just, again, I don't want to hurt our ED friend in the back's feelings, but ED nurses move quick. Like, you've got 20 patients in the lobby waiting, you're drawing blood, you're thinking about how you're going to get this person in and out as quickly as possible. And I think it's really important to remind our ED friends that, you know, it's okay to slow down, and it's actually really important to slow down when we're working with these types of patients. I talked a little bit about the PPE failure, but I turned that into a win really quickly, that we reallocated supplies. Our hospital incident command structure wasn't used to its full capabilities. I think it's really hard to do this during drills, especially when you have a limited amount of time, because I know that they would have been up and moving and had a lot more jobs to do if I hadn't created a lot of that work or done a lot of those check mark boxes ahead of time. Our travel screening failed, so that was kind of a bummer. This was an internal process that we've been working on. I just saw someone smirk. I think your travel screenings probably failed too then. It happens, and we've been actively working with our IS colleagues to fill these gaps. What's a drill without communication failures? I don't think that exists. So we had some communication failures in getting our BICU team left early, and then realized that this patient was still on the highway. They hadn't come to the unit yet, or out to the parking lot, excuse me. We utilize walkie-talkies. I never really thought that we'd have to do like a walkie-talkie 101 with folks. Like, I don't know, I've been playing with walkie-talkie since I was like 5, but we did. And so there was errors in how to use walkie-talkies. Like, you don't necessarily know these things are going to happen until you practice them. And so lots of communication failures, and also remembering that we all have one of these, and we have texting, and we have phone capabilities, and we don't always have to use the special, exciting communication options. We can just use our cell phones. A lot of stuff was simulated. We had to simulate things because it was a drill, and I only got like a half day. Not everyone wanted to be on site with me for 36 hours to practice a drill to its entire extent. And so this was less realistic. We had some missed learning opportunities with this. We work really closely with our public health colleagues, and we didn't even tell them this drill was happening because we weren't ready to kind of integrate a lot of those pieces. Now that we've gotten through actually just transporting someone in an ambulance, we're ready to engage a lot of our other partners. I like to end on a good note. So what went well? We completed our first multi-agency transport in collaboration with Alice and her colleagues. So I think that's huge. Getting all of these people at the table and willing to participate was a big deal. And Cassie rode 44 miles in an ambulance, and she's still here to talk about it. The ambulance was safely draped and isolated. Our legacy and AMR protocols that we created were actually utilized. So they were printed and they were using them in the ambulance, which I think is great. And they were used effectively. All participating teams were actively engaged. We learned so much from AMR, and I think they learned a lot from us too. And so remembering that while we have processes in place, they might not always be the best processes, but when we work together with other agencies, sometimes we can make something that's even better. Our ED team followed the CDC Identify, Isolate, and Inform, which was really exciting for me because I've just spent a lot of time training everybody on this, and it was good to see that some of it has stuck, and that they knew that the black box existed. That was like my biggest win. I just wanted to give her a big hug, and she was like, okay. We deployed the BICU team to the ED. So kind of capitalizing on all of our emergency department nurses that are on the BICU team now and letting them go do their thing in the ED was really cool to just watch Alyssa be in her zone, be in the ED, talk the special ED nurse language with the nurse that was at Silverton was a huge win. Everyone donned and doffed their PPE safely. AMR copied our ensemble, as I mentioned, and they were able to get in that safely and get out of it safely. And then I think lastly, our level 1 colleagues were on site supporting and evaluating the drill. So we had Cassie on site, we had Krista, we had Angie from Nebraska. And I think just remembering that these folks are all here to support all of us, whether or not we're in their region, is just a great reminder. And so I get to be the person who brags about my team and talks about these drills, but there was just so many different people who supported this work. So a huge thank you to those folks for participating, evaluating, telling us all the great things that we did and opportunities for improvement. Okay, I'm gonna pause. Here's Cassie in our beautiful new emergency department room at Silverton. It even has a lot of windows, you guys, and isolation doors. Any questions? You can also ask Alice questions since she's here. She shook her head no at me. It's okay if you don't have questions.
Okay, I don't see any
Okay,
questions
thank
from our
you.
audience. Thank you.
Right. I'm just going to speak very briefly and then turn it over to Nathan. So super excited to hear Mike Hartley earlier talk about the Iowa case. And we've got a good opportunity from our friends and colleagues from Alaska to talk about an incident that they had this past January that involved a small hospital, public health, EMS transport, and all the things that happened. So Nathan, take it away, please.
Thanks, Daryl. My name is Nathan Wormington. I'm the Health Emergency Response Operations Unit Manager with the State of Alaska Department of Health. Really quickly, I'm going to give a timeline overview of all the events that took place, and then we'll turn it over to the panelists to kind of answer some questions, answer lessons learned, and talk a little bit more about the event and kind of what we got out of it. So really quickly, next slide. So these are our panelists. I'll let them introduce themselves as they go through and answer questions. It's been mentioned through this, the importance of collaborative partnerships and meeting people and interacting before the disasters happen. I'm not sure how many of you have had the opportunity to be involved in a disaster emergency or ahead of time, but rarely, if ever, does information come in through a clear, concise, and reputable source. So for the timeline of the events, the transport from this patient, this is initially a suspected HCID patient from South Peninsula to Providence and Anchorage. Overview for this. So timeline, got a phone call or actually a text message on the afternoon of Monday the 13th. It said, hey, are you tracking this patient? And it's not uncommon that we get those types of inquiries of, hey, did you hear about this? And it's like, well, no. What can you tell me? Like, well, do some more research. Like, ask your people, or what can you tell me about this? So a lot of time it's a fact-finding mission, right? So on the 13th, got this text like, hey, are you tracking this? No, let me do some research, start to vet the source of the information. It was from a reputable source, it was from one of our local emergency managers. But it was, hey, what can you tell me about this? It was more that prodding, right? So start doing some research, find out, okay, there's a patient that's in the state where it had begun to spread about a patient with concerning symptoms from a notable country of origin with a plausible incubation timeline and a travel history. So knowing where that patient came from, they're like, wait a minute, signs, symptoms, timeline of this, incubation period, everything else. So on the 13th, the patient presented symptomatic to South Peninsula Hospital. ID was consulted and word had started to spread through the emergency management grapevine. So I'm not in the clinical side of it, but I'm in the healthcare preparedness side of it. We start to hear that word starts to spread on the 13th. So I gave my team a preliminary heads up, was like, hey, there's a patient with some concerning symptoms. There's a possibility they may get transported. We'll let you know what happens. In keeping with that, 4:45 the next morning, we get a phone call on our duty officer phone. So we have a 24/7 duty officer emergency line. It says, hey, things have progressed for a variety of reasons. This patient's going to be transported to Providence. So we activated our DOH Emergency Operations Center, showed up at our building at the Frontier building there in Anchorage and started to have conversations about facilitation of that patient transfer. So one of the things I want to highlight, and I won't take away from the panelists, but communication is key through all of this. Our AAR shook that out as well. Concentric circles of communication. The clinicians were doing a fantastic job communicating amongst themselves on that patient care, what they needed, getting specimens tested, how they were going to get those sent out. Hospital emergency managers were standing up their incident management teams. Our team was stood up to help assist with the patient transfer. We'd reached out to our transport partners and started to get them spun up to figure out who's going to transport that patient. But then the third component of that Venn diagram is the healthcare administrators. They're starting to come in here and, okay, there's a lot of buzz in the clinical side and emergency management side of it. What's this going to cost? How are we going to do this? Where are they coming in? How's this going to affect the facility operations? So communication remains key throughout all of that. So we started that process early in the morning. Got to highlight this again, the importance of the vetting it. As that came in, we got a panicked phone call from a rescue coordination center saying, hey, we just got a call of a confirmed Ebola patient with a request to transfer. In the meantime, in the background, we're all working through with LifeMed of, hey, what do you need? How are we going to facilitate this? Clinicians are talking about what resources they need to get the patient, stabilized and ready for transport. We had to quell that concern of, no, there's not a confirmed Ebola. There's no way that in a 24-hour period we could make that happen. So started that process on the 13th, leading into the middle of the day, the 13th. They making phone calls, talking with LifeMed consistently, were able to successfully get the patient picked up, transported to Providence there in Anchorage. One of the complications through that was conversations around specimen testing, whether they were going to test it on site, whether the specimens were coming with them, they were going to draw new specimens. Able to get the patient successfully transported to Providence, Alaska Medical Center about 4 hours later on the 14th. And then LifeMed had accepted the patient, transported them. We deployed an isopod, fully realizing that's not, first line recommendation. It's not FAA certified for transport, but it was an additional layer of PPE for them to utilize to transport that patient. So with the help of LifeMed Alaska, some just-in-time training, some deployment of some equipment, they were able to successfully get the patient safely transported from South Peninsula to Providence, Alaska Medical Center. Diagnostic workup continued. They continued to do the differential diagnosis into the 15th. Early on in the day, we had a preliminary positive. Finally had a confirmed positive for measles at about 1:30 in the afternoon on the 15th. ID consulted back and forth, decided that with the rollout and everything else was going on, they were able to successfully rule out viral hemorrhagic fever. At the time, the consideration was Crimean Congo fever based on the country of origin and that travel with that patient. So our internal Department of Health EOC actually stood down at the end of that day on the 15th. And then our epidemiology section took over for the contact investigations and follow-up beyond that. So we did brief out at the end of the day, let everybody know what our timeline was for external communications. Had a HON alert initially, again, emphasis on communications. It was discussed at the end of the day that we were going to do a press release for a variety of reasons that didn't shake out till later in AAR. So it was decided to do a health alert, and that went out the following day at about 1 o'clock. So total all this from the time of the text messaging concern to fully, getting the patient transferred, stabilized, and the rollout testing over the course of those 3 days. A lot of moving parts, a lot of conversations, a lot of siloed conversations, a lot of overlap. But we subsequently had the Providence, Alaska AAR with all the partners in this room on the 31st. And then because of the epi investigations for contacts and the incubation periods associated with those measles contacts, we had our internal AAR on the 21st, or I'm sorry, April 21st, because that final contact isolation ended on March 21st. So super fresh, super at the forefront of what we've got going on. One of our biggest takeaways from the emergency management side of it was you can't plan an exercise any better. This is a real life incident that we're able to learn some lessons learned. Fortunately, there was a near miss. It was not VHF, but we were able to work through a lot of those processes and identify some of those weak points. So with that, we'll move into the panel discussion.
If you want to sit here, or I guess you sit there. All right. So ready or not, patients are going to come. So super excited now to really moderate some questions. And if each of the panelists at the start, if you could just give an overview of who you are and the organization you represent, we would appreciate that. We'll also pause after each question to take at least a question virtually as well as from in the room. We should have some time at the end as well to take some additional questions. So really do encourage questions throughout this. All right. So everybody's going to answer this. We'll start with Dr. Twomey first. So what are 2 parts of your organization activation that you thought went well and why?
So can you hear me? Okay. So I think that the 2 parts that went well are first our doc-to-doc communication. So this patient first presented in one of our outpatient clinics. Our provider there was suspicious and worried and called infectious disease in Anchorage, got advice, and then was advised to send the patient up to the ED. So did a doc-to-doc with the ED doc. And so there was good communication, at least internally, on what those next steps were. And then that continued communication with the infectious disease doc in Anchorage. So I think that went really well. And so people on the ground in that situation felt like they had a pretty good handle on what to do and what the plans were and what to do next. The other thing that I think went well is when you're at the end of the road, you are very flexible and adaptable, and you just, guess what, get the job done. And I think that was a good thing and a bad thing. There were a lot of times that people said, okay, we just got to get the job done, and it probably wasn't the right thing to do. But there was also a lot of times that they said, we just got to get the job done, and it was exactly what needed to be done. So
Excellent. And could you also just give us an overview on your role?
Sure.
And
Sure.
brief overview on your facility.
Sure.
Because I think the size of our facility impacts maybe how your answers are going to resonate with some.
Yeah. So I'm the CMO at South Peninsula Hospital. I'm a family medicine doctor and I work half-time in the clinic and half-time administrative. I was in the clinic when this happened and was unaware, blissfully unaware of everything going on. We are a 22-bed critical access hospital. We have 3 isolation rooms in our hospital. We have a 9-bed ED with 1 isolation room, 1 large outpatient family medicine clinic, and then 1 smaller one with a specialty clinic as well. So we're, like I said, we're at the end of the road, and bring a lot of people through and get them taken care of and on to the next place if need be.
Yeah, thank you so much. All right, Lindsay.
Yeah, my name is Lindsay Sprinkle. I'm an infection preventionist at Providence, Alaska Medical Center in Anchorage, Alaska. I took some notes and brought some information about our hospital. We are the state's largest hospital with 401 beds. We have about 1,200 nursing staff and about 850 physician and provider staff. We are a level 2, both pediatric and adult trauma center, and we are the state's only tertiary care center. We do have both, the state's only children's hospital, the state's only level 3 NICU. We do see patients from all over the state. So even though we are based in Anchorage, which has about half of our state's population at about 350,000 residents, we do see patients from all over the state. So it's not unusual for us to have our Life Med Alaska colleagues bringing in patients from, again, from throughout the entire state. We do have comprehensive heart, oncology, wound, dialysis, pain services, and then both inpatient and outpatient behavioral health and rehabilitative services. So pretty comprehensive, covering a lot of different services. Basically, if they can't make the trip to Seattle, they're coming to us if they can't handle that length of flight. So we are currently a level 2 treatment facility. We are kind of pursuing potentially being level, did I say we were level 2? Yeah. We're level 3, pardon me. We are currently trying to pursue level 2, given the fact that we are going to have to probably house a patient for longer than it would take to get them here to Spokane. And it is very expensive to get resources to Alaska when you need them in an emergency. So what went well, the early mobilization, we were really impressed with the way that the different departments in our facility responded and utilized their resources. We had an EVS manager who had gone through some training with us last October, who got his staff completely in the appropriate PPE and ready to clean the hallways after the patient went through. We had a respiratory therapy manager who printed out instructions for the ISTAT and had that in the room before the patient ever arrived. Our ICU had an Ebola binder that has since disappeared and we don't know what was in it, but it was apparently very helpful. I assume it was a leftover from 2014, gave them some very impressive kind of start towards preparation at 4 o'clock in the morning. So certainly there was a lot of early mobilization. And then really the way that our staff showed up, we had volunteer nurses who were offering to come in and provide this patient care and were really dedicated to providing as high quality of patient care with the most dignity and respect for the patient that they possibly could. So really, really proud of our staff.
All right, thank you. And I apologize. I realize I've kind of went out of order. So we're going to go to Jean now with Alaska State Department of Health and give an overview on you and your organization and then kind of your role from this incident as well, please.
Great, thanks. My name is Gene Wiseman. My job, I'm the section chief for Rural Community Health Systems, which is one of the sections in Division of Public Health. Our section houses really 2 critical elements for this response. We have the Office of EMS as well as our Health Emergency Response Operations Group, which runs the Department of Health EOC. So in an event like this, my role would be transition into incident commander and for any of the other public health disaster types events. I've been with the state since COVID. My background is actually in EMS, doing search and rescue medevac across Alaska. And just out of curiosity, who's been to Alaska in this room? Okay, so there's some, but just to put it in perspective, it's big, it's austere, it's Arctic. You get weather. It's in the ring of fire. There's earthquakes, and don't believe what you see on TV about the volcano. We're all going to survive, and it'll be okay. But this happens, right? We have 23 critical access hospitals across the state, and there are no roads, and we rely on medevac. So when things like this happen, I jokingly say to my team, like, "Oh, it's Tuesday." This is just the thing that happens, right? So when this event occurred, from my perspective, what really went well, and what I can't emphasize enough, is knowing communication ahead of time, and who your partners are. We came together off of the kind of the tech stream of like, are you tracking this event, to like actually doing things. And Travis and I had met, like not personally met, but just a couple months before at a training thing in Barrow, Alaska, which is 720 miles north in the Arctic Circle. And I was like, oh, I got his text number. Let me see what LifeMed's doing this. Let me see if they're doing something about this thing, right? So vetting those information, and just to talk about how big we are, I actually got to shake Dr. Twami's hand. I'd never met her physically until today. So we're just a big state, right? But knowing those people ahead of time, knowing the organizations, we were able to, assemble the teams fairly quickly to have the planning sessions virtually done, multiple check-in points, and just, with a phone call, we reached out to Daryl, and the Respect team was there. We had Asper just pending and just sitting in the room as well. And so that came together really, really fast. And I think it was beneficial to get us all on the same page. Healthcare in Alaska, even though the state is so big, we're a small community, and everybody. And the Division of Public Health, which houses, our epidemiology, state labs, and public health nursing, who were all, major players in this event, especially as it turned out to be measles, and they had to do their contact tracing and all of that stuff. They were a part of this from the very beginning, and everybody was able to just stop and pivot and be nimble, to make sure that we kept a couple things in mind, right? We had clear objectives, but given our small communities, we wanted to definitely be person-centered and pay close attention to how we actually communicated, given just the small sample size of our patients that are out there. Like, HIPAA violation right off the bat, right? So you had to be like really cautious about how to do this. And our team is used to working with those small numbers and navigating the communities that way. And so that initial collaboration was just, I can't say enough about that. And to be honest with you, I'm going to finish off this part and just say I'm grateful for the event, because it provided us an opportunity to play for real. You can't replicate in an exercise this. We had an exercise with Providence in Respect just a year earlier with that care pod on site. It's like, oh, this is like a pretty realistic thing, but it was done in multiple phases, and to have that realism, because it was real, apparent, it shook out a lot of bugs, and we learned so much from this. So I'm actually, one of my key takeaways is not only the strong partnership and communication, but that the event actually happened, because we would never have learned the lessons that we learned from this particular event.
Right. Thanks, Gene. All right, Travis, if you could give us an overview of your role and your organization as well, and then answer what went well.
Yeah. My name is Travis Cruz. I'm the Vice President of Clinical Operations and Education with LifeMed Alaska. LifeMed is an air medical and ground transport agency in Alaska, as you might get from the name. We have every day we have 7 aircraft in service 24 hours a day. We've got, we have 7 bases in operation with 10 aircraft and 6 ground ambulances across the state. We're responsible for moving just over 10,000 patients around the state every year. And we've got about 130 to 140 clinicians, kind of depending on I don't know what my turnover rate is at the moment. It's a really neat organization, and it gets to serve a really, a really special and unique part of the country. As far as what went well for us, you've heard this theme repeatedly. Our internal communications actually went incredibly well. The initial call that we got at 4 a.m. actually went to my Kodiak base. And as they're trained to do, they started kind of moving in the direction of doing the transport until they got the piece of information. It's like, hey, this is maybe hemorrhagic fever. At which point they made a very good choice and said, hey, let's stop. Let's get some more information. Let's get some more people involved. And pretty quickly, myself, my medical director, my ground division director, and a lot of other folks were involved, and having a lot of really good internal conversations, and then reaching out to all of our resources across the state. Gene's right. He and I had been up in Barrow teaching a class together a couple weeks prior, and I think I was an hour or two into it and hadn't been smart enough to call him yet. And he texted me and is like, hey, were you guys tracking on this? And I'm like, oh, yeah, we're in the middle of it. And it really went well. What we learned definitely was we needed to have a little bit more formalized, like if this kind of thing comes up, who are the outside people we call early on to make sure that they're tracking and we're coordinating that really well. The other thing that went well from our perspective, and some of this was just frankly kind of dumb luck. Myself and my safety manager both happened to be in Anchorage and in a position to respond to this directly and personally. And we actually had enough of our King Airs, the twin engine turboprop planes, in service right then that I could put a patient on one with that kind of a disease process and then take that plane out of service for 24 hours without significantly impacting the state's reserve of aircraft. So essentially I had an extra plane, and that worked out really well and made the whole process a lot more doable, frankly.
All right, thank you all. And I know we've heard from Lindsay already, so we'll pause for any questions online. None there? Any questions in the room? We do have some more questions, so if it hasn't come to you yet, we can get to it in just a minute. All right, so can you talk about your communication plan? And some of this we may have touched on already, but so, don't necessarily be redundant, but if there's something else that comes to mind, what went well, and what would you recommend to others that do not have the communication plan in place? That do not have the communication plan in place. And we'll go Dr. Twami and then to Gene.
Yeah, so I did mention earlier, I think that our clinical piece, the communication plan internally, and then to Providence, to the infectious disease doctor, went really well. It was very close loop. What I would say moving forward is we did learn a lot about how to extend those circles and include other parts of the facility and then the state, so that we weren't trying to deal with it all on our own. That doctor at 4 a.m. that decided that needed to transport a patient didn't feel like she was doing it all on her own. So that was that is part of the plan moving forward, having that more formalized HICS process and having somebody even at 4 o'clock in the morning feel like they could start that process.
All right, Gene, what comes to your mind?
Yeah, when I think about our communications, whenever you have an event, you have an after action report, right? And that communication is going to hit number 1 or number 2 on the list. And what we did well is we did communicate well. We functioned earlier, we established early, we rounded up all the partners together, but then we fell into our natural pathways, right? And our clinical discussions were happening here, our emergency managers were all talking together here, and the administrators were talking, but that didn't really crossbreed, right? And so there was things that got missed because of that, even though everybody that was communicating together in their clinical realm, they're speaking their language, right? And emergency managers were speaking their language. But there was missed opportunities and missed information when it came to, notifications out, and just kind of having a clear picture, from the aspect of, when, just working through the logistics of labs, which we'll get into on some of the things that didn't do well, or that we're looking at improving. But just, okay, when are positive labs identified? Where, how is that shipping going to happen? And these communications were happening with the clinicians and what have you, but the emergency managers need to maybe make it happen, right? And so there were some gaps there that needed to happen. I would say, as far as, recommending, to others for a communication plan is one, just keep that in mind, right? Of like who needs to be at the table and look again, and have that conversation in plans to bring those right folks to the table, and to find ways to bridge the communication between the known kind of siloed groups, right? Bridging that administration to clinical or emergency management to clinical. Like just look for opportunities to make that meld. And I think that's a really important takeaway. The other is, having pre-established, if you're going to be working with the public, some pre-established messaging, for the different, types of encounters that you may come across in the emergency management world. But it's more than just pre-established, it's also pre-cleared. And that one's a tough one. And so we kind of struggled with that as we had moved through. We were, going to put out, some public media information, right? And then it turned into a HUN. But there's a lot of back of the scenes, and it was really about the clearing of information. And so a takeaway from us was perhaps the state of Alaska wasn't the right people to take the lead because our hands were tied. And so maybe we reach out to the other PIOs and form a JIC within that small group so that your PIOs are talking together as well and say, okay, our hands are tied, you take the lead. And just establish that relationship by having those groups together as well as another group. So that's what I would recommend for that. Thanks.
All right, thank you. And Travis, what communication tips do you have, and what would you recommend others?
First off, if you don't have a plan, start making one. For us, we had an internal plan. We recognized after the fact that we didn't really have a good external plan. And we've modified that to kind of have a booklet now that tells us, hey, for these kinds of things, these are the other parties in the state we should be reaching out to early. One of the other things that really struck me in the midst of all this, it was, I think sometime around 9:30 in the morning or so, I started to get on the plane with my partner to go. And I got a call from Gene saying, hey, we're going to have a stakeholders meeting by Teams at 10 o'clock. I need you in it. And I was like, dude, I'm literally door sealing to leave. And he's like, don't, just wait. And that meeting was hugely important because there was actually a few things surfaced during that meeting. Some additional resources were offered to my team that actually made the entire transport a lot safer. Thank you. And that's the isopod that we utilized, and honestly made the whole thing a lot safer and more comfortable for us. And from that, internally we'd already been doing this thing of so in EMS and in aviation, before you get on the plane and take a flight, you do a risk assessment, and you do that between the medical crew and the pilot. That's just standard operating procedure in the industry. We've now added a step for highly unusual and high-risk operations where that risk assessment now cannot just be done by the crew and the pilot. It has to be done multidisciplinary across the company. The ops team and the clinical team have to be in touch on a meeting with the flight team and the pilot so that we can have that multidisciplinary approach. And I learned that from two places. One, that meeting that Gene called, and two, in the midst of all of this, as we were getting ready to go, there was a period where I said, okay, we've got a plan, we're safe, we're going. And my actual ops director had been having a little side meeting with his team, and he called me and he's like, hey, don't go. Like there are risks that we haven't addressed yet. And he was right. I was in the middle of it with the crew and the pilot. We thought we had it all managed. He'd seen some pieces from the outside that we hadn't yet. And we were able to remediate those risks very quickly. But we recognize that you really do need these things that are very specialized, very high risk. You need those additional voices because everybody in this industry, we want to get it done. And we want to do it safely and effectively, but we want to get it done. Having those additional stakeholders gets the extra voice of like, well, did you think about this? And that's huge. Plan for those people in those communication trees because they will save you.
All right, thank you. And Lindsay, what about from Prov Alaska Medical Center?
Yeah, so I think just to reinforce the internal communication was fairly efficient. We realized pretty quickly that means of communication that we were already comfortable with and that were already established were utilized much more than sort of trying to set up a communication means in the middle of something. So to that extent, I think one of the recommendations that we would like to pass along to this community is make sure that your staff, whoever is going to be a part of incident command, make sure that you've all taken the same training, you have the same knowledge and vocabulary. So if you're talking about a communication liaison, what does that mean? It can be separate to your organization. It doesn't have to fall under anything bigger than that. Although when you are working with state stakeholders and other private companies, it really helps if you have the same language, the same knowledge, you're using the same vocabulary, your acronyms, you're not using them readily, that people aren't understanding what you're talking about. And then within that as well, figuring out if you're going to create new modes of communication, figure out what the parameters are for each of those modes of communication. So if you set up a Teams meeting with XYZ people in your incident command, make sure those people understand this is what this chat is for. And then it helps to kind of disseminate some of those different pieces that some of the information does need to be a little bit siloed because it would just get overwhelming if all of the information was dispersed to everyone. But then being able to say, okay, if this needs to go from incident command to our frontline caregivers, maybe we shouldn't be using the infection prevention Teams chat as a way to disseminate that information, which is what we fell into. We used the resources we had, but trying to figure out who those different people are, what those roles are going to encompass, and what the rules are around those different modes of communication. One of the other things that, and I would like to kind of reinforce what I think Jean had said, was the figuring out not only how you're going to communicate to your internal, like your staff members. People will notice if a containment center is set up in your ICU. But then also who's going to talk to the patient's family and say, you cannot come and you need to stay home and you need to quarantine in place, and who is going to have the time and the patience and the ability to sit and have those conversations with that patient's family who are understandably in great amounts of distress. Especially when they are finding out that their person is now going to be put into a plastic pod and shipped to a different hospital. It's a very, very scary experience. And I think our ICU manager handled it beautifully, but it took him away from the rest of the ICU. So figuring out who's going to manage some of those communication pieces. And then having a transfer of command. So chances are there's a lot of people here who, even though you are a level 3 center, you are going to have to prepare to potentially have a patient overnight. What are you going to do overnight? Who do your staff call if something happens? What if XYZ emergency happens? What are your list of contacts and communication? And making sure that you have your staff prepared for any sort of an event that you can kind of come up with or brainstorm, and that they have the resources they need.
All right, thank you. Seems to be some themes there from all four panelists up here. Any questions from virtual chat? Any questions from the room on communications?
I'm curious, when we're planning for a response like this, we always are careful to who are the key players, the partners that need to be involved in the communication. And I'm a big advocate for just the essentials. I feel like it could get out of control really quick and people all of a sudden want to be involved or feel like they need to know. Did you experience any of that where you had people feeling like they needed to be involved in meetings or in communications that was unnecessary? And if you did, how did you navigate that?
I'll take a stab at that one. Of course, once a response, starts to happen, people, want to do things, right? And they want to be a part. So part of that's managing expectations, in the group, and like, okay, who's the lead of the agency or that right person, and then they can disseminate within the group. I mean, just in our hero team alone, we have multiple members, that are part of health emergency response. Not all of them had an active role in there, but they all wanted to be a part of the conversation, right? And so it's just kind of tempering that a bit. And then some of it is saying no as well. So we had, Nathan had alluded to the Rescue Command Center or Coordination Center, who was notified by another air medical service that there's an Ebola patient, and this air ambulance service was going to independently activate the guard to go get this Ebola patient, right? And it's like, so we had to work with them, like, and there's like, do you want to, they wanted, like, do we need to be a part of this conversation? I'm like, no, we have this in hand. We'll reach out again. And by the way, if you ever get a phone call like that, you should probably call our duty officer's number first. But just kind of tampering those expectations, and being comfortable with saying, we'll reach out to you. If when the time's right to need you, and the future partners or the people that are in addition will come out in those meetings, right? As you're communicating with one another, like, oh, we've identified somebody that is a crucial piece to this. Like Travis was saying, his operations, folks in their shop, like, oh, they're a part of that, and they became a policy. So finding those gaps also, will shake itself out at the end.
Anyone else have anything to add to that? All right, we'll keep moving. So what, in your opinion, as you work through and update your high consequence infectious disease plans, are roadblocks or significant barriers, and do you have any solutions? We'll start with Dr. Tuomi again.
I think one of our biggest ones was labs. We had the patient, we had the samples, but we couldn't get them to the lab to run the tests. And so they ended up being transported with the patient, and it seemed like a delay. It was like a frustration delay for our lab, for our clinical staff. And so I don't have a fix to it. I do know that, we just had no other way to get them transported up. Just with the distance we had, we probably could have driven them and they would have got there faster than the patient did. So just, I think a better plan of that moving forward. And that could have helped just make things much more smooth. So
thank you. Gene, anything from your perspective on that one?
Yeah, it's funny. Dr. Twomey brings up the labs because yes, labs. So, back to, visualizing Alaska, right? I mean, Homer, where the hospital is 250 miles outside of Anchorage. It's mountainous roads, right? So that's where the air decision came in. But, part of the lab fiasco with this, right? It's just the shipment of them. You got a category A, right? And like, do you have the right boxes for that to even get them moved? They moved with the patient, which is probably was the most expeditious way to get them in there. But then, in our current scenario with our public health labs, measles testing is done in the Fairbanks lab and not the Anchorage lab. So now, even if we were to cleave out, as one of the differentials, let's get a measles swab. I'm guessing it's a swab. I'm not a lab person, but a measles test, off to Fairbanks. Okay, well, we could do that. FedEx is not available on the weekends. One thing we learned, and just in these rural communities, and it brings up the question of other critical access hospital areas and hub communities where there is no road. They're stuck by weather. Like, how do you ensure that lab stays testable for the amount of miles it has to travel? When it came to, okay, now the CDC, right, and let's test for, the hemorrhagic fever, or whatever other panels that epidemiology and the docs are deciding to do, right, that has to go to Washington. Well, there's no FedEx, and there's only one FedEx that leaves at 2:00 out of Anchorage every afternoon. Or you have to have your stuff there by 2:00, and it takes off. So there's not multiple options to move these labs. So if you've got a delay from the source patient who's in a critical access hub community that then gets delayed into Anchorage, then that lab sits until the next available plane. which could be 24 hours out before that's allowed to leave. And, again, to put it in perspective, the Anchorage to Seattle leg is 3,000 miles. Or not 3,000, it's 1,400 miles. And that's just a little jaunt, right? And that's like the first step. And now it's got to go 5,000 miles to get to Washington. So just these obstacles that were there. So the lab is working on, our lab is like looked at that and said, okay, how do we replicate, the testing procedures, from Fairbanks so they can do it in Anchorage, right? To maybe mitigate the measles, because everybody is worried about measles right now, as they should be, and like, how do we bolster those testing? So lesson learned out of there. Also, like increasing their just the simpleness of like having category A shipment boxes, right? Like that wasn't thought of. Like, how do you move that lab from the airport or get it to, how are you making that movements without a courier or with a courier? So having those, just those logistics in place, and then it makes me think of like other, takeaways and barriers is, in Alaska, it's not uncommon for a weather front to come in, a blizzard or whatever, or just, we call it the fog monster. I've never been anywhere where it can blow 50 miles an hour and still be foggy. And it'll be that way for days, right? And so here you have a patient that maybe presents into another critical access hospital not connected by the road, and so how do we prepare them to have that patient for 48 hours? Because God said, you're not moving this patient because I gave you bad weather, right? And so it's just like, it's one of those things. And so there's a lot of logistical aspects that came out as significant barriers, as far as what to do. I mean, you look for those avenues, like I was talking about the lab, replicating their protocol into Anchorage. But we're just going to have to continually watch, for how do we improve this shipping thing, right? I don't know if we cracked the category A waste thing. I was so glad to see that lecture earlier because we're like, we don't know how the hell we're doing this. But and they were like, and by the way, state of Alaska, who's paying for this? We're like, not us. So
I thought I heard DOH was, but yeah, everybody else has the Cat A waste issue as well. Travis, what comes to your mind with this question?
Yeah, moving forward for us, it's getting back into having enough people that are trained, ready, and having those plans in place. And I mean, it's the same problems that everybody has with that kind of thing. It costs time and money to put people through training, to get the equipment to train, and then in Alaska to find the experts to help us train. And the good news is like Region 10 exists. The Department of Health exists. We have a lot of Providence and other collaborators in the community who can help at least lend us some of that expertise and occasionally some of that equipment and things so that I can get my teams trained up on a regular cadence. Earlier they were talking about the quarterly training they're doing for the EMS crews here, and like I'm salivating, like that's amazing, guys. And I very much want that for our teams too, because this is, when it's real, it's dangerous, and we've got to be ready for it and be on the top of our game. And the only way you do that is you train. So,
ready or not, patients will come. Lindsay, what comes to your mind with this question?
Labs. I will. I think it's one thing though is if you do work in a facility where you aren't sure where you send various labs, making sure that you kind of have that clarified. So our TB labs are run in Anchorage, our measles are run in Fairbanks. So knowing which of your labs run which of your tests can be really helpful in those moments, just having that list somewhere. I do think, thankfully, one of the physicians at the Department of Health also made the recommendation. I think, correct me if I'm wrong, but I think typically the recommendation is to take all of your labs and send all of them to the CDC. And she said, no, wait a minute. We already missed one flight. We might miss another flight going to CDC. We can send measles now in state and we can get that answer faster. And so we opted to not actually follow kind of the lower 48, what we call lower 48 recommendation of sending all of our labs to CDC. We split off that nasopharyngeal swab and sent that to Fairbanks. And that's the reason that we got that turnaround, I believe, so much faster, which great thinking by her part, because we did not have the PPE and the appropriate means to take care of that patient for another 24 to 48 hours while all of those samples were sent to the CDC. I do think one of the roadblocks that we are hitting internally is overlapping and conflicting documents and processes and policies. Again, I referred to an Ebola binder in the ICU that we didn't know existed until this happened, that we just have to kind of collect all those different pieces and make sure they align. It's something that thankfully we have a lot of motivation within our clinical team and our executive teams right now because they've seen kind of how much we need those services right now, and we need to focus on that. So we're trying to leverage that momentum and be able to help kind of get our policies and processes in order. And then resources. Everybody right now, I think, resources for training, resources for PPE, resources for building out and repairing our containment unit that we've realized some of the snaps have busted. So now our containment unit is partially functional. So, having some of those resources identified, and that is an ongoing process, and part of why we are in the process of pursuing some of that level 2 clearance, just because that will open up some additional funds. So grants, lots of looking for unusual sources of funds.
Okay.
Yeah.
Thank you all for that. What was one key learning objective for your organization from this experience? And again, hopefully something new. But yeah, if you could kind of sum it up in one key learning, what would you say? And we'll start with Dr. Twomey again.
I would just say now we have something that we can drill. So we have a scenario or a thought experiment that we can have and then drill across all the different areas. So our communication is better. We can do it internally, and then we can talk about the what's happened here and how we can then expand it externally.
Yeah, great point. Gene, what comes to your mind with that?
Yeah, we had several takeaways, but I think one of probably the biggest takeaway, right, is just when these events happen, they're rare, right? And so, but to successfully manage that, we have to, we use that thing called incident command system. And this event highlighted the importance, but also the weaknesses that we have in DOH surrounding the incident command system. And because this was a real event, right, it caught the attention, I think, of, those that need that. And so, working with our leadership of like when, that trigger is pulled, that we're opening up an emergency operations center, that from the top down, that gives the ability to, for the players that need to be a part of that, to give them permission to reprioritize their day and make it a new priority, for this given time to manage this event. And I think that was a big lesson learned for us. And I'm really optimistic about how that will feed how we operate in the future.
Okay. Travis, what about you?
Like a lot of folks have said at some of these things today, my organization had undergone a lot of turnover and changes in management and stuff since like 2017 when we first started becoming part of the infectious disease response plan. So for us, the biggest thing is resurrecting and reformalizing that knowledge in the form of like teams that are identified, trained, and then institutionalizing that into LifeMed so that it doesn't just work because the right people are in place. It has to work because the institution is in place. And so we're getting that baked into the cake, and that is for sure our biggest takeaway.
Okay. I know we're grateful that you all are hosting the NETEC EMS training upcoming.
We're real excited.
Lindsay, what comes to mind here for you for Alaska?
I think just kind of highlighting that for us, at least, we had a big realization that all medicine in Alaska is rural medicine. So again, thinking about labs, thinking about PPE, thinking about transporting, we may not be able to follow kind of the typical recommendations. And so really having to come back with all of our community partners and make sure that we are really establishing and formalizing those relationships so that everybody, again, kind of knows what their role is and what their responsibility is, and making sure that we're not leaving our critical access hospitals in a lurch, that we're providing and including some trainings and some resources for them as well, letting them know that they do have the level 10 respect available for consult. I mean, we I don't know how many people of the team we called, but we were on Teams meetings pretty much constantly. Like, is this PPE okay? How should we do this? What do we? So, I mean, definitely knowing your resources, and then practicing and training. It just, you play like you practice. So, doing it with as much kind of real life scenario as we can, and then yeah, being able to really come back to the fact that our Alaskan community is pretty special. We take care of each other, so it's finding those people in your communities that you can have that relationship with as well.
All right, thank you all. So we'll pause as we transition for either virtual questions or questions here. I think some key themes we heard is exercises are great, but real world incidents are far better. You can use those real world incidents to help future trainings as well, and exercises and preparedness. Communications is a challenge. Lab continues to be a challenge. Cat A waste. So these low frequency, high consequence events are tough, but thank you all for sharing your experience. Any questions from the virtual world? Not seeing any. We'll open it up to questions either for this particular questions or really just for the panelists at large.
I just had a quick question, and you may have covered this in the timeline. I just know that there's concern specifically with these of like a possible co-infection. Usually it's malaria and viral hemorrhagic fever. So at what point did you guys de-escalate your like PPE isolation? Was it right after the measles came back positive, or was it after the CDC results came back?
I think I'm probably the best to answer that. We actually, from my understanding, I actually was not present at that moment, but I believe that our infectious disease physicians, I think every infectious disease physician in the state of Alaska was notified and consulted on this, in all honesty. It's a very small community, and I think they all were talking. And then between them, the Department of Health and the physicians at the Alaska Department of Health, and the discussions with the CDC, that was when the recommendation was, and then the ID doc actually went back in and re-examined the patient. The initial, again, from my understanding, the initial cause of concern was that there originally had been, there wasn't as much of a rash present when the patient arrived. And then there was at first some possible blood visualized behind the tympanic membrane or in the inner ear. And so there was concern that with this patient's vomiting and nausea, and we weren't sure if the patient was not vomiting blood because they were vomiting so profusely or if it was VHF. So I think that was a decision that was made with over quite a while of deliberation, that once that infectious disease doctor went back in, reassessed the patient and said, no, I'm not seeing actually any blood behind the tympanic membrane. The patient then was starting to develop a more characteristic measles rash. And so then I think that was when the decision was made to, and at that point, the patient had actually had a rash, but it wasn't a classic measles rash. And so by the time he actually was taken out of the like the HCID PPE, he actually was about 2 hours outside of his measles window. So he went from full PPE to no PPE within about 2 hours. It just was, he didn't even require airborne anymore. So yeah, good question though. But it was a very, it was an ongoing conversation.
I think it was about a couple hours because we were waiting for us to be able to release people from isolation down at in Homer, and people kept calling me, when can we be free? And I'm like, hold on, they haven't decided yet.
Travis, anything from the EMS perspective to the question asked about PPE? I think you guys were kind of wrapped up by that time, but any comments from the experience?
I mean, as far as this goes, not really. As in terms of PPE, I will say, like, we thought that we had a fair amount of PPE on hand, that unfortunately, like, and they were like disaster supply PPE that had all existed prior to COVID, and apparently nobody had really inventoried that super well, and since COVID. And we ended up short a few pieces of what we wanted to have and believed we had. We were very fortunate that both the Department of Health and the sending facility offered us some equipment. We ended up taking up the sending. And I've said this in a lot of these reviews in cases and stuff that we've been talking, but I'll say it here again. Your team did such an incredible job in such a resource poor environment. Like, they were so squared away and so professional. And as we walked in and kind of gave them some very quick briefing on how to use the isopod and stuff, they didn't hesitate, didn't miss a beat. They were awesome.
Thank you. That's really great to hear.
Any other questions from the group? I think there's a lot of kicking to be done on labs, or not labs, but testing maybe more.
That we encountered was they couldn't run standard clinical bedside care testing on equipment because it rendered warranties invalid, or it took too long for them to turn around. And it's unrealistic to have a $4 million piece of equipment sitting there that you use once every 10 years for that specific one-off. So if NETEC or RASPTC can do some kind of advocacy on behalf of, the laboratory equipment manufacturing side of it, I think that helps eliminate some of those barriers to that timeliness of clinical interventions and care.
All right. I think Krista's got a closing.
Yeah, it's a great call out, Nathan. And what I'm just going to comment on that is the NETEC Respect Lab work group that Carrie is a part of, and there's subject matter experts from all the Respect labs that participate in that are advocating for that. Very well known gap for sure. It goes back to that risk assessment, and during peace times, what planning can you do as a level 3 or level 4 facility to know your lab platforms? What can you safely do? Do you have point of care testing capabilities that you could train people to be able to do some element of clinical lab safely without compromising the rest of your operational capabilities for lab? I want to, since lab is the theme of this hour, I just told Carrie the lab's getting lots of love this year. So, but very important comments, and I want to expand upon what you talked about, Lindsay. And I think just knowing what your state public health lab can test for and what it can't test for. And to your point, that your comment about all labs going to the CDC, all VHF specimens would have to go to the CDC for PCR confirmation, but the presumptive testing can happen with a quicker turnaround time, which is just going to give you that much more information. It's just that not every state lab can conduct the same presumptive testing for VHFs. And I think you heard Mike Hartley say that. All the Respect labs can test for Lassa fever, but I think there were only 4 other LRN labs in the country that could test for Lassa fever when that patient presented to Iowa. So that's just an example. But yeah, send your measles swabs or anything else that's, what can your state lab do and what can you get a quicker turnaround time to help with that differential diagnosis? And then I know the state labs in our region work very closely together. And a lot of times Alaska sends things to the Washington DOH lab for a presumptive test turnaround time. And so, anyway, I just wanted to provide a little bit more context to that, but.
Yeah, so pre-planning is super important. And Nathan, I think what I'd say too is NETEC and the Respect Network is working on this. I sometimes think that states that have experiences like this may be just as effective, if not more. Let us help advocate, but please use this example, especially your leadership and with elected leaders and stuff, to know where these gaps are. But yeah, we're 10 years in and it continues to be a theme. And the other thing I think I heard here is so many people, because we just don't see these cases very frequently, are relying on plans and training that they did 10 years ago. And that's not okay. Our healthcare workforce is at risk because of that, as well as the patients that we're supporting. So any other last questions? I know we're right at the top of the hour. Well, to the panelists, Nathan and everyone sitting up here, thank you so much for sharing a bit about your experience. We're really grateful for your time.
So we are going to wrap up the virtual component here. We just have a few slides to talk through some things, and then we'll transition for our in-person attendees to a couple of rotation stations. So first off, I just want to thank our virtual attendees for sticking with us all day. This is our first in-person and virtual symposium. So we will be looking forward to hearing some feedback on how we can improve it. But I know a lot of people have stayed online all day, so we're really grateful for that. Okay, I'm just going to talk through some next steps in quite a few different areas, just to give you a recap on some items. So you've heard about the National Special Pathogen System. Dr. Grind talked about it. So really, what are the next steps for the NSPS? So this funding allocation highlights here is some H5N1 supplemental administrative funding through ASPR, the Administration for Strategic Preparedness and Response. They're disseminating some funds, and some of them to NETEC specifically, to build out the NSPS level 2 facilities. So the application, the work plan, the budget, everything's been submitted to ASPR. And now we're in that kind of waiting game period for it to be brought back and approved and official. And just due to the current climate and a lot of organizational changes at the federal level, there's just been some delays in those processes. So we are continuing to do the work to build out. NETEC is working very hard. There will be an application process with the goal of designating 75 level 2 facilities across the country that will receive a one-time funding allocation based on that big bucket of money there, the second to the last bullet, the 43 million. And so in conjunction with that, many of us that are from our program participate in the NETEC work groups. Adrian from Seattle Children's participates in a pediatric specific work group. And so there's personnel from across the country making up these work groups to address making a resource guide. So when the application process becomes open to facilities, there's a resource guide there to help them address and look at their program to kind of mitigate those gaps they might find to submit an application to be a level 2 facility. It's going to be, and we have shared probably some of you think ad nauseum, information on NSPS, but what we've tried to do is really be transparent, and what we know, we want you to know. And so I have shared that minimum capabilities, the level 2 minimum capabilities that were developed by NETEC and NSPS in a slide deck. Happy to share it again for somebody that wants to look at it. And then also a kind of a funding guide for level 2 facilities based on those minimum capabilities. So that's for those of you that have heard us update on this regularly, there's not a lot new, but the timeline really hasn't changed. They're still saying mid-May to June for all of this to be released. And I think as soon as they get approval for the funding, we'll see something roll out rather quickly. Any questions about that? That's all I'm saying about NSPS today. Okay. Next steps for a support request. So if you are sitting here today and you're like, I was just talking with several people today about category A waste, but if you, anything today that has raised some questions and you're like, well, I'd love to talk to somebody about that, or wow, we'd love to do an exercise, or we'd love to have some help with training, that's why our program is here, and we would love to come alongside you and help. And so if you would like to request support in any way, or just talk about like, we want some support, but we don't know what we want, just reach out to us. So there's a QR code here that you can scan and fill out a form. Or you can just simply email me. My email's there. And really the first thing we usually do is set up a 30-minute meeting just to talk about what are your identified needs and how can we come along and create a plan. And there's quite a few of you in the audience today that we've done that with over the last couple of months. And that's generated, is going to be moving into maybe an on-site visit or an on-site walkthrough, a review of a policy, whatever it need be. Just please know that's why we're here. And I know there's been a lot of questions about lab and concerns about lab, and Carrie in the back is an excellent resource for lab capability. And so she's done quite a few walkthroughs in labs and facilities in our region. And so we can do very focused support or broader support. So please don't hesitate to reach out. All right, some upcoming educational offerings. So a little shout out to the Halle Borealis. Did I say it right? Halle Borealis? Hail Borealis. Daryl? I'm blaming Daryl on that one. Dang it. Conference May this year. We're going to be up there doing a couple of sessions, but I don't know, is your registration closed, Nathan? All right. All right. Excellent. So if you want to attend the Hail Borealis Conference in Anchorage, May 20th through 22nd, registration is still open. And then there's a QR code. Jean has some cards with a QR code if you want to take one of those as well. I think Daryl already talked about the EMS Biosafety Transport course that we're doing the day before that conference on the 19th of May at Anchorage Fire Department. And that's an 8-hour course. And if you are interested in that for Alaska EMS partners, talk to Daryl. We are working with the local chapter of APIC in Alaska to do a frontline facility special pathogens preparedness course in conjunction with their local APIC conference in October. So the date for the course we're going to be doing is October 9th. And I think what you're seeing here is how much a real world event generates engagement and interest. And I think Alaska partners are doing an excellent job of capitalizing on that to provide education, training, and preparedness efforts for this. And then we're working with Idaho Department of Health and Welfare for a high consequence infectious disease planning series. And we're going to do our first virtual seminar with those Idaho partners on June 5th. Happy to advertise and spread the word on any other preparedness efforts that are going on in our quarterly newsletters. So please don't hesitate to share anything with us, and we'd be happy to use our channels to spread the word. Okay, now you've all sat here and waited. I want to get my CEs. Here's your chance. So the next steps for obtaining CEs, you can scan this QR code. You will fill out a very short survey, and then you will have your certificate emailed to you upon completion of the evaluation. And Brooke for our team manages that. So if you have any questions, her email is here. You can email any of us, but we'll all just say, I don't know, I need to ask Brooke. So you might get a quicker response if you reach out directly to Brooke. So I'm going to leave that up for a few moments so everybody can fill that out before we talk about next steps for our in-person attendees. But I'll take this moment to just really thank our whole team. So Diane Waters is our program coordinator and really is the mastermind behind all of the logistics and making all of this happen. And so a huge shout out to Diane for keeping our team all together and getting us to this point. And Daryl and Carrie and Cassie and Brooke and Sarah Did I get everybody? Yeah, Brooke's been managing the Q&A back there for our virtual attendees. And then I just really want to thank all of you for attending and being here and partnering with us as we continue to, continue to bang the drum for preparedness for special pathogens in our region.